Scientific feast promises to be a unique, exciting opportunity for all of us to interact with renowned national and international faculty. It also promises to provide interactive state-of-art practice-changing education for dermatologists. Following last year's tradition and success, cadaveric demonstration of facial anatomy and injection techniques are the mainstay of this conference. Scientific program is exclusively framed. Hallmarks of this conference are renowned speakers, recent techniques, developments, and newer updates in the field of cosmetology. It is a great opportunity for dermatology students, researchers, faculties, and associations. The aesthetic extravaganza would not have been possible without the hard work of Dr. T.A. Rana, who has tirelessly worked along with his team, consisting of Dr. Jyotimay Bharti, Dr. Viral Desai, Dr. Sukhbir Singh, Dr. Pallavi, Dr. Apurva, Dr. Rinki, and Dr. Tanya. I am highly grateful to our esteemed faculty and esteemed VIP faculty who has spared some time to join us. I am grateful to Dr. Denesh Maur sir, Dr. Ganesh Pai, Dr. Kaushal Verma, Dr. Manisha Nijavan, Dr. Vibur and Mandiratta. So without wasting much of your time, let's set up the learning stage to exchange and share views and experiences with the motto, in learning you will teach and in teaching you'll learn. Thank you.
Thank you so much. And now, ladies and gentlemen, we are going to call here on the stage our very senior and expertise in this industry. Ladies and gentlemen, please put your hands together as we invite the mentor, Dr. Denesh Maur here on the stage. Can we have a big round of applause for Dr. Denesh Maur?
And good morning, all. Good morning, Dr. Rana, Dr. Ramanjit, and other people, my friend, Dr. Ganesh Pai. So first of all, I would like to extend my heartfelt appreciation to Dr. Rana, T.A. Rana and Dr. Ramanjit Singh, Jyotirmay, Dr. Sanjeev, and Apurva, and the whole team of Facial Aesthetic Dermatologists Association of India. I remember 2016 when it started, right from the beginning. And your dedication to the field of facial aesthetics and dermatology is truly commendable. Your knowledge, expertise, and self-sufficiency in the field are inspirations to many. I really appreciate the respectful and ethical manner in which you people are practicing your profession, and your commitment to excellence and patient care is evident in everything, whatever you do. Personally also, I would like to express my gratitude for the respect and kindness you have always shown to me. Your warmth and generosity are a testament to the high standards of your association. As you continue to excel in your practice, I urge you to always uphold the highest standard of ethics and integrity, what I can tell you. And remember that honesty and transparency are essential in building trust with your patients. So never compromise your values by cheating or misleading patients for any financial gain or personal benefit. Never provide any false assurance or guarantees that may not be achievable to the patients, that will always leave you in problem. And never prioritize your profits over patient welfare. So your reputation and legacy are built on the trust and satisfaction of your patients. They always prioritize their well-being, safety, and informed consent. So let your expertise shine through, provide accurate diagnosis and realistic treatment outcomes. Offer personalized care and attention to each patient, their unique needs, and stay updated with latest advancement and best practices and in facial aesthetics and dermatology, what we are doing here in this particular event, which is probably one of its own kind in the country, I am witnessing since 2016. So by adhering these principles, you will not only maintain the highest level of professionalism, but also contribute to the advancement of your field of facial aesthetics. We all know the importance of this. And remember, your patient's trust is sacred responsibility of yours, and honor it with integrity, compassion, and excellence. So thank you once again for inviting me over here, and wish you all the best for the successful 8th World FADS Conference. Thank you very much.
Thank you so much, sir. And now I would request to have a few words by Dr. Ganesh Pai. Can we have a big round of applause? I would request Dr. Ganesh Pai to please come up here on the stage and give his views and vision for all the people who are present here and listening to this session.
Much. I think the need of the hour is precisely these kind of conferences where you have a focus on most of the clinical and cosmetic conditions which need the attention of dermatologists. See, when you have an IIDVL kind of meeting where you have thousands of people coming, you don't really learn. What you really do is you integrate with the people. You learn to make new friends. But these are the places where you have 400 or 500 delegates. Now, for instance, this one is highly focused on the face, highly focused on lasers, devices, fillers, injectables, and whatever is new and exciting in this field. So you attract talent. You also get marquee speakers who make your life easier. And one of the best things about such conferences, and I attend a lot of these nowadays, is that you can easily interact with the doyens in dermatology or in cosmetology, which is very difficult because I have often seen in an IIDVL conference, some youngster wants to discuss a problem with me, some cosmetic problem, and the moment I start talking with him, no less than 20 people will meet me and say, when did you come, when are you going? These are the standard questions, so it's very distracting. In this kind of a conference, during the lunch breaks, tea breaks, or even otherwise, you can get hold of a mentor. You see, create a mentor. See, all this life, you have been having a coach. When you did your MBBS, you had a coach. When you did your PG, you had a coach. That's a fixed agenda. Ye padho, this is the chapter, these are the questions, these are the cases. What a mentor, and you're charged a fee, and it's a closed agenda. Mentor is what you catch on to. If you're a youngster today, this is your chance to interact with Professor Denesh Maur. Get hold of him because he can't escape, as you were just saying. He's here. You can't go anywhere for 2 days. Ask him about real life situations. Ask me what is to be done, what is best, which machines work well, how do you set up a center, how do you roll out the cosmetology setup, how would you manage the finance? What mistakes? Don't ask them what are the good things you did. Ask them what are the mistakes they made, because learning about their mistakes will make sure that you don't make the same mistakes. See, we have something called experience on our side, which you youngsters don't. Ask all those things, and you get to have a mentor. So a mentor is someone who will say, you know, day after tomorrow you have a problem, you just call up Professor Dinesh Maur and say, sir, मेरे क्लिनिक में ऐसा ऐसा प्रॉब्लम हो गया, मेरे पेशेंट को ये हो गया. You call Ramandeep and say, sir, I want to know what to do with this kind of a laser. They are accessible because they have become your mentors. A mentor is for life. He is a guiding light for you. The agenda is open. There's no closed agenda. And there are no fees. But a lot of youngsters have a fear. They tell me, sir, how do you go and talk to such people? They're so senior, they're so big. Believe me, they're children at heart. They were youngsters once, and they love imparting their knowledge to youngsters. So in this kind of a situation where they're relaxed, where they're not in their city busy seeing millions of patients, where there's no other disturbance. Get hold of them during the breaks, talk to them, and find out the best way forward in your career. And I think that is what makes these kind of conferences successful. You first have top-class speakers giving you very vital inputs on cosmetology and lasers. And then you can talk to the same people during the breaks and find out what works best for you. So with this, I thank you very much. Welcome to FADS. Welcome to an exciting couple of days. We are all going to learn here, young, old, middle-aged, all of us. Thank you very much.
Thank you so much, sir. And I would request you to please stay back. Meanwhile, I would request our chairperson to please join us here on the stage for the facial rejuvenation. For this, I would like to invite Dr. Ramanjeet Singh, Dr. Mir Shahnawaz, and Dr. Sanjeev Gulati. Can we have a big round of applause for all the chairperson who are joining us here on the stage? And our chairperson will be the ones who will be introducing our speaker, none other than Dr. Ganesh Pai. Though he does not require an introduction, but yet our chairperson will introduce.
So, good morning, everyone. Welcome to the first session on facial rejuvenation. And now we are inviting a very, very eminent speaker who needs no introduction, Dr. Ganesh Pai. And sir is, of course, based in Mangalore. He was HOD, KMC, Mangalore, and he's the doyen of dermatology. And his topic is relevance of clinical dermatology in aesthetic practice, bridging the gap. Over to you, sir.
Thank you very much for this introduction. And I think this is the big bugbear in our career today. 3 years we work hard, we become hardcore dermatologists, but we are actually caterpillars then. We suddenly become metamorphized into cosmetologists. 3 years of dermatology training, then 3 months of cosmetology training, and then we don't know whether we are dermatologists or cosmetologists. And I think this is where the importance lies. So how do I move the slide, please? This one? Right. So the relevance of clinical dermatology in aesthetic practice, bridging the gap. I always tell this, after 30 years of 35 years of teaching, and Dr. Dharmendra sitting there will agree with what I'm saying. He's come from Nepal, one of my colleagues now, and I postgraduate earlier. Now what's happened was just 2 weeks back, I was in Mahabalipuram, delivering another oration there, and Dr. Avitas John was chairing there, one of my students. And now tomorrow, Dr. Dharmendra will be chairing. So it shows that I have become a dinosaur, and maybe the last dinosaur remaining, because dinosaurs are getting extinct. So that's it. So the relevance of clinical dermatology, see the evolution of science. We will not be aware of changes in science as they will occur over a period of time. Okay. It will be the story of the young farmer who proudly displays an axe saying, "This is my grandfather's axe. My father replaced the handle, I replaced the blade." Effectively, it's totally new axe, but he doesn't realize it. So this is a lifestyle dermatology now, it's our Trojan horse. You need years of training as a clinical dermatologist, and then look what happens. Lasers require months, fillers require weeks, and Botox and peels require days. So one of the biggest problems when you read these textbooks from the Western world is that it's all work on type 1, 2, and 3 skin. And here we are handling type 4, 5, and 6 skin. So essentially, when you have Asians, we have a problem of hyperpigmentation. And that takes months to go in difficult cases. And then you have erythema, which happens in white, which takes weeks to go. And so what are the problems with pigmented skin? Erythema is hard to see. You look at the book, they say, look for erythema, look for erythema. How do you look for erythema in type 5 and 6 skin? But you can get an edema. Before you get an erythema, you're likely to see an edema. So there are various tools. Tomorrow I have a master class, which is I think 12:30 to 1, which I will lay out every possible device that I have used, which is probably every device, and I'll show you the results, both good and bad, because it's important at this stage of our life to show you not merely the what is good and what works well, but what doesn't work and the mistakes we made. So remember, the eyelids and neck are most difficult to work on because there's hardly any subcutaneous tissue. You can destroy the muscle very easily and cause long-term scarring. This is something you must clearly take a picture of and remember. When you're working on the face with any device, just look at the thickness of the upper eyelid, 25 μm. Lower eyelid, 40 μm. But look at the cheeks, 125, 120, upper lip, 115, which means you are at greatest risk when you're working with your device on the upper eyelid or the lower eyelid because there's hardly any subcutaneous tissue underneath. So please remember that. When you work on the cheeks, you're relatively safer than when you work elsewhere. And you get a whole lot of complications. I will not go into this. And I'll go beyond this too. And look at this. See, this is cosmetic. See, the moment you have a look at this is cosmetic dermatology for you. And in this cosmetic dermatology, you're going to see a Sturge-Weber. You're going to see a nevus. But then, if this is, you're being a cosmetologist. But then, from cosmetology, if you are a clinician, what should you be looking for? This. Look at this. The 8 C's of the Sturge-Weber syndrome. So there's a cavernous sinus enlargement, congested veins, cerebral atrophy, calvarial thickening, cortical tram tract calcification, choroid plexus enlargement, hemangioma in the eye, and cutaneous port wine stain. See, we only see this last one, the cutaneous port wine stain, and we think of which device to apply to the hemangioma. But the fact remains that they must be assessed by a neurologist. They must have a radiological opinion because you don't know what else you're looking at. So we can use PDLs and IPLs and a whole lot of other conditions where you have vascular network. And then you come to tattoos. Look at these tattoos. I'm not bringing all the tattoos, but remember, a lot of these they add a lot of beauty, but they also add a lot of contact dermatitis. Patients get allergies to these dyes, especially the yellow and the mercuric sulfide. So, but look at this latest thing which is happening. They have found this out, that tattoos may increase blood cancer risk by 21% because tattoo ink contains known carcinogens which are transported to the body and end up in the lymph nodes. So researchers from the Lund University in Sweden use national registries to identify cases of lymphoma. And look at this. They found a 21% increased risk of lymphoma in people who have tattoos compared to those who are not. This is very recent, just a month and a half ago. So now researchers are looking at whether tattoos can raise the risk of different cancers. And this has just been published in eClinical Medicine. And the author is Christel Nielsen. You look at that. I was actually terrified. In one of the meetings in Barcelona, there was a video in which a Taiwanese dermatologist, cosmetologist, showed a video. Even as you're tattooing, the ink is flowing into the lymph nodes and getting accumulated. You start tattooing the forearm and he's tracking the particles going into the axillary lymph nodes. So it's not as simple as it's a cutaneous thing on the skin. Right, so these are the... Now, TRTs are very important, thermal relaxation times to prevent burns. So you must know physics. It's not enough to just know about cosmetology. And also to never promise that the tattoo will go fully. So evolving concepts in dermatology. Now, these are the lifestyle problems now. People want to take isotretinoin for a long... You put a person on isotretinoin, he doesn't give it up. He goes on taking it for weeks and months together. And, You have minoxidil with, and you have for androgenetic alopecia. You have sildenafil, testosterone, semaglutides for obesity. So lifestyle abuse is something which is happening in a lot of drugs which you give. Please remember that. People never get off finasteride. You start finasteride, they go on taking it, and they don't see you for months together. So evolving trends in hair reduction are happening from single wavelength to triple wavelength, and you can see the benefits. This is something which I think is very important for a whole lot of you. Which wavelength to choose, which wavelengths are better, and how are you going to use single versus triple? I think the best benefit now is the triple wavelength, because the most important thing for a patient is, doctor, will this cause burns? Triple wavelengths don't. And doctor, is this painful? Which triple wavelengths are not painful? But these are the ones you have. So what is the future development of contouring for face and body? And this is how we know it works. Probably are going to be shown these things. The whole idea is when you lower the temperature to this 4 to 6 degrees centigrade, you destroy the fat cells. The RF action, how RF works, went from you have contact, penetration, emission, withdrawal, coagulation, and then ultimately almost all of these equipments do neocollagenosis, formation of new collagen. So all of these do the same thing. So the electromagnetic RF energy stimulates microsparks with RF electrodes. And as you can see, the microchannels are produced of this kind of a diameter. And these are now useful for drug delivery. Please remember that. So photoacoustic, a lot of people are telling me, sir, what's the difference? So when you use a pico Q-switch laser, or you are using a photoacoustic technology, which means very high peak power with very short pulse duration. It's easy to explain to a beginner saying, look, it's like a kabaddi. What happens if a guy takes his own time to touch the opponent, gets caught, generates heat? That is nano. What happens if a guy makes a lightning raid, touches and runs back in no time? That's pico. So remember that. So there is no photothermal, there's a photoacoustic. So this is the difference between photothermolysis and photoacoustic, which the difference between the Q-switched nano and a picosecond. You can have a wrong use of lasers. In the beginning of my career, this is one of the mistakes I made. The patient had a scarring when I used the energies for this. It should have, with the nano, I should have probably sent it to a plastic surgeon and got it done. Familial pigment line should not be attempted, as results are poor. You can see that. This is a patient who needs a lifestyle modification. He needs a dietitian and maybe a psychoanalyst also, more than seeing a dermatologist. So please remember, don't go and put your lasers on these kind of patients. Keep them away from these banquets. It's very important. If you find anybody here who's qualifying for this kind of skin here, make sure he doesn't eat too much at the banquet tonight. So this is one of the problems. Endocrinal assessment is very important. See, the cosmetic part is removing the hair. You have the machine, you do it. But this is the showroom. Where is the go down? The go down is in the ovary. It is continuously producing more and more hormones. So you must have an endocrinal assessment. If it's severe, please rule out malignancies. If it's moderate, PCOS. So there you are. And overuse of lasers in type 5C. Laser toning is not as simple, especially when you use carbon. It can cause damage in type 5 skin and type 6 skin. And you can even do, if you use it sensibly, I use the fractional CO2. My go-to machine is the Ultrapulse from Lumenis, and I could make this a pretty good nose. In fact, he needed another session, but he was happy enough with this. Managing fresh tattoos. See, this is one of the things we are always taught nowadays academically. If a patient comes with a fresh tattoo, don't do it for the first 3 or 4 months. Am I right? They say, don't touch it. It's no longer true. So I'll tell you what happened. This girl was studying in medical college in Mangalore, Father Muller's, and on the occasion of her parents' 25th wedding anniversary, she had this tattoo done in Mangalore. And she proudly sent it to her parents at 6 p.m. 9 p.m., the mother and father boarded the bus from Bangalore to Mangalore, came, blasted the daughter, brought her to my clinic and said, "Sir, please get rid of this. This is a stupid, foolish daughter of ours." And I then saw what's most important is you can't use a nano, but you can use a pico. To remove this, you can use a pico because pico Q-switch lasers have a very short pulse duration, like the kabaddi player I told you. They get in and get out in no time. Therefore, they do not generate heat. And because that is the denominator, it's very low, you don't need too much of energy. See, power is equal to energy divided by pulse width. So you get a lot of power by using very low amount of energy, simply because the denominator is so quick. And therefore, you can use a pico and do this, but you cannot use a nano. So there you are. So I did this for what it was worth. Right. So is it only cosmetology is that we're missing? I mean, I have a feeling now that if you don't really have a good training, you'll go and use a CO2 laser to remove a hystoid lepromatous nodule. What prevents you? If somebody is not well trained, you see a nodule of lepromatous leprosy, use CO2, blow it off. You see, that's possible. Therefore, I always say, educate yourselves, and we are more likely to miss basal cell carcinomas. So here, dermoscopy can be done. Please remember that. Dysplastic nevi are very important. So it's a problem when you have a dysplastic nevus, is a nevus which is fairly large, and it's greater than 5 millimeters, flatness, and has 2 of 3 features. So if you see a mole, if a patient comes to you with a mole which is having variable pigmentation, irregular outline, and an indistinct border, send it to a plastic surgeon, have it excised in toto, and then, no. See, this is one patient. When you do this, this is what you see, irregular outline and a variation in color. Suspect a melanoma developing in this. So it's no longer cosmetic. Please don't say, here's my chance to use my Q-switch laser. I'm going to use my nano. I'm going to use my pico. I'm going to blow it off with CO2. Damn it, you may be looking at a melanoma developing here. So please remember, please leave some cases for the plastic surgeons. Please don't do everything yourselves. So there you are. You can see the difference. And so then the histopathology was done. In fact, it was so controversial that they said it was melanoma-free from Dubai. So then I was in Dubai giving a lecture, and then I was asked, I said, you do a revisit of that. Then they sent it to another center in UK, and it turned out to be an early melanoma. So sometimes even histopath needs to be revisited. So then you are having melanoma jab trials now. The first vaccine for melanoma is coming. Remember, it's exciting. And the risks are lesser now than before, and the survival rates are higher, and the follow-up data shows good results. Now, clinical dermatology versus cosmetic dermatology. Look, this is a basal cell carcinoma. You can see the rolled raised edge here. Surely not a candidate for your lasers. So please remember, have a heightened awareness. And if you hold a magnifying lens close to this in early lesions, so this is a late lesion, in early lesions, you will see a leash of blood vessels very close to the border of the basal cell carcinoma. So if you see a leash of blood vessels, remember that is your most suspicious reason for having it excised. There you are. I mean, these are, can't do much about these. People who cut themselves up. No laser in the world works. Remember, when patients come with these kind of scars, they just need counseling. They don't need lasers. This is a woman who tried to hang herself and came to her father brought her to my clinic next day. See, the noose slipped. See what, this is not cosmetic, all right? Please remember, don't put this under cosmetic. This lady was under big stress. Actually, I need to make a police complaint in these cases. But I did not. I had a brain block. I felt bad for that girl. I never saw her later, but she was to be married off to somebody whom she didn't want to marry because she had her own sweetheart. And she tried this the previous night. The noose slipped, and with the slipping of the noose, this is what she got, you see. And therefore, please remember, these are things, the moment somebody comes with this, don't do your RBM laser or your fractional CO2 to improve that. She needs counseling, and the family needs counseling. This is something which came to my clinic about 4 months back. She was having this gangrene of the little toe. Now, ordinarily, if you miss this, you may miss a lot. I had her sent to, today I don't have time. One of the biggest thing is when you go through a list of 150 patients in a day, it's impossible to give 20 minutes of time to a patient who needs a systemic workup. But something was wrong because she had malaise, she had fever, she had loss of weight, she has diffuse hair loss, and this is what she was having. And this turned out to be a patient of systemic lupus erythematosus. So you see, doctors had been treating her for 1 year for various ulcers on the toes and fingers without realizing what this was. This was SLE. So please have a heightened awareness of connective tissue disease or a malignancy whenever you have these kind of cases. So this is a patient who had visited my clinic many years ago for a nevus. I had told her I had to have it excised. 10 years or 15 years later, she came with a squamous cell carcinoma on that. And a 26-year-old came to my clinic just about 4 months back with a squamous cell carcinoma on his inner cheek. And so no age is too young. So if somebody comes to you and shows you this, he used to eat, this tobacco. You can see the staining on the teeth because of that. He was from Gulf. He had come for a short vacation. The biopsy showed that it was a squamous cell carcinoma. So please, don't say, oh, this is leukoplakia and give some creams. This is a raised rolled edge. You can see a squamous cell carcinoma. And remember one thing now, post-corona or maybe post-corona vaccination, the number of malignancies has shot up. Lung cancers, breast cancers, ovarian cancers, pancreatic cancers I see this happening all the time. And you please ask your oncologist and your doctor friends, they are showing a spurt of this. Between 40 and 50, you're seeing malignancies as well as angioplasties, cardiac blocks. We don't know whether it's the vaccine or the malignancy or the corona itself, but this has been the problem now. So there you are, the biopsy showed squamous cell carcinoma here. So there you are. So I always say this, you come with nothing and fight for everything, and in the end you leave everything and go with nothing, which means we often have seen there's hardly any cooperation between a lot of dermatologists. Everybody thinks for A to succeed, B must fail. No, A and B can both succeed. If you put your brains, your hands together, if you put your efforts together, you can make sure that we grow together as a society. FADS will become a bigger and more powerful institution by being cooperative and solving our problems together, okay? So you leave everything and then go with nothing. So please remember that. Thank you very much.
Thank you so much, sir. Sir, I would request you to please stay back, and I would request our speakers, our chairpersons, to please felicitate our speaker. So can we have a big round of applause as we take this as an opportunity to felicitate our speaker for sharing such an insightful information with all of us. So here we are presenting So with this, ladies and gentlemen, I would request you all to please give a big round of applause for Mr. Ganesh Pai. So thank you so much. And now, ladies and gentlemen, we are going to invite here on the stage Dr. Pradanya Manvatkar. Can we have a big round of applause as we have our next speaker here.
Hello, everyone. I like to see smiling faces, everyone's smiling. So I'm Dr. Pradnya, and I'm here. I want to, at the outset, thank the organizing committee for actually allowing me to present a very different topic in an aesthetic conference. And I jumped at the offer because I think what Dr. Pai sir has done for me is he has set the stage. You know, some cases you just do not do. You know, masterly inactivity is what you need to understand and then go ahead, right? So, let's move on. I call myself a confused dermatologist, basically. Because have you been in that place where you have a patient in front of you and she's complaining of, or he's complaining of a tear trough, or maybe a jowl, or maybe, acne, and somewhere deep down you feel, oh, I should not treat this patient. I'm like, nahi yaar, nahi haath lagana chahiye. I'm going to lose my night's sleep with this patient, right? And then you have those patients also who come and ask you, Doc, mujhe kyun hua? Why did I get this? And then you're like, I don't know, So when I'm ancient, okay, I'm quite old. So when I passed out in 2008, the commonest answer I used to give to my eczema patients was, I don't know, it's idiopathic. If it was atopic, of course, I'd kind of give a background to it. But usually psoriasis, I don't know, stress maybe was my answer. So the confusion led to a lot of me trying to understand what it is. And today's topic is from BDDE to BDD. All right? Do you think that some of the patients that come to you might actually have a BDD issue? I think so. So so what do you do about it? Do you tell the patient to go to a psychologist? No? If you told the patient go to a psychologist, would they go to a psychologist? Correct. And that's where today's topic becomes important. It's not only identifying who not to treat, or rather identifying what if the patient could be a prospective BDD or BDD in the making also. Please understand that BDDs may not come to you because they are OCD patients. They might go to the psychiatrist. But a prospective BDD might. And that's where, Emodermatology comes into the picture. If you see that 12% of patients in our dermatology setting who actually are suffering from BDD. Correct? So please keep that number in mind. Now, why the semantics? Why am I calling it emodermatology? Because it is not psychodermatology. All right? It has nothing to do with diagnosis, primary, secondary cases of psychodermatology. We are not treating our patients with risperidone. I remember we used to have these delusions of parasitosis come to our OPD when I was a resident. And risperidone ka kitna dose dena? I used to call up the psychiatrist resident and but no, we're not doing that. That's a psychiatry patient. That is not our patient. Trichotillomania. If the scalp is more than 20% lost, it's a psychiatry patient. You cannot treat them because then you need multiple types of antipsychotic medications which need to be titrated over a period of time. I can't just give one risperidone and expect her to be hunky-dory the next day. Correct? So that is why this is not psychodermatology. It deals with the emotional reason to why the disease occurred in the first place. Okay? And then it also deals with the emotional dysfunction that happens with the disease later. Therefore, I like to call it emodermatology and not psychodermatology. All right? Are you excited to know what this is? I see everyone. I see. Good. Okay, so principles of emodermatology. To educate the patient on how chronic stress matters, how stress can lead to a change in your hormonal levels, which are cortisol, adrenaline, can change the way your keratinocytes function, your melanocytes function. There is release of corticotropin releasing hormone in your keratinocytes, from your keratinocytes. Why? Because your epidermis is an extension of your ectoderm and your brain is too. So whatever receptors commonly are present in your neurons and around your neurons are also present in your dermis. So whatever changes at the cortisol, cortisol and adrenaline levels is happening is also happening at your skin level. So your keratinocytes are making CRH. Your keratinocytes are actually making CRH, which stimulates alpha MSH, which causes your dermal pigmentation. So now do you have an answer to your patient's query? Why did I get this? It was your stress, all right? Then to able to identify the triggers, which is what I said, the neuroimmunocutaneous endocrine system exists. There are a number of studies, if you go and check the internet, how they're related. And therefore, what it helps me do with my patient is to tell them that although I'm here to handhold you, I'm here to guide you, I need your help too. I can't expect you to go back home, cry, and then expect a glowing skin with my erbium glass the next day. It's not going to happen. Correct? So that's what NICE is about, right? These triggers can be thoughts, or even like my mother-in-law yelled at me today. Or it could be, why was the patient so rude with me? Or it could be, oh my God, aaj galla nahi hua. Sorry, I'm using really crude words because that's what I use. We are daily wage workers, I keep saying that. I have one year, shit. So these are all small things. And we think that stress is catastrophic. We think COVID was stress. No, it's post-COVID. It's the post-COVID effects that was stressful. It's the daily, acha, socks yahan kyun rakha hai? Or towel. Who have husband and wives who put the towels on the bed? And yeah, there she goes. Okay, so that's stressful. And that is what I'm saying. That stress is the stress that needs to be dealt with. It's not catastrophic stress. As a matter of fact, catastrophic stress we deal better. Because we know that this catastrophe is not going to happen in our lifetime. At least. We are 99% sure. So we know कि इसके बाद नहीं करने वाला. I don't need to do this. Vis-a-vis the towel, I have to do this every single morning. Correct? So to guide the patients in their journey to sustainable treatment outcomes. Okay, I am here to help you. I want to treat you. I want you to look the best version of yourself, or I want to clear your acne. But I also want you to get to ensure that it is sustainable. Right? Our resident and our professors used to joke, my seniors, once your patient, always your patient. I used to find that amusing. I said, हाँ यार, patients, I will never, there'll be never lack of patients for me. Because once a psoriasis patient, always a psoriasis patient. Today, as I look back at the joke, I do feel bad because that should not be our approach. Our approach should be, how do I make this patient independent of me? And believe you me, it's gratifying equally in revenue-wise as well, because you do end up getting these patients over a period of time, but they're far more emotionally aware that they are in control. That's what Emodermatology helps me do. So I don't have to use secukinumab. I don't. Okay, so create a state of responsible skincare in our patient pool, because obviously you can't go and apply steroids. They come to you. You can't. Do you have patients who come to you and say, PRP every week karte hain? I just was speaking to a doctor and he said, I have a patient, he loved PRP. वो बोला कि every week करेंगे. I'm like, oh my God. So do you think that this could be a prospective BDD? Yes. Yeah, so right. So here and where these principles of Emodermatology help me guide that patient. Give him the PRP session, but not to his detriment. Basically, it's creating a state of thinking awareness. Ki by whatever you're thinking may not be the truth. So if you have one acne, doesn't mean your full face is your face is full of acne, right? So the basic of Emodermatology basically stems from applying a cognitive behavioral therapy called rational emotive behavioral therapy. This therapy was evolved by Dr. Albert Ellis. He was a psychologist in New York. And I learned REBT through a personal crisis. And how many of you have taken therapy here? No one second therapy here? Oh my God. Okay, fine. I have, okay. It's a brave thing to do, by the way, so don't judge me. So I took it for my own personal crisis. Excuse me, please. Therefore, I realized it was so helpful. It's made my life bearable. Actually, it's made my life wonderful. I started applying REBT to my patients in 2018. And the principle is called the ABC theory. Okay, it's a very simple principle. It's like mathematics to my patients. Sometimes if I feel that the patient is unable to understand what I'm saying, I just write down that A plus B is equal to C, and I ask the patient to work on it. Now, for every activating event, which could be anything, it could be a past thought, it could be a present circumstance, you add a belief to it, which leads to a consequence, is what the ABC theory says. So what do we know? We know that my activating event led me to stress. My mother-in-law screaming led me to stress. My towel led me to stress. My patients not coming in led me to stress, right? And that stress led to what? Anger, anxiety, depression, sadness, fear. And then that led to physical changes like the acne that I had before my exam. Or, someone commented on how old I looked and this is not nice. I am very, very disappointed and sad. I'm actually fearful that I'm going to age faster than I thought I was, right? And behavioral. Usually the behavioral, the OCDs, which I said the frank BDDs will go to a psychiatrist, will not come to you. But that's not the case. A is not equal to C. It is not because you screamed at me, I got angry. It is because what I thought about you when you screamed at me, that made me angry. I say this and I give this analogy to a lot of my patients. I'm going to give it to you today. You see a beggar on the street, all of you have. What happens to you? Can anyone answer? Like just one person answer. You feel bad? You want to answer? Answer, Dr. Indu, please. Bolo na, kya hota hai? Perfect. Okay. Now, Dr. Indu, you're my patient. Okay, so if you see your best friend in the same situation, now what happens? Begging, what happens? Would you say you should work? No, right? What changed? Begging did not lead to this reaction. What did I say? What happens to you when you see a beggar? You thought when you see a beggar, you feel they should work. Right? But when that beggar became your best friend, you've not seen for 5 years, you changed. What changed? Begging udhar hi raha na. Agar aisa hota to sabhi beggars meko affect karte hain. My perception about that, okay, so I got a friend now. So I had this entire perception of what friendship should be. How did my friend do this? What can I do as a friend? Oh my God, this is crazy. This is how life is unfair. How society is stupid. Your thoughts came into me. And how many automatic negative thoughts do you think in a day? Do you know? Around 60,000. And you don't even know them. Right? So that's what this is. So it's not the trigger, it's not the activating event that caused the consequence, it's the belief that you hold about it. That I must never have acne is my belief. So when I get an acne, oh my God, this is ridiculous. How can I get acne? Correct? So that's what I was talking about, for every adverse effect, you have a belief which is an illogical thought usually, which will lead to a consequence. And these are the common Bs that I find. And this might be helpful to you because this actually helps me dispute the patient. Now what's disputation? Have you ever had patients where you told that, you need an erbium glass laser? But the patient says, no, doc, do you really think I need an erbium glass? Maybe I'll do a PRP. What do? You say, हाँ ठीक है चल PRP करते हैं. No, what do? You say, no, listen to me. I understand what you think, but I believe erbium glass and blah, blah, blah. You go on your rant, right? So that's disputation. You're actually disputing your patients. You're saying, you know what you think. Hold on to your horses. This is what I think, and I think we should go ahead with this. And you try to help the patient understand. That's disputation. So once I know my Bs, one acne is full of acne. I have never had acne in my life. What happens if I get acne? How did I get the acne now? क्यों भाई तुम आदमी नहीं हो क्या? तुम इंसान नहीं हो क्या? I mean, like you're a person, right? I have never ever had any allergic reaction. I said there's always a first, episode. I've never had. Doesn't mean you'll never have. Yeah, if I must be a bad person if okay, this is called the just world hypothesis. And a lot of our patients come with this, please remember. The just world hypothesis says that if something bad is happening to me, I must be bad.
Dr. Pradnya, we request you to wind up soon.
Yes.
Yeah, we exceeded your time.
So, words like I must, I should, I will, I am, forever, ever, always are words that you should catch when the patient is speaking with you. And I believe you can talk to each other today and you'll be able to identify these beliefs. So how to apply? Like I said, disputation was the key. Disputing irrational beliefs could look something like this. Is getting a clear skin help you get a promotion? Does clear skin ensure that you have talent? Does getting bad skin mean that whatever you have achieved in the past becomes zero? And then would you describe a person's worth based on their skin? If you won't do that for other patients, I won't do it for me. Right? Goals of Emodermatology is, like I said, make the patient put the patient in a state of thinking awareness and make the patient independent of all those thoughts that don't really help us achieve goals for them, which is sustainable treatment outcomes. Thank you.
Thank you so much.
Hello. Thank you, Dr. Pradnya, for such a wonderful presentation. And now I would like to call upon another speaker. The felicitation, yeah.
I would request our chairperson to please felicitate our speaker. And next, for the tropical and chemical peel facial regeneration, I would like to invite here on the stage Dr. Tanya Yadav. And meanwhile, as we felicitate our last speaker, can we have a big round of applause for So before we call Dr. Tanya Yadav here, I would request our chairperson to please introduce Dr. Tanya Yadav.
Dr. Tanya, she is a fellow consultant, Medanta, the Medcity Gurgaon. She has an area of expertise including PRP and mesotherapy, pigmentary disorders, including vitiligo and melasma, and a number of publications, correlation of serum Ig antibodies to Helicobacter pylori in chronic skin disorders, correlation of neutrophil lymphocyte ratio and platelet lymphocyte ratio with severity of psoriasis. And let you start. Ma'am, may I have the privilege of requesting you to start the wonderful presentation. And the topic is topical and chemical peel facial rejuvenation. Thank you.
Is it audible? This one is, okay. Good morning, everyone. I'm Dr. Tanya Yadav, and it's a pleasure to be here today and talk about topicals and chemical peel and facial rejuvenation. We'll start off. Facial rejuvenation using non-invasive methods like topical and peels have gained popularity due to its lower risk and shorter recovery. They offer minimal downtime, provide subtle, natural enhancement, favoring the modern aesthetic trends. Also, the young adults seek preventive treatment to delay the signs of aging, making this the treatment of choice. Let's start with the hero in the category, that is retinoids. They regulate apoptosis, differentiation, and proliferation of the cells. They decrease transepidermal water loss, protects collagen degradation, and inhibit metalloproteinases activity. In a study, wrinkle reduction was observed as early as 4 weeks with 0.25% high-strength tretinoin, as you can see in the images. An increase in epidermal thickness over control was 46.28%, with increase in collagen 1 in 3 gene expression, up to 1.3-fold and 1.43-fold over the controls after 12 weeks of treatment. Another high-strength 1% tretinoin solution application twice weekly showed compaction of stratum corneum and increased epidermal thickness. Next up is vitamin C, a potent antioxidant which prevents the reduction of CD1A expressing Langerhans cells upon UV radiation, and it reduces UVB-induced erythema by 52% and apoptotic sunburn cell formation by 40 to 60%. It also has an anti-aging effect and activates pro-collagen mRNA to regulate type 1 and type 3 collagen synthesis. It increases the gene expression of collagen and synthesis of tissue inhibitor of MMP1. In this case, 10% topical vitamin C application for 12 weeks showed significant reduction in 4 to 8 score and improvement in wrinkling with reduced pigmentation. Now, growth factors are gaining a lot of attention these days, and they're derived from human, animal, and plant cells with recombinant bacteria and yeast. After gaining entry in the keratinocyte, they stimulate the keratinocyte to stimulate fibroblasts and produce more growth factor, which forms a loop. And they also stimulate myofibroblasts and the protomyofibroblasts and myofibroblasts, right? And the non-recombinant human growth factors like that from neonatal skin shows 32% new collagen formation in the grain zone, as you can see in the image, after 60 days of treatment. And it shows 27% epidermal thickening. Another derived from the neonatal human dermal fibroblasts stimulate higher expression of type 3 and type 5 collagen, which is very similar to the fetal skin. The other one, which is derived from fetal fibroblast cells, after 6 months of which histopathology shows increased fibroblast density and epidermal thickness, and the electron microscopy shows new collagen formation. As you can see in the image, there is marked reduction in periorbital, fine line, and wrinkles. But these growth factors are large hydrophilic molecules, offering less penetration in topical preparations. Although they can reach the dermis via hair follicles and sweat glands, also in the aging skin, as we have compromised barrier function, they permit better penetration. Now the very famous peptides, they are involved in modulation of cell proliferation, cell migration, inflammation, angiogenesis, melanogenesis, and regulation and synthesis of the proteins. There are basic 5 categories. Signal peptides would modulate dermal extracellular matrix, collagen, elastin, and keratinocytes. The structural peptide would improve the hydration and elasticity of the skin. The carrier peptide, which stimulates the synthesis of collagen and elastin. The neurotransmitter inhibitor peptides, which act like Botox because of snare inhibition. And the enzyme inhibitory peptide, which increases the hyaluronan synthase gene. Peptides are highly selective, have multiple points of contact with their target, and they results in decreased side effects and toxicity. They also consist of a natural L-amino acid, which are non-immunogenic and are broken down over time to yield the other amino acids. But they're tested in vitro using silicon replicas of the skin, have higher molecular weight, and have low lipophilicity and are bounded by other ingredients, which prevents the release and absorption. The most famous peptide of all is human copper binding peptide, that is the GHK copper complex, which is naturally occurring tripeptide in the human plasma and is also released from tissue after injury. It is a strong antioxidant and anti-inflammatory, has potent anti-cancer effect, activates acute and chronic wound healing, increased synthesis of dermatan sulfate and chondroitin sulfate, all of which are important for the rejuvenation part. It stimulates synthesis of collagen, selected glycosaminoglycans, and with LED stimulation, the cell viability has increased 12.5-fold with production of basic fibroblast growth factors up to 230% and collagen synthesis up to 70%. It also stimulates epidermal basal cell, markedly increasing the integrins and P63 expression, which all favors the increased stem cell activity. As you can see in the image, 4 weeks of daily application has resulted in marked reduction of fine lines and wrinkles around the periorbital and the nasolabial fold as well. The very famous snail mucin, as you can see in the Instagrams and all the other social media, these are highly glycosylated proteins secreted by animals for adhesion, hydration, and lubrication process. In the study, mucins from the Helix aspersa, which is the garden snail, has helped with skin regeneration in acute radiodermatitis, improved erythema, decreased transepidermal water loss, and increases skin elasticity with reduced wrinkle and skin roughness, as you can see in the image. Over the right, we have the difference in healing process with the application of SSF, that is the snail secretion fluid, in a laboratory mice. The Mason trichome staining shows increased collagen deposition in the SSF-treated group compared to the controls. Next up is galactomyces ferment filtrate. It's, I would say, this is a very new thing, and it's trademarked as Pitera, and it was founded when the sake brewers had very youthful appearance in the hand, but they had wrinkled face. So they found that galactomyces ferment filtrate is the reason, as they decrease the TNF-alpha, interleukin-13, and UVB-induced reactive oxygen species in the keratinocyte. They upregulate tight junction molecules, increase production of anti-inflammatory cytokines like IL-37. They also activate AHR translocates into the nucleus from the cytoplasm, where it upregulates the expression of filaggrin, as you can see in the image. There it is in cytoplasm, and now the AHR are in the nucleus where it can upregulate. When we talk about rejuvenation, I think chemical peels have had the longest standing and the widespread acceptance, and they act by controlled keratocoagulation and denaturation of the proteins, which releases the pro-inflammatory cytokines and chemokines. They activate the normal healing signal cascade with which stimulates the new dermal collagen and elastin with the regeneration of new keratinocytes. Talking about the superficial peels like AHA, BHA, Jessner's, and TCA, they have a very mild role in skin rejuvenation and regeneration, but after multiple application, they can penetrate to a deeper level. In the median depth, we have glycolic 70%, TCA 35%, the augmented TCA peels, and Obagi TCA peel. Now, the Obagi TCA peel is nothing but they have a non-anionic dye which renders the color blue to make it more even on the application part, and they have saponin and glycerin to make a very homogeneous 30% TCA with the water and oil emulsion to penetrate on a slower level and irritate the skin less. In the deeper peels, we have Bacon-Gordon formula and Hetter's all-around use formula, which uses 33% phenol with 0.35% croton oil. The newer peels like modified Jessner peels and VI peel using TCA, salicylic acid, retinoid, phenol, and citric acid with PHA and the LHAs, they have very mild role in the rejuvenation although. We can apply the peels in a sequential manner like salicylic acid after TCA, which enhances the penetration without increasing the concentration and delivering better result with a lesser risk. The segmental peels offer better result with using the different peeling agents in the same session with the different cosmetic units. And the punctated peels uses 88% phenol in the punctated manner in a static wrinkle areas to promote the healing with the lesser side effects. In the image shown, first case required 3 sessions of 35% TCA peel to reduce the wrinkles and melasma as well, while the second case needed only 2 sessions of Baker-Gordon formula to reduce fine line and open pores. These cases required 2 sessions of 70% glycolic acid to address the fine lines and the open pores. Over the past decade, I think there have been increased interest in products found in the nature because of their perceived safety. Numerous plants and drugs of natural origin support the normal repair system of the skin and therefore show great therapeutic potential in the skin regeneration. They act by moisturizing and barrier repair like the Centella asiatica, aloe vera polysaccharide, alginate, Avena sativa, and as an antioxidant like astaxanthin, caffeine extract, tea polyphenol, ginkgo flavonoids. They also have sunscreen-like effect like that of arbutin, licorice, anthocyanidins, and are anti-inflammatory like that, like the curcumin, proanthocyanidins, and mushroom extract. Yes. Only 2 more slides, sir. Botanicals and plant-based extracts are being added in peels due to their natural anti-inflammatory, antioxidant, and healing properties. These newer chemical peels provide added milder enzymatic exfoliation and reduces the downtime and side effects as well. One such popular peel is the pumpkin peel, which uses 10% glycolic and lactic acid with 1.5% bilberry extract, which is a natural antioxidant and anti-inflammatory, and the pumpkin enzyme, which are rich in vitamin A, C, and E. The other enzyme peels very well known in the market are papaya enzyme peel having papain, pineapple enzyme peel having bromelain, apple enzyme peel having malic acid from the apples, others like cranberry enzyme peel, cucumber enzyme peel, and pumpkin and yam peel. That's it. Thank you, everyone.
Thank you, Dr. Tanya, for a very, very informative talk. Please be on the stage for presentation.
And I would request our chairperson to please felicitate our speaker, that was Dr. Tanya. Ladies and gentlemen, can we have a big round of applause for Dr. Tanya as we felicitate? Thank you so much. And now I would request our chairperson to please introduce our next speaker, which is none other than Dr. Ashmita Kapoor. Can we have a big round of applause for Dr. Ashmita Kapoor?
Welcome, Dr. Asmita. Dr. Asmita would be speaking on newer modalities in periorbital rejuvenation. May I have a slide, please?
Yes, sir.
Introduction slide, please. And Dr. Asmita is working, she's practicing in Gurgaon. She's a very, very talented young dermatologist. So over to you, Dr. Asmita,
Thank you,
please.
sir. So I think we're facing some technical difficulties. Just 2 seconds. Good morning, everyone. I'll be presenting today on modalities in periorbital rejuvenation. So before going into the modalities, first a little bit about the anatomy of the region. So the periorbital region is a very unique anatomically. It is composed of bones, muscles, the eyebrows, the eyelids, as well as some ligaments, tendons, and fasciae, and the fat compartment. So all of these play a very important role in the pathologies in the periorbital region. The bones and muscles, the bony anatomy of the brow and forehead, it is defined by the supraorbital rims and the frontal bone of the skull. The muscles are divided into the elevators and the depressors. And as we all know, there is only one elevator of the brows, which is the frontalis, and the depressors, which are corrugators, the orbital portion of orbicularis oculi, the depressor supraciliae, and the procerus. The eyebrows, they are made up of a head, body, and tail. The length can vary, the horizontal length can vary from 5 to 5.5 centimeters and a width of about 1.3 to 1.5 centimeters. The highest peak of the brow is at the junction of the middle and the lateral third. In females, the brow is more arched and above the orbital rim, whereas in men, it is more flatter and almost over the orbital rim. The eyelids, the structure consists of 3 layers. First is the thin skin layer, which is the outer layer overlying the tarsus and the preseptal areas. So this skin is probably the thinnest in the whole body, measuring about 0.2 millimeters. And there is no subcutaneous fat here. The middle layer includes the orbital septum and the orbicularis oculi muscle, and then the tarsal plate and the palpebral conjunctiva, they provide a frictionless surface, which are known as the inner layers. These are the muscles. As you can see, the frontalis muscle is a fan-shaped muscle which is covering the forehead, then which is the only elevator, and then coming to all the others, the depressors, which is the orbicularis oculi, is the circumferential muscle, then in the glabellar region, the depressor, the procerus, and the corrugators. The second image you can see that shows how the fat compartments, they are descending down as we age. So what happens is the orbital retaining ligament that becomes weaker as we age, and the roof, that is the retroorbital fat pad, that descends down. Coming to the important ligaments and fascia here, the Whitnell ligament is a suspensory ligament. As you can see over the top left corner, that is it prevents excessive posterior movement of the levator muscle. Then the capsulopalpebral fascia, which is the lower layer analog of the levator aponeurosis, that arises from the rectus, inferior rectus, and it surrounds the inferior oblique muscle, forming a Lockwood suspensory ligament. And then the most important one that we should be aware of is the orbital retaining ligament that spans from the periosteum of the inferior orbital rim and is attached to the fascia on the undersurface of the orbicularis. The fat pockets, we are all aware, there are 3 main fat pads in the periorbital area, the pre-aponeurotic, the preseptal, and the Gallia fat pad or the retroorbicularis fat pad. So as periorbital aging sets in, the preseptal and the roof fat that descends and may lose volume. And with this gravitational descent, there is unsupported brow that causes brow ptosis and the appearance of a heavy lid. This is the blood supply and the nerve supply. So blood supply is usually by the anastomosis of the internal and the external carotid branches, and the nerve supply through the branches of the facial nerve. So I won't be going into too many details. That will be covered with fillers. So what happens with aging of the periorbital region, and how you should be looking at brow lid as a continuum. So there is deepening of the periocular, the glabellar and the forehead wrinkles or rhytids. There is descent of the brows. There is hollowing of the temples and dermatochalasis of the upper and lower lids, which is nothing but the overhanging skin over the lids. Then fat pseudoherniation of the lids. Involutional ptosis sets in. There is deepening of the superior sulcus as well as photoaging and hyperpigmentation. How do you differentiate hyperpigmentation, periocular? So these are the four main types that we see: the pigmented, vascular, the structural, and the mixed. The pigmented has a brown hue, whereas vascular is more blue and purple, and structural usually is a skin-colored shadow. And mixed ones, there can be 2 or 3 of these appearances together. So we can do a simple stretch test in clinical practice, which is the manual stretching of the lower eyelid skin. If it retains the pigment, then it is a pigmented type of hyperpigmentation. If there is an increase in the violaceous or blue discoloration, that means it's vascular, and the structural improves or resolves with stretching. So here is where your fillers mostly come into play. For the structural, which is mostly volume loss. So what are we aiming for here with periorbital rejuvenation? It is to restore volume, minimize and soften rhytids, and improve the skin texture and coloration. Now we will come to the modalities of treatment. Firstly, with the topicals, the market is flooded with a number of eye creams. So what to choose? Right. I've just made a comprehensive list of most common ingredients that are found in these eye creams. So retinoids are the main component with the mechanism of actions of these. So retinoids increase the collagen content and they normalize the elastic tissue organization and also stimulate the fibroblasts. So they have a very good role in the improvement of rhytids. Then vitamin C is a powerful antioxidant and is also a cofactor for collagen synthesis. Vitamin E, that acts as a scavenger for free radicals. Caffeine is a very important ingredient again. It is antioxidant, anti-inflammatory, and it increases the skin elasticity. Also enhances the barrier function by decreasing the transepidermal water loss. Then coming to niacinamide, it inhibits interleukin-1, PARP1 and TNF-alpha, so has a powerful antioxidant effect and also improves elasticity. Hyaluronic acid, as we know, a great way to maintain moisture, so it maintains the water reserve, the turgor, and also gaps within the extracellular matrix. Peptides are coming up in a lot of new eye creams that I'll cover later also, a little bit about them, but there are certain trademarked peptide complexes now available in eye creams like Iceril and Haloxyl. So ceramides again are very essential for forming a waterproof barrier and they also help in repair. As we know, the eyelid skin is very thin, so it needs moisture retaining and that will improve the overall texture as well as the rhytids. So ceramides come into play there. So this was an article that is a review of efficacy of all popular eye creams. So I've just made a cheat sheet out of that. So what is the concern and what ingredients to use where? So for hyperpigmentation, niacinamide, caffeine, vitamin E and C are very effective. For puffiness, caffeine and to some extent even vitamin K. Puffiness, caffeine is great, but you need other modalities of treatment as well. Sometimes might require surgery. So, but this can definitely improve. For wrinkles, caffeine, retinol, vitamin C, peptides, very effective here, hyaluronic acid and niacinamide. Now coming to some chemical peels. So the glycolic acid, TCA, lactic acid, and ferulic acid. These are the ones that were previously available and conventionally being used. So now there are certain combination peels also available in the market, like the RG peel, which has 20% arginine, 20% lactic acid, urea, aloe vera, and allantoin. This can be used in the periorbital area for rejuvenation. Then mesopeel, periocular, and mesopeel icon. These all have varying constituents, like mesopeel periocular contains azelaic acid and salicylic acid and lactic acid. And mesopeel icon has glycolic, citric, phytic, lactobionic acids, which are the PHAs now, and tartaric acid. All of these help with hyperpigmentation as well as with rhytids. The next modality that we see now is microneedling. That has also come up a lot in the few years. With or without PRP, you can do this. So microneedling uses multiple intradermal small punctures, and it facilitates the absorption of certain topical serums or medications that you can use. And as a standalone treatment also, it increases the collagen production, helps with skin tightening, and also it is reported by the patients. There is subjective improvement in skin quality. So endpoint in the periocular area would be erythema with or without pinpoint bleeding, but usually erythema is enough. You don't have to wait for any bleeding in the periocular area. PRP, it can be combined. You can inject as well as it can be applied topically with or without with the microneedling sections. If you're just injecting the PRP, intradermal injections of the autologous PRP is a very good way for rejuvenating the periorbital area. So indications being for wrinkles, for hyperpigmentation, as well as photoaging. This is one of the review articles that is a comprehensive, exhaustive research of how PRP was used for rejuvenating the periorbital area. Then coming to MNRF, or the microneedling fractional radiofrequency. So these are new devices. They have fractional radiofrequency as well as a feedback loop, intelligent feedback loop that gives you basically gives you an idea of the temperature and the depth you are reaching. So it helps tighten the skin by causing the contraction. This system that penetrates the skin with microneedles, and it delivers the thermal energy into the dermis, up to the dermis. And this physical stimulation induces a wound healing cascade of the dermal collagen, contributing to regeneration, remodeling, and finally leading to skin tightening, which improves your skin laxity and leads to fewer rhytids. Now coming to lasers, traditionally Q-switched lasers have been used for periorbital hyperpigmentation, but ablative lasers like erbium YAG and CO2, they can also be used in more advanced indications, like there is periorbital rhytids as well as for texture correction, tightening. Erbium YAG lasers, they carry lower risk of scarring and have a relatively quicker recovery time, but there is chances of dermal bleed because they don't have hemostatic effects. And CO2 lasers, they reach a greater depth, so it makes it optimal for skin tightening, but there is also chance of overcorrection, which can lead to ectropion. So that's where we need to be careful. And basically, fractional lasers have, since they have come into the market, they have improved. Adverse effect potential has significantly reduced because of that. So this picture shows the results after 3 sessions of a Photona smooth eye. So this is basically a laser that uses erbium YAG as well as combines ND-YAG, long pulse ND-YAG, but in this they have a smooth mode which uses non-ablative erbium YAG. So this is their trademark novel non-ablate with smooth mode that without bleeding and with precisely controlled temperature deposition, you have achieved a significant tightening of the periorbital area, as well as a reduction in the wrinkles, as well as under eye bags or the puffiness. Coming to microfocus ultrasound now. So HIFU was approved by the FDA in 2009 for use in brow lifting. But off-labelly, it is also being used as periorbital rejuvenation also, specifically in concerns with the descent of the fat pockets. So there have been reports that a single ultrasound treatment of the forehead can produce a brow height elevation of up to 1.7 to 1.9 millimeters. And here they use a transducer which is of 3 mm or maybe even 2 mm and a 7 megahertz frequency. This technique combines direct ultrasound visualization of the targeted tissue with non-invasive delivery of the focused ultrasound energy and precise microcoagulation zones. These are the zones that are very important. Here, the precise microcoagulation zones, they reach up to the deep dermis to the SMAS layer. These are created and they cause gradual tightening of the skin through collagen contraction and remodeling. And as I told, besides brow lifting, it can also be, HIFU is also used for periorbital rhytids also, crow's feet, which is off-label use. And here you usually use a 2 mm transducer. Some things that need to be taken care of while using HIFU around the eyes, the contact of the probe. It should not lose contact and it should be at a 90 degrees angle because the skin here is very thin. If you damage the epidermis here, it can cause blistering. So that is one thing that has to be taken care of.
Please wind up your talk,
Sir.
Dr. Smita. Getting late.
2 minutes. Threads. Dermal threads are being used for facial rejuvenation, but in the periorbital area, under the lids, we usually use monothreads, that is the PDO threads. They because of their collagen remodeling properties, they can have a tightening effect and a rejuvenation effect. And they can be used standalone or with other treatment modalities. Then skin boosters. Now, the phrase skin booster that has come up, it was initially used for hyaluronic acid filler products which are non-cross-linked. So they can also be used to improve the skin aging and diminish wrinkles. And as they are non-cross-linked, they don't have much of volumizing effects, but they diffuse well into the peripheral tissues, causing fewer irregularities. So there are, retain the moisture and there is less adverse effects, less swelling. They're tolerated better, basically. And exosomes are again a type of skin boosters only that have also come up. I think there a lot of people have covered in their talks. Now they are microphysicals, we all know. But injecting into the periorbital area is again a little tricky. It's being said that you should use it topically along with microneedling here. And then coming to neuromodulators, we all have been using Botox for a long while. There is a new Botox in the market, Daxxify. This is the daxibotulinum toxin, which was approved by FDA in September 2022. So this has a longer effect than Botox. Botox wears off in 3 to 4 months, as we see in the periocular. This usually lasts for about 6 months on an average and up to 9 months. And fillers, again, all of us have been using. This is old, I think. I don't need to cover it as a newer modality, but just for the sake of completion, and I don't think we have a better option than this. So these are the HA injectables. First, they were approved in 2003. Restylane was approved for facial contour deformities. And usually, I would just few key points for tear trough injection. A low viscosity HA product is to be, it can safely be used to correct the tear trough deformity. High viscosity, they are not preferred in the tear trough. Then always use supraperiosteal depot injections and be lateral to the infraorbital foramen, be careful of that. And use gentle massage and avoid overcorrection here. So this was one of the Herman's grading of tear trough and the injection points basically in the tear trough deformity, but this would be covered again. So I think, and some take-home points with this: diagnose the condition correctly and do not shoot in the dark. Respect the brow lid continuum and be mindful of anatomical landmarks to prevent any untoward effects while using injectables. And multi-pronged approach with combining treatment modalities is the way forward for periorbital rejuvenation. So, thank you.
Thank you, Dr. Asmita Kapoor, for a wonderful talk.
Okay, I would request Dr. Ashmita to please stay back, and meanwhile, I would also. And now I would request Dr. Dinesh Mathur to please come up here on the stage. Dr. Dinesh Mathur. Okay, he is not present here. So it's time that we are also going to felicitate our chairperson who are present here. And ladies and gentlemen, meanwhile, as we call our felicitator here on the stage, I want to know from all of you who are present here, how much information that you are getting today, like you think it is meaningful for you and you are gaining knowledge. Can I get hands from you all? Come on. All the informative informations, isn't it? Yes or no? So can we have a big round of applause for all the speakers which we had since morning? Okay, so I would. So Dr. Dinesh Mathur is already here. Please come up on the stage, Dr. Dinesh Mathur. And I would request you, sir, to please felicitate all our chairperson. And I would also request a very senior dermatologist, Dr. H.S. Girgila. He is also present here on the stage. And now it's time that we are going to felicitate our very first chairperson, Dr. Ramanjeet Singh. So I would request everyone to please put your hands together as we are felicitating our first chairperson, Dr. Ramanjeet Singh, who is also the president. And next, we are here with our next chairperson, Dr. Sanjeev Gulati, and Dr. Mir Shehnawaz. Can we have a big round of applause? Thank you so much, everyone. Thank you so much. Now, ladies and gentlemen, moving forward towards the panel discussion. And for this, I would like to invite our first moderator of the day. Ladies and gentlemen, please put your hands together for Dr. Apurva Singh. Can we have a big round of applause as our very first moderator is getting up here on the stage. Next, we have the name of the panelist. So we have Dr. Deepthi Saxena. Can we have a big round of applause for all the panelists who will be joining here? Dr. Deepthi Saxena, Dr. Ganesh Pai, Dr. Indu Bilani, Dr. Pradanya Manvatkar, Dr. Ashmita Kapoor. Can we have a big round of applause for all the panelists who are present here? Over to Dr. Apurva Singh.
Good morning, everyone. I would like to start with today's first panel discussion, Topical and EBDs for facial rejuvenation. So we have our esteemed panelists on our stage. Let's start with the first question that I have today. Chemical peels have been considered age-old first line for facial rejuvenation till date. But recently, many of you have shifted to EBDs or lasers as first line. What are your thoughts on that? Mike.
I think topicals have been used, but EBDs have a better role now because they're coming up in a good way now because you can do much more with them than just topical therapies. That is there. You can reach a better depth. You can treat various concerns at once with them, and yes, that's.
Dr. Ganesh Pai, sir, your thoughts on that?
It's true because when you have peel, you're addressing the epidermis primarily. If you're going below the epidermis, you're likely to be causing a burn. So the entire problem in cosmetology is between 1.5 to 3 millimeters under the epidermis, under the skin. So to address that, you need to either fractionally ablate it with the CO2, or use an erbium, or use an MNRF, or use a HIFU, so that that segment which is causing the scarring, the sagging, or whatever is addressed. So peels are superficial, devices are deeper. But just like you need, every time you take a dosa, you need chutney. Whenever you do a device, you also need a peel. It's a combination of what you do with the device and with the peel that gives you the best results.
Your thoughts?
Yeah, I totally agree with sir. It's always the combination which works best. And if it's only superficial, then peels will only work. But if it's chronic and constitutional, we have to do a combined procedure.
Indu ma'am?
Yeah, so yeah, we have shifted, but it also depends sometimes on the budgets and sometimes whether on a particular problem also if a patient has, then we have to target it accordingly, doing more of peels or more of...
Same pinch. Everything's being covered. So yeah, I'd prefer EBDs over peels.
Okay, moving on to next. When a patient comes to you, like we discussed with Dr. Pradnya has already discussed, with patient coming with very high demands, how do you customize and personalize the patient treatment plan as per patient requirements and budgeting?
It's a very tough question. I'll say no to the patient. See, it depends on what is high demanding. We have to first find out if the patient has realistic expectations or not. It's just not about making a plan. Because no matter how good a plan it is, and if the patient is not going to be receptive or have realistic expectations, that plan is going to become a big flop. So the outcome of treating a patient is not devising a plan. The outcome of treating a patient is understanding where the patient is coming from, with what expectations he or she is coming from, and then discussing with the patient what can be achieved. That's how I would go with it, rather than just ye karo and ye karo and ye karo.
Yeah, true. So first consultation should be longer. You should understand the patient's needs and you can give them your suggestions. You can give them like a detailed list of whatever is suitable for them and then they can choose according to their budgets.
Okay. Yeah, first of all, what matters is the expectation of the patient, and that should be clarified whether it's true, it's up to the mark, or he or she is expecting a lot. We have to counsel them accordingly, and then we have to plan the treatment according to the time frame they are having. If somebody is having a marriage or something like they have only 3 months or 2 months, then accordingly we have to mix the combination of procedures, or we can go individually as well.
But it's a simple rule of thumb. If a patient asks 100 questions, there is an invisible lawyer behind that patient. Be careful. If the patient asks no questions, that's equally bad. You never know what trouble you'll get into. I classically remember about 20 years back, I did, a young lady wanted to look good. And she asked me what you can do best. I said, all right, we'll do an erbium laser peel, which is a pretty superficial peel. But it takes about 3 days for it to improve. And at the end of it, she says, tomorrow is my wedding. So there you are. I didn't ask any questions. She didn't offer any answers. So if somebody shuts up and says nothing, or somebody asks you too many questions, that's a bad patient for you to have, all right? Somebody in between those 0 questions and 100 questions, consider them for your cosmetology procedures.
I totally agree here with sir that if somebody is asked, I think you should take some time, answer their questions, but if they have too many questions or they're confused about what procedure they want to go for, I think you should know where to say no and also spend some time with them, come up with a plan according to their budget also. That also plays a lot of role in today's world.
Yeah, I think about the most important thing in cosmetology is that if a patient smells money in your clinic, if the patient gets a feeling that you're not there to give a proper service and charge an appropriate fee, but you're out to make money, that's when the trouble begins. Because the sum total of your reputation is what people speak behind your back. And so therefore I've seen a lot of successful cosmetology centers going down the hill over a period of few years because patients think, "Arey, wo to paise bana raha hai." There's a difference between making money and earning money. So please remember that. Advice from somebody who is 70 plus.
Okay. You want to add something? Moving on to next. As for periorbital rejuvenation, these days most of you are done with fillers and you're moving to something new and next. So as per your views, what's next in periorbital rejuvenation? EBDs or something else? What do you prefer these days for periorbital rejuvenation?
I usually, if fillers are not the first choice, then I'll go with mesotherapy or skin boosters, what you call it.
Okay.
I think we've had a lot of bad outcomes previously when we were left, right, injecting fillers. So nowadays people are coming with a lot of eye bags after 2-3 years due to an old filler over there. So, we've been taught gradually that we have to first address the other areas, the temple, the cheeks, before moving on to the under eye area. So yes, we have shifted our points of injections maybe. Not totally done, I would say, but yeah, we have reduced the amount of fillers and we are trying out the new therapies, the PDRN, PDNs. Of course, they also maybe have their drawbacks, like I've had cases of swelling also with the PDRN I tried. So we really need to try more. Like skin boosters also we've added to the treatments, and of course the old chemical peels and all are continuing.
So for me, periorbital melanosis, if that's what we're talking about, has a lot to do with lifestyle. So unless I know that the patient and I are on the same page regarding the choices that the patient needs to make regarding lifestyle, I know that my procedures really very well. Okay, now when it comes to eye bags, I think it's a surgical case, to be very honest. But when it comes to tear troughs, of course, I would like to use a bioremodeler. That would be one of my choices. And peels. But honestly speaking, it's all about lifestyle for me, for periorbital melanosis. And nothing can beat a good night's sleep, nothing can beat good nutrition and exercise. And we've seen drastic changes when the body fat indices go down, where you see the acanthotic features of your periorbital melanosis go down. And that creates a big change.
It depends on the amount of sagging that you see in the lower eyelid. I mean, the older patients will have more sagging. So if there is sagging, then you have a combination of MNRF and along with skin boosters, or you can even use a PRP. Reasonably good. But if the sagging is too much, then they need a plastic surgery. They go through the lower eyelid and then tighten it up. The problem is with CO2, MNRFs are much safer. The problem with the fractional CO2 or an erbium is the PIH. The post-inflammatory hyperpigmentation can be a big mess. Because remember, that's one tissue you don't have, and the skin is very thin. As I said, it's just about, 40 microns. And there's nothing underneath that. You hardly see any fat, you hardly see any muscle. So everything shows through. And you have what's known as the Tyndall effect also, when you can see a lot of pigment. Besides, there's another thing. is that the eye bag which looks bad at 7 in the morning looks pretty good by 5 in the evening. So generally patients tend to talk about, yeah, honestly, sans the makeup and early in the morning, the eye bags look much bigger to these women. And so if you photograph them in the morning before the procedure and photograph them in the evening after the procedure, they think, thing has worked. But the essence of cosmetology, as I see it among a lot of very fickle patients, and you spoke about those kind of patients, is ultimate cosmetology is that patient comes back saying, Doc, I've improved a lot, but you know that the patient has not improved at all, and you don't want to argue with the patient because the patient says, "Main bahut achhi ho gayi hu." You know nothing much has happened. So cosmetology is something which is in the hawa mein hai. It's up in mid-air. It doesn't have its feet firmly on the ground. It's all a question of, anticipation, and it's all for us to say, what is this patient going to say? And patients feeling, yes, I'm feeling much better, because there's a psychological element to it. So I think you're a damn good cosmetologist if the patient thinks she is much better than you think she has become.
Yes, I think I've covered most of what we use in periorbital rejuvenation in my talk also. And yes, everything else that everybody else has said is correct. You should choose where to do what procedure, and fillers, most people are moving towards skin boosters now, and even PRP combined with microneedling I think works very well in this area.
But seriously, is one thing you need to do. A lot of these patients are hypothyroid. So please, assess their thyroid function tests, and you will find a surprisingly large number of women, and especially women with eye bags, puffiness, who are actually having chronic hypothyroidism. So please look into that. And hypothyroidism is very prevalent now. A lot of women coming to the clinic, when you test their TSH is 9, 10, 15, 20, whatever they are. So please do that, because at the end of every cosmetic procedure, there's also a medical reason for that. So as I was talking in my first talk, cosmetology vis-a-vis clinical dermatology, look at hemoglobin levels, look at ferritin levels, look at your thyroxine levels. All of these are equally important.
Moving on to next. How would you grade longevity of results? Chemical peel versus EBDs.
How would I grade the longevity of the result? Well, based on the pathology that I'm treating. So if I'm treating an acne, nothing works, because if the patient is not going to, improve his lifestyle, they're going to keep coming back with acne spots. But if you're looking at other diseases like maybe aging, then EBD, definitely over a peel.
Yeah.
So that's how I would place it. Recurrent conditions vis-a-vis conditions which are not recurrent.
Dr. Indu ma'am?
I think it depends on the patient's lifestyle and other factors also, apart from just, like if you just look at chemical peels and EBDs, of course EBDs would have a longevity, more of a longevity, but it depends on many other factors, patient factors.
Yeah, same, it depends on the pathology as well. Like if acne is coming and recurring there, so peels will work better rather than EBDs.
There's always a hormonal aspect to acne, especially in women. So you need to address that in younger women, because hormonal aspects leading to, especially with polycystic ovary disease, that is very important. Hormonal. The second is sedentary lifestyles. I mean, if somebody is not able to put in 1 hour of exercise in a day, if you can't spare 1 hour out of 24 hours for fitness, a lot of women think, and men also think that, you just go and pump yourself full of fillers and stuff like that, and whitening creams, and then you absolutely see with depigmenting agents, you have women today coming with what I call Fanta face, Coca-Cola body. The face looks like Fanta, it's orangish because of depigmenting agents. Below the neck, it's all Coca-Cola.
I think with longevity of any kind of results, whatever you are doing in the clinic, apart from that, home care is what makes the results last longer. So that also plays a role, what they are doing at home, how much sun they are exposed to, what are they using to maintain the results. So that is also a very important part of
How
treatment.
regular they are with the treatment part.
Yes, how compliant they are with whatever medications have
At
been
home.
prescribed at home,
Yeah.
as well as with the procedures.
Yeah. Okay. Moving on to the next and the last, I'll be really quick. One single modality for full face rejuvenation if you have to choose. If your patient is short on time, any quick event, wedding, or patient is from abroad. He says, I'm short on time, I just want one single modality, a sitting or maybe max 2 for full face rejuvenation. What would be your choice?
Okay, so very tough question. But I would choose the erbium glass laser. I think with relatively low downtime, it helps me bioremodel plus give that immediate change in the skin texture, or a bioremodeler, one of the two.
So if the patient is from abroad and just wants one session and can take injectables, is ready for that, then I would choose my threads and fillers and everything in one session. For a bride, maybe depends on the time period. If she's come to me earlier, then maybe a skin booster I could give. If not, if there's just 1 week left, then maybe a medifacial or something.
For a short time and single session, I usually prefer mesotherapy with the exosomes or skin boosters, or hydrofacial along with glow peel. That's the best without any downtime.
I should think MNRFs with hydrofacial would probably address most of the problems for a short period of time. But there's one advantage with patients who come from abroad. That is, they're not going to come back and complain to you for the next 1 or 2 years. So you can take a bigger risk with them. I have often seen this, You do a procedure where there's a chance of a PIH and the patient leaves and the patient gets PIH. They'll send you a message for a couple of months that they're not improving, but they can't come back and be critical of you. And 1 year later, when they come back, the natural course of time has removed the PIH and they're very happy. So when you have patients who are leaving back to their country, but within 1 week, not after a month or so, please do a more aggressive procedure, because the more aggressive procedures will obviously tighten the collagen more. They'll break the scars more, like a fractional CO2, for instance, which will temporarily lead to PIH or problems, but in the long run will lead to a lot of smoothing of skin and scars. Foreign patients tend to do it. I've seen a lot of my Dubai patients in which I have done little aggressive therapies, but when they come back next year, they're very grateful. So it's that things don't look good for a month or two, but after that they become much better. And you don't have to do any hand holding because they are too far away to hold hands. You're lucky.
If they're traveling abroad, it will depend on the travel plans. If you tell me they're traveling tomorrow or day after, then I would just go for maybe a medifacial or a laser toning with a mild peel, like a lactic acid peel. If they have few days, then yes, you can go for more aggressive therapies like microneedling, MNRFs, and all these. Even ablative lasers.
Thank you very much. I would like to thank all my esteemed panelists, Dr. Deepti Saxena, Dr. Ganesh Pai sir, Dr. Indu Balani ma'am, Dr. Pradnya, Dr. Asmita. I request on stage Dr. S.N. Bhattacharya sir to kindly felicitate our panelists.
And to felicitate, Dr. S.N. Bhattacharya is already here on the stage. I would request, sir, to please felicitate Dr. Deepti Saxena and Dr. Indu Balani. Ladies and gentlemen, please put your hands together as we felicitate Dr. Deepti Saxena along with Dr. Indu Balani. Thank you so much, all the esteemed panelists, for taking the time out here and sharing your insightful knowledge with everyone. Thank you so much. And before you leave the stage, I would also request to please felicitate Dr. Apurva Singh. Can we have a big round of applause as I request Dr. S.N. Bhattacharya to please felicitate Dr. Apurva Singh. Thank you so much, everyone. Now, ladies and gentlemen, moving forward, towards our next session, which is the fillers. And for this, I would like to invite here on the stage our chairperson, Dr. Dr. Ginni. Can we have a big round of applause for Dr. Ginni? Dr. K.S. Mehta, Dr. Denesh Maur, and Dr. Kaushal Kumar Verma. Okay, so we have our chairpersons here, and now I would request our chairperson to please introduce our next speakers, and he is the one to talk about how to choose a filler for upper lips, and here we are with Dr. T.A. Rana. Can we have a big round of applause as our chairperson introduce our next speaker?
Well, I think to introduce Dr. Rana is, and in this audience, and that too I introduce Dr. Rana probably is something very difficult. Because Dr. Rana is the chief person who started this FADS, and he's very well known, and I'm not going to read out all those things. He's a senior consultant dermatologist, Sri Ram Hospital, Heart Institute, director of Skin Laser Institute in Noida, completed laser aesthetic medicine fellowship from Skin Institute, Germany, more than 22 publications, presented papers, abstracts, and offers customized treatment, blending dermatology medicine and with cutting-edge technology of optimum outcome. He is recognized as a respected media figure in cosmetic dermatology, often appearing as an expert television and internet media, and he holds life membership in several professional organizations, including IADVL, EADV, IACLS, ISD, ECAM, AAD, and AAAM. Specializes in dermatosurgery, lasers, fillers, Botox, and he has founded the Face Aesthetic Dermatology Society in 2016. I also came there and I am witness of that. And organized 7 successful FEDS Congress and hands-on workshops among the major academic achievements. So all yours, Dr. Rana.
So much. Yes. My topic is the filler of the upper face and periorbital region. Now I am training the Chandigarh and PG students last month. Overview of the dermal fillers. What are the phase of dermal fillers? Upper face dermal fillers are injectable substances used to restore volume, smooth wrinkles, and enhance contour in the upper part of the face. These areas include the forehead, temples, brow, and periorbital region. As the upper face experience volume loss, wrinkles, and skin laxity due to the decreased collagen production and the redistribution, dermal filler have to rejuvenate these areas, providing a more youthful appearance. History. 1893, soft tissues augmentation was started by Neuber, who took the form of the arms and transplanted into the facial defects. 1899, Paraffin was used and was later given up due to the foreign body granulomas. 1940s and 1950s, silicone was used extensively until the Commissioner of the US Food and Drug Administration declared the use of injectable silicone to be illegal. 1970s, the field of the soft tissue augmentation underwent to regulation change when researchers at Stanford University worked on the use of the animal and human collagen as implant materials. Aging. Some physiological processes such as a deteriorated skin quality of the atrophy or resultant loss of the facial volume and skin elasticity result in facial aging. As one grows older, then skin connective tissues become thinner along with the exposure of elastic fiber to collapse. The appearance of the aging phase associated with some problems including wrinkles, blemishes, age spot, volume loss, and sagging of the tissues. Layer of the face, the skin, deep fat, superficial fat, periosteum, mass, and bone. The key area of the dermal filler in the upper face. Forehead filler are used to soften the wrinkles and lines as a horizontal forehead, lines for global lines between the eyebrows. Temple, volume loss in the temples can create a hollow. Gaunt look fillers helps restore fullness, balance facial proportions, and create a more youthful appearance. Crow's feet, lateral canthus, though often treated with the neuromodulators like Botox, fillers lines around the outer corners of the eyes can also benefit from dermal fillers to smooth wrinkles. Optimal filler characteristics: long duration, no migration, performance promise, painless, reasonable cost, non-toxic, non-inflammatory, non-carcinogenic, non-animal origin, easy to inject, easy to store, ease of learning to how to inject. Technique of the injection: linear threading techniques. The filler trainers are teach every student and every new learners the technique of the fillers, how to inject. The full length of the needle is inserted in the middle of the wrinkle and the substance is injected while pulling the needle slowly backwards, retrograde, so that the threads of the gel are placed longwise the wrinkles are fold. Most commonly employs techniques and works well in specific wrinkles, NLF and mandibular folds. Cross hatch techniques. Linear threading techniques in use the periphery of the defect. The needle is withdrawn from the skin and inserted 5 to 10 mm in adjacent at the first site of the injection and procedure. Repeat this method is carried out at a right angle of the original lines. Serial puncture techniques. Multiple serial puncture are placed closely along the length of the treated wrinkles fold so that it images into a smooth, continuous line of the wrinkles. Fan techniques. The needle is inserted the periphery of the area treated the linear line threading techniques. After injecting one linear thread, the direction of the needle is changed and injected as before in fan-shaped manner. Depot tanks. A small bolus of the filler is deposited into mid-deep dermis, holding the needle perpendicular to the skin. This is done to create a volume and fill up the space for small localized defects, especially acne scars, varicella scars, trauma scars, works best and has giving the additional subcision effect in addition to the filling. It requires massage for the modeling after the injection. Tenting technique: injection given vertically from the right to rather parallel to the contour. It is a unique technique that is used to create plump, full, non-ducky lips. Allows to create vertical lines of the filler in the lip, thus helping the lip to be pulled up towards the 1 million border instead of becoming heavy and taking away under the lip border. Fun techniques: needle inserted perpendicular into the fold and after the advancing it implant injected to either side in retrograde manner. Multiple such injections are placed along the length of the fold is the lines are best corrected by the fan. With the 90% injection or 90-degree injections are given deep in the tissues with the gradually tempering production depositing the needle is withdrawn. A number of the towers are created, thus providing support to the tissue, helps in the treating volume loss. Sandwich techniques, implant is injected the various layers deep to the superficial, one above the other to provide a structural support to the second, and more superficially filling to be done is another setting. Types of the dermal fillers used in the upper face. Hyaluronic acid fillers, hydrated skin provides a volume and is reversible, commonly used in delicate areas like the tear trough. Calcium hydroxyleptide, longer lasting, stimulate natural collagen production, often used in deeper area like the temples. Polylactic acid stimulate the collagen production with results developing gradually over time, ideally for volume restoring in the temple. Benefit upper face dermal fillers. Restore youthful volume and contour, smoothness, fine lines and wrinkles, enhance symmetry and balance in facial features, minimally invasive with little downtime. Dermal filler in the upper face need to be chosen carefully as the areas of sensitive with thin skin and important underlying structure. The right filler choice depend on the specific area being treated, the patient skin quality and the desired results. Many dermal fillers provide immediate improvement with continued result as the production settled in depending on the type of the filler used. The result can last from 6 months to over 2 years, especially with fillers like hyaluronic acid and calcium hydroleptide. Eyebrows can provide the subtle life of the brow area, helping to open up the eyes and reduce the appearance of the sagging. Tear trough under eye, hollowness or dark circles under the eyes can be treated with the fillers to smooth the area. The appearance of the tiredness and sunken eyes. This is my patient. I do the tear trough and nasolabial fold before and after pictures. This is the next patient, tear trough only. Consideration for the periorbital area. The skin is a delicate structure. As you know, the previous panelists and lectures discuss a lot. While low viscosity and soft filler are needed, risk of overwhelming the incorrect production choice. Vascularity impact of the avoiding complication like vascular occlusion, use of the blunt cannulas and proper injection techniques. Risk management and safety. Potential risks, bruising, swelling, lumpiness, vascular occlusion. Best practice, use of the versatile filler, hyaluronic acid. Proper injection techniques, cannulas, small amounts, laying of techniques. Periorbital anatomy, understanding the underlying anatomy and aging changes of the periorbital pressure, a crucial component of the successful rejuvenation of the periorbital region. Understanding the soft tissues, vascular and bony anatomy is the crucial of the successful rejuvenation in the periorbital area. The periorbital region is one of the most dynamic and unforgiving in relation to volume enhancement. The eyelid skin is the thinner in the body that lacks subcutaneous fat and it is a dynamic structure. Irregularities are more readily appearance in this area than other areas of the face. Understanding the complex periorbital anatomy is important to help avoid potential complications. Periorbital injection, both botulinum toxin and dermal fillers have been widely used to address periorbital aging. Complications arising from the botulinum toxin injections are usually transient and related to its effect on the affected muscles. Most patients with complications arising from the botulinum toxins injections can be treated supportively with the ocular drops, and referral to the ophthalmologist or oculoplastic surgeon may be considered. Dermal fillers have been used effectively in the periorbital area for over 20 years. Various dermal fillers are available, however, in the periorbital area. The reversible temporary hyaluronic acid fillers are preferred. Proper selection and placement products can be helped avoid some complications. The use of permanent, non-reversible fillers are discouraged in the periorbital area, as this area is constantly changing and complications with these fillers can be difficult to address. This presentation will also focus on non-ischemic and ischemic complications associated with HA fillers. Of note, when injected HA fillers, hyaluronidase should be available. This is my clinic patient and inject to the tear trough. These are the more references of the tear trough and upper face of the body. And these are the more reference. And thank you very much.
Thank you, sir, for a nice presentation.
Thank you so much, sir. And I would request you to please come forward. And I would also request chairpersons to please felicitate Dr. T.A. Rana. So, ladies and gentlemen, please put your hands together as we are felicitating Dr. T.A. Rana, who was here to speak on how to choose a filler for upper face and periorbital. Thank you so much. Now I would request our chairperson to please introduce our next speaker.
I would like to invite our next speaker, Dr. Supreet Singh. He will be sharing his presentation on rejuvenation, mid-face and lower face.
Can we have Dr. Supreet Singh here on the stage? Okay.
Now he is Assistant Professor, Department of Dermatology and Consultant Dermatologist at Ansuk Skin and Hair Institute, Jammu. Dr. Supreet, please.
I guess one page is missing. One page is missing.
Good morning, everyone. I'll be speaking on filler rejuvenation for mid and lower face. The desirable aesthetic features as well as the mid and lower face are concerned, they are malar projection, fuller cheeks, a smooth convexity from lower eyelid down to nasolabial fold, forming an OG curve, a well-contoured chin, and a sharp jawline. To achieve them safely, there are 4 essential prerequisites. These are extensive knowledge of anatomy, and appropriate injection techniques, adequate choice of the product, and the right approach. So the question is, why fillers? This is because facial aging is a complex process with interrelated changes in bone, fat, muscle, and skin. There is volume loss that occurs as a result of atrophy of subcutaneous fat, as well as deep fat that leads to a deflated appearance, weakening of facial retaining ligaments, dermal atrophy, and thinning of epidermis and loss of collagen. All these changes, they lead to accentuation of facial features such as nasolabial folds and jowls. And a characteristic triangle of youth slowly gets transformed to the pyramid of aging. Now, coming to the individual changes, as far as the bone part is concerned, specifically to the mid and lower face, maxilla is the main bone that undergoes change. There is resorption with loss of projection. Maxillary angle reduces, a piriform aperture enlarges as the nasal bones they recede. In the lower face, mandible angle increases, ramus height and mandibular body height they decrease. There is reduced skin projection. Coming to the soft tissue, the deep fat atrophies that leads to the volume loss and that causes deflation of the face. Superficial fat, apart from being atrophy, it tends to reposition itself under the effect of gravity and weakening of supporting ligaments. Coming to individual fat patch, we have atrophy of infraorbital fat that leads to bony appearance of lateral side of orbital rim, as you can see in the picture, a tear trough deformity. Similarly, atrophy of medial cheek fat leads to mid-cheek concavity and appearance of a mid-cheek groove. And atrophy of middle cheek fat further accentuates the depression of medial cheek fat. Similarly, nasolabial fat atrophy leads to a more pronounced nasolabial fold and nasolabial groove. Now, coming to the first prerequisite, that is the anatomy. For the filler point of view, face anatomy can be considered as a 5-layered arrangement spanning from bone to the overlying skin, and in between we have fat pads, superficial and deep, separated by mass layer. As far as the fillers are concerned, fat compartments are important, and as far as the anatomy, we have mobile superficial fat compartments and static deep fat compartments. As you can see in the picture, we have infraorbital fat, middle cheek, medial cheek, and nasolabial fat, superior and inferior jaw fats. The deep fats are static because they are adhered to the underlying bone. We have medial suborbicularis oculi fat, the medial SOOF, lateral suborbicularis oculi fat, lateral SOOF. We have deep medial cheek fat, and we have deep labiomandibular fat and deep mental fat. Now, separating these two layers, we have SMAS that plays a pivotal role. It is basically an organized fibrous network composed of platysma muscle, parotid fascia, fibromuscular layer covering the cheek. It's very essential as far as facial expressions are concerned, because all the muscular contractions are transferred directly to the skin, located just beneath the superficial fat, as you can see in the picture. It includes facial muscles as well as ligament-like tissue. The 3 laminae that form the SMAS layer, they are the thin fascia on the outer surface of the muscle, mimetic muscles themselves, and the thicker fascia on the underside of the muscles. And at places where there are no muscles, fascia 1 and fascia 3, they fuse. Now, coming to the retaining ligament, these are very important for the filler point of view. True ligaments are those which directly originate from the facial skeleton, and they are pierced as SMAS and finally insert into the dermis. These are orbicularis retaining ligament, tear trough ligament, zygomatic cutaneous ligament, as you can see in the picture, buccal maxillary ligaments, mandibular ligaments. It is the loosening of this ligamentous system that contributes to the gravitational descent of superficial tissues. The most important anatomical structure is the vascular system. As you can see in the picture, face is richly supplied by the blood vessels. Facial artery being the main blood vessel, it enters the face by curving around the lower border of the mandible, and here the vessel lies deep to the platysma, and then slowly takes an oblique route and has a route both in 2D as well as 3D planes. And at the level of lateral commissure, it divides into 2 branches, superior labial and inferior labial artery. From here, it is known as the angular artery, and further, the important point is, as far as the nasolabial fold is concerned, in the lower 2/3, the vessel is deep, and in the upper 2/3, it becomes superficial. That is why we give injections supraperiosteally in the nasolabial fold. Similarly, the other arteries are infraorbital artery, transverse facial artery, zygomatic facial artery, and the facial vein. Now, coming to the second prerequisite, that is the knowledge for the facial fillers. We have various fillers that are available in the market. We have hyaluronic acid, we have collagen, polylactic acid, calcium hydroxyapatite, and autologous fat and polymethyl methacrylate. And out of these, hyaluronic acid has gained importance because of its wide range of indications, including it can be used for the treatment of fine lines, wrinkles, deep folds, both periocular and perioral areas, even for lip augmentation. And also it's available in various G' formulations. And also an antidote that is by the name hyaluronidase is also available in case of any mishap happens. Out of these, calcium hydroxyapatite has been FDA approved for the use in lipotrophic cause as a result of HIV/AIDS. And now coming to the third most important is the techniques. As far as mid and lower face are concerned, a multi-layering approach is one of the logical approach that can be employed. Young patients with limited volume deficit can generally be improved with injections limited to the deep fat compartments. Older patients with significant volume loss and mid-face hollowing, they require a double plane treatment. And this multi-layering approach actually starts with the supraperiosteal injections targeting the deep fat pads, and it finishes with the superficial injections into the mobile subcutaneous fats. So as far as mid-face is concerned, first compartment is the deep fat injection. This forms the basic and the first step as far as the filler for the mid-face is concerned. The basic support is provided to the deep fat layer, targeting medial SOOF, lateral SOOF, and deep medial cheek fat. And these, as you can see in the picture, can be mapped by tracing 3 lines. One vertical line, that is line number 4, and mid-cheek line that usually coincides with the mid-cheek safety line. It's an arbitrary line that runs from the medial canthus to the ipsilateral mandibular angle, and a zygomatic line that courses the zygomatic major muscle. As you can see, blue dots can be employed as needle entry points. Now, this injection can be done with the help of a needle as well as with the help of a cannula. As far as the needle is concerned, the original technique was patented by Dr. Wayne Carey from Canada, where he used 3 bolus deposits of the product in medial SOOF, lateral SOOF, and deep medial cheek fat. The injection is performed slowly at a low pressure. We take the needle at 90 degrees and go until it touches the bone. Aspiration maneuver, that's very important, it is done. And volumes as low as 0.2 milliliters to 0.3 milliliters can be deposited depending on the volume loss. This is to be followed by a gentle massage to smooth out the product and to reduce any irregularity, especially in thin-skinned patients. Similarly, we can do the fillers with the help of a cannula, where a 25 gauge cannula is used. We can choose a point, that is the lateral entry point. This is usually 1 to 2 centimeters below the lateral canthus, and this area is relatively safe and poorly vascularized. Here, we always try to stay above the mid-cheek safety lines, as just discussed, to avoid encountering the facial vein and potentially the infraorbital truncofacial artery. Again, a pre-hole needle is pressed deeply as possible into the deep fat layer with an angle of 90 degrees, and then with a non-dominant hand, tissues are lifted to insert the cannula at approximately 60 degrees angle. And a reliable indication whether you are inside the right plane or not is that the cannula's movement should not be visible onto the skin surface. And likewise, injection is given in the medial SOOF, lateral SOOF, and then we can withdraw the needle and again insert into the right direction so that deep medial cheek fat is also filled. Again, as far as lower face is concerned, nasolabial folds, 2 types of injection can be given in the deep and the superficial. In the deep plane, it's done in case there is severe volume loss. Usually filler with high G prime is used, and typically it is deposited in the canine fossa. Caution needs to be exercised. Facial artery is there. As the artery becomes superficial, that's why we give deep injections on this side. Again, aspiration maneuver is always important, and we inject very slowly and massage out. For superficial, a linear threading technique is employed. Skin is stretched with 2 fingers to better visualize the fold. We stay slightly middle to the fold and then inject. Again, aspiration is very important. Similarly, for marionette lines, as you can see in the picture, 2 sites can be chosen. The upper injection site is usually inferior to the modulus, and we inject slowly. Vertical column technique can be employed. And again, for the rest of the injection, a linear threading technique is employed. The caution needs to be exercised. We have to keep a check on inferior labial and sublabial arteries here. As far as chin apex is concerned, this is a very important area as far as lower face is concerned. As you can see in the picture, for augmentation, the product is delivered onto 2 or 3 sides. For the first side, the needle is positioned in this midline. Aspiration maneuver is performed. Pinching is done to avoid the unwanted displacement of the filler, and we deliver supraperiosteal bolus. You can give up to 0.2 ml of the fillers there. Caution is to be exercised. Do not inject too low, as you can lead to the formation of witch's chin, and also do not overfill. Avoid mental artery and vein in this area. Similarly, for the pre-jaw area, as you can see in the picture, it's a triangular area from the mental foramen to the mid-lateral zone of the mandible. We position the needle at the jawline, aspirate, and make a deep subcutaneous injection. Here, care needs to be exercised. We have to avoid mental artery as well as mental nerve. For the mandibular body and angle, usually fillers in this area are done to create a more defined jawline. 2 or 3 sites can be chosen. Both subcutaneous and supraperiosteal injections are used. Subcutaneous are usually preferred in case of females, and supraperiosteal injections usually delivered at mandibular angle. They are ideal for male patients as they have more squarish jaw. Again, caution needs to be exercised. We have to avoid scratching of the periosteum, as this is very prone for development of deep hematomas. Facial artery is very important in this area, so it needs to be avoided. Another approach is an MD codes approach that was initially devised by Maurice de Mayo, and each code basically includes information regarding the depth, delivery tool, the technique, and the volume recommended. As you can see in the picture, it comprises of various components. The letter, it denotes the area to be injected. The number denotes the subunits that can be injected. The number denotes the subunits, yes. And the color denotes the red areas or the danger areas where there are potential vessels and neurovascular bundles, and very cautions needs to be exercised over these areas. And shape denotes the technique of delivery. Using this approach, cheek has been divided into 3 zones, CK1, CK2, CK3, CK5, as you can see in the picture. Each subunit being zygomatic arch, zygomatic eminence, then anteromedial cheek, lateral cheek, and submental or buccal area. Caution needs to be exercised, especially in CK2, CK3, and CK5 areas. As CK3 areas is in the vicinity of infraorbital foramen, you have to avoid this area and be cautious in this area. Similarly, for CK5 and CK2, you have to avoid facial artery. Similarly, for nasolabial fold, denoted by 3 subunits, NL1, NL2, NL3, as you can see in the picture. Injection in NL1 zone can be a supraperiosteal deep injection, as the artery is superficial in the roof of the piriform, this space here. Similarly, for chin area, it has been divided into 6 areas, as you can see in the picture, C1, C2, C3, C4, C5, C6, and jawls from JW1 to JW5. And as you can see in the picture, C6 are triangular areas. That means fanning technique to be employed in this area. In C1, that is a mental angle. One second. Yeah. So coming to the complications, we have non-vascular and vascular.
I'm sorry,
non-vascular
please conclude. Time is over.
Okay. So at last, I conclude by saying that there are 3 prerequisites. That is, extensive anatomy knowledge is very important, appropriate injection techniques is very important, and adequate product choices. Multilayering and MD codes approach is logical, and always inject slowly with low pressure, always perform the reflex maneuver. It's important to recognize signs of local ischemia, and always maintain an emergency kit with hyaluronidase and vasodilators, and establish networks with experienced physicians in case of any referral. And if you have to treat both mid and lower phase, always try to treat mid phase first. Thank you.
Thank you so much, Dr. Supreet. I would request you please come right at the center of the stage, and I would request our chairperson to please felicitate Dr. Supreet Singh, who was here to talk about the mid-phase and lower phase regeneration. Can we have a big round of applause as we felicitate Dr. Supreet Singh? We have our next speaker coming up here on the stage, Dr. Deepti Dhingra. Can we have a big round of applause for our next speaker? And meanwhile, I would request our chairperson to please introduce Dr. Deepti.
Thank you, Supreet, for taking us through the facial anatomy and then educating us on the various fillers and the techniques used for correction of the mid and lower face. Now we have Dr. Deepti Dhingra coming up. She's going to talk on minimal volume and texture, lip correction using fillers again, I guess. Deepti's CV is there on the screen. She's a medical advisor and dermatologist, Kaya Skin Clinic, Hyderabad, consultant dermatologist, Fortis Hospital, Delhi. So I guess she's traveling between Hyderabad and Delhi, and now talking on the revitalizing thin textures lips. Over to you, Deepti.
A very good morning to everyone. Thank you to the chairpersons for introducing me. But that was an old CV. I would also
suggest please keep it to the time.
Yeah. So that was an old CV. I think they have put in my older one. I'm currently practicing in Dehradun. I have a clinic by the name of Skin Station. And I'm thankful to the organizing committee for giving me this wonderful opportunity to talk about the second most commonly discussed thing in Bollywood. I'll keep it second and I'll keep you guessing what is the first one. So that is, I'm sure you guessed it by this image. It is the world's fastest growing cosmetic procedure worldwide. Yes, it is the lips. A small 20-minute of filler can make a huge difference to the confidence, a huge difference to how people perceive themselves, and also to the way they look. So I'm extremely delighted to be talking more about it. So I'm going to be discussing a very comprehensive and, like Sir said, a very short approach to diagnosis and treatment of thin textured lips. To begin with, we'll understand what thin textured lips is all about. It is lips that appear thinner due to natural aging, genetics, or external factors. The effect of thin lips is commonly in appearance. I have seen people who have thinner lips, they generally perceive themselves to be lesser confident. Considering there are multiple Bollywood songs also on lips, it is very important nowadays for people to have nice, luscious lips, so it improves their confidence. Common insecurities related to thin lips, and also when it comes to lips which are thinner and texture, there are issues like lip dryness and chapping. How do we diagnose thin lips and textured lips? By a clinical evaluation. So a visual inspection of lip volume, texture, hydration, assessment of fine lines, wrinkles, and lip definition is how we clinically evaluate it. Additionally, patient's history like age, lifestyle habits like smoking, sun exposure, use of lip balms or anti-aging creams, and another thing that I missed writing here is their dental structure is a very important evaluation when it comes to evaluating someone's lips. Photographic documentation for baseline and tracking process. Looking at aging lips, a particular aging lip would look like something that has a lengthened upper lip, a drooping cupid's bow, flat lips, a wider mouth and drooping corners of the mouth, commonly associated with loss of lip volume and fine lines on the surface of the lip. The treatment approaches for thin lips would include non-surgical enhancement and surgical and cosmetic procedures. Non-surgical enhancement is the various makeup techniques like lip liners and glosses. Topical treatments are multiple lip plumpers which are available these days, which also serve a short-term purpose in enhancing the lips. And the third is lifestyle adjustment, which includes avoiding dehydration and working on damage that happens because of sun exposure. There are various surgical and cosmetic procedures which are available to work on this condition. Lip fillers and hydra boosters, lip implants, and even fat transfers are commonly done to improve the appearance of thin lips. Hydra boosters for textured lips. So, skin boosters for lip hydration are injectable treatments that deeply hydrate the skin and lips, improve the texture, and restore a youthful appearance. The skin boosters contain hyaluronic acid, which is a powerful humectant that draws moisture into the lips, making them appear plumper, smoother, and healthier. The skin boosters are predominantly for people who are not looking so much so at volume enhancement, but they are looking more at hydrating, softening, and making the lip texture look smoother. How skin boosters work for lip hydration? These are skin boosters which are injected into the lips or the skin around the mouth to deeply hydrate the tissue. Hyaluronic acid attracts moisture from surrounding tissues, leading to well-hydrated and softer lips. The procedure typically takes 20 to 30 minutes with little or no downtime. The results can last for several months, and some people require a recession within a month or within 6 months based on the severity of the condition. Talking about lips with hyaluronic acid fillers, lips are treated with hyaluronic acid fillers in particular people who require volume enhancement, as these fillers add plumpness to thin lips, textured smoothing, which means to reduce the fine lines and uneven texture, and hydration. Hyaluronic acid fillers, they attract moisture and the lips look more hydrated and younger after performing lip enhancement. The key injection while injecting lip fillers is upper lip versus lower lip ratio of 1:1.6. That is, the upper lip to the lower lip volume is usually a guide for balanced filler placement. Particularly in aging lips, there are a few parts of the lips that should be kept in mind. One is the borders of the lips, that is the vermilion border. When we inject the vermilion border, it gives the lips more definition and the lips and gives a more youthful and a younger appearance. The second is the middle body or the vermilion zone, where the lip filler is placed for more plumping effect. So if there is a client who's looking at plumping, then we would prefer the middle body. And if someone's looking at more definition, then it is obviously the vermilion border. There are other parts like the oral commissure, which is a very important structure that we must support while we are injecting the lip fillers. So putting a lip filler at the oral commissure also provides the support that it needs. Lastly, looking at the filtral column of the patient. I've seen in my experience that the moment we add a little filler in the filtral column, the patient's mouth starts looking more anteriorly projected, which gives them a relatively younger and a more youthful appearance. Looking at lip fillers for thin textured lips in an overview. Injectable dermal fillers usually hyaluronic acid. The filler lasts for 6 to 12 months. It is a quick procedure and should always be performed by a certified professional. A very important document is a consent form. All fillers, when done, taking a consent form before doing any injectable is the most mandatory part of doing a session. The results may take up to a week or 2 weeks to be completely visible. Some people experience swelling, so we would call it a procedure with minimal or no downtime. We must align the patient about swelling or bruising. That may last a few days. Lastly, about the post-treatment care and maintenance. Aftercare following the procedures, avoiding harsh products or sun exposure. Ongoing lip hydration to be continued. Follow-up consultations for progress and assessment. Repeated treatments for fillers or additional laser therapies that you may have planned. Patient education on maintaining lip health through great lifestyle choices. Now we're going to look at some results. If you look at this wonderful lady, she looks good in the first picture as well, but in the second one, she looks more youthful. We're going to take a front view of her. Again, just highlighted a little upper lip here, so that is where she looks more younger, more anteriorly projected. There is another picture. Can you guess that's who? Yes, that's me. I personally love lip fillers. So I also thought that after doing a little lip filler, I also started looking very different. I'm still looking at someone who can do it for me again. Thank you so much.
Thank you, Deepti, for doing it on time. Thanks very much.
Thank you.
Thank you so much, sir. Thank you so much, ma'am. And I would request you to please come right at the center of the stage. And I would request our chairperson to please felicitate Dr. Deepti. So, ladies and gentlemen, as we are felicitating Dr. Deepti, can we have a big round of applause? Now, ladies and gentlemen, moving ahead towards our next panel discussion. Okay, I would request Dr. Ramanjeet sir to please come up here on the stage to felicitate our chairperson. So we have the first one whom we are going to felicitate is Dr. Denesh Maur. Can we have a big round of applause as we felicitate Dr. Denesh Maur, sir? Dr. K.S. Mehta. We are going to felicitate Dr. K.S. Mehta. Can we have a big round of applause for Dr. K.S. Mehta? Dr. Kushal Kumar Verma. Can we have a big round of applause? Thank you so much, all the chairperson who were present here. Thank you. And now we are going to move forward towards the panel discussion. And for this, I would like to invite our moderator here on the stage, Dr. P.K. Talwar. Can we have a big round of applause for our moderator? And we have our esteemed panelists as well who are going to join us here on the stage. And I'm going to take the name. Dr. Jyotimay Bharti, can we have a big round of applause for all the panelists who will be joining us? Dr. Jyotimay Bharti, Dr. Deepti Dhingra, Dr. V.S. Rathore, Dr. Sukhbir Singh, and Dr. Ankita Pant. Can we have a big round of applause for all the panelists who are going to join us here on the stage? I would request Dr. Viral Desai, sir, to please join us as the esteemed panelist. So, ladies and gentlemen, this is the panel discussion where we will be discussing the complications of fillers, and the moderator, Dr. P.K. Talwar, is already here. So, over to you, sir.
Can we invite Dr. Patrick also? Can we invite Dr. Patrick also? Sir, please join.
So, we have Dr. Patrick as well with us. So, I would request you, sir, to please join the esteemed panelists.
Dear panelists, now we are going to start with a very interesting topic, and that is the complication of the fillers. My first question is that we are always advised to do the allergy test on fillers. Now, are you really doing the allergy test on every patient? Let's be very honest, because I don't do it. So we can be honest to each other. In every patient, are you doing allergy test?
No. In every patient, I am not doing allergy test.
Yes. No, absolutely. We are not doing allergy test. So,
no, I see no reason to do
so I think all of us are cutting corners academically, but yes, it's okay.
No, it's not about cutting corners, because the fillers are now HA based, right? So because of that, you don't need allergy tests. When they were collagen and they had other, if you talk about semi-permanent, permanent fillers, yes, maybe that was required, and collagen, but now it's all HA, and we don't use anything else in India except HA.
Yeah, but in the books it is advice, so that is why I just asked the question
that was,
academically. Yes,
yeah,
I'm
that
not
was
doing.
the old fillers when they were collagen based.
Okay.
That's what, or silicone or collagen.
Okay.
But those are completely outdated. And they are
absolutely, by at least 30 years.
Yeah. It's been 20 plus years. It's
Okay,
there.
fine. Now, my second question is, suppose you know that the filler, there is allergy to the filler. Would you abandon the procedure, or you will shift to something else like PLLA, hydroxyapatite at that time?
No, we'll
completely stop the procedure that time because patient is already in allergy. If you introduce any other product, it can lead to further, anaphylaxis or any kind of severe allergy form. So the point is, if you see the patient is reacting, immediately stop the procedure, put them on antihistamines and steroid if needed, and call them after the symptom subsides, and then you decide what can be done. But if the patient has reacted once, I think second time you should avoid that kind of injectables in that patient.
Yes, I in my period in aesthetic medicine, I certainly have never tested. We took over from the Americans, who were way behind in aesthetic medicine, may I say, compared to Europe, and they did tests for collagen because it came from a mammalian source. In HAs, we've never, there's no reason to test. I mean, they come from genomic bacteria, particularly. It took us a long time. I suppose we started injecting HA back in 1996. In the United States, it took them up to 2005 because of the FDA. The problems that we get with HA fillers really have nothing to do with allergy. It is more to do with the breakdown after 3 months into low molecular weight HAs, setting up an inflammatory process. Calcium hydroxyapatite obviously has no reason to be allergic. It comes from a bone source with a gel mix. So, and most of the polyacrylamides that have been taken off the market set up an immune response much later also, some of them up to 10 years later. So I see no reason for sure.
Yeah, I would say that. No, because today with HA, it's unknown, it's unheard of again. So, and right now we only use HA in India. They're not approved. So probably that was relevant when the collagen was there. That was before 2005, 2003. But the only other kind of allergic reactions, I wouldn't say allergic, but rather T-cell mediated reaction, a delayed hypersensitivity, which is very common nowadays, and especially with highly cross-linked fillers because of the BDD component. So the reaction is not to HA, the reaction is to the cross-linking agent, which is your BDD. And you don't get any kind of allergies immediate, never with that. But you get something which is like a delayed T-site mediated lymphocytic infiltration, which is typically seen 6 weeks to 12 weeks later. And yes, that could lead to edema, angioedema and all that. But it's not life-threatening, but localized swelling. Otherwise...
Yeah, so he's right. Hypersensitivity can happen, but after 4 to 6 weeks, and it subsides with mild anti-allergics or, mild steroid.
But still you will go ahead with the procedure if there is hypersensitivity you feel there is?
Yes, because it subsides.
Okay. I have injected patient again who had hypersensitivity and is doing well, no problem. Okay. All I did was I changed the brand. So from using very highly cross-linked, I use a little less cross-linked, and the patient is absolutely fine, no problem.
Okay. Now, the next question is, what is the area you are most dreaded of while injecting filler? Which is the area you are scared of?
It's the nose.
And why?
The vascularity of the nose. So that is why I don't inject the nose, and that's the area I think I'm most terrified of injecting.
One area.
I couldn't disagree. Of the many blindness in the world that I've witnessed or have been sent to me, 2 have been from the temple, 1 has been from the nose, and actually 4. 1 has been nasolabial as well. So on the ratio, certainly the ones I've seen, 1 was Sculptra with a cannula, superficial, and that was 2008. Another one was from Sweden, and it was a nose. 1 was from Chile, it was a nose. 1 was from the United Kingdom, and that was temple. So the ones that I'd be most afraid of are nose and temple, for sure. But we have safe ways of treating those also, as well as Most of the ones that caused a problem, except for the nose in Sweden, I don't think should have happened in the first place. The patient in both the temples were done with a cannula superficially. They didn't do gunshot technique that I would prefer. And the nose is always a bit tricky. The nose that was done in Sweden was by an ENT surgeon, and the one that was in the United Kingdom shouldn't have been done because of previous surgery on the nose. So there's red, I suppose, flags that we should use. If you're going to do a nose, don't do one that has already had surgery on it. Don't do something that's outside your bounds, particularly sort of in the area just above the dorsal hump. And I think, like we're witnessing this morning, a death in Britain because of BBL. It's all over the Times of India and everything. That person, we had triggered some time ago that he was a problem. So it's, I suppose, knowing anatomy, who's qualified to do what products you're using, and you're trained to do the area, you know.
Yes, Viral.
Yeah, I mean, so actually if we see the statistics, the maximum amount of blindness cases have been reported by nasolabial fold. It's only because that area has been most frequently injected. So that's the main reason. So yeah, you cannot, yes, nose and glabella are very dangerous areas, followed by temple, partly the forehead, but yet the most commonest areas are injected most frequently, and you tend to be more careless when you inject these areas because you do it so often. So actually, you should be dreadful of every area, and you should be careful, because if you actually see if you do an angiography study of the face, there are vessels all over the face, every single place. So how much ever you study, there's so much of variation. So the technique, your tissue handling, your bolus size, and the speed of injection are the key factors to prevent a complication. And it's now agreed amongst most experts that the speed of injection plays the biggest role. So that's very important.
Now, next question is, what is the worst complication you have ever seen following filler? Not yours, but somebody else's, who might have been referred to you because all of you are very senior injectors. Which is the worst complication you have come across?
So I'll be very truthful. Actually, I got a filler done and I had a vascular event. Yeah, on the chin. And I had to highlight it. So I think there was the biggest learning experience for me. One, because it was on me, so I was calm and it taught me a lot. So I think I'll say it was on me, and the area was the chin where I got a vascular event.
Can I ask you this, that what kind of vascular event did you have? Did you have like a compression?
Yes, I had a compression. So I had a compression and I had a vascular block. So by which the entire area first it was blanched, then by the morning I got up, I had a huge swelling and I could feel the pulsation. And because I was flying from one city I was coming back to Dehradun. So I knew by the time I was in the flight that something was grossly wrong. So I went to a plastic surgeon friend in Dehradun and I got myself high-laced. And it took me about, say, 3 weeks to 4 weeks for the entire event to settle down. So.
And which was that area? Inforbital?
It was, no, it was the chin.
Chin.
Yeah.
Okay.
Because in the chin is a very tight component, and I've had problems often. Do you think it was a vascular component, or you think it was a bruise or hematoma?
It was neither a bruise nor a hematoma. I could see the blanching, and I could see the swelling progressively increase. I could feel I could feel the pulsation above it. Like, I could feel that there was, there was a lot of vascularity above it. And as the day was progressing, I have some pictures, I can show them to you later. But yes, it was like a whole vascular event. And it took me like, I don't know, maybe 2 sessions of high-lace to get it out completely.
It's very frightening indeed, isn't it?
Yes, it was frightening, but I think since it was on me, I take it as a huge learning experience. Now, if I was okay, I think people do get okay if the right measures are taken in the right time.
And still you had the courage to inject your patients also.
Oh yes, that's what I said. After that, I got a lot of, actually the confidence increased.
Yes.
I realize that, if the right measures are taken in the right time, it becomes uneventful after a month. But for a patient to be calm for a month, it's going to be too much.
The anatomy is very important.
Yes.
Yes, Jyoti. Ma'am.
I'm also a case study, and last time we discussed in FADS itself, only 2 cases so far reported, and one is me. So I got myself injected with filler, just under eye fillers, 4-5 years ago. And each time I'll get a sore throat, my eyes will swell up, okay? And I would not correlate for 2-3 years. And then suddenly I realized only the area where I got filler done, that will swell up, okay? But last time, it was a massive swelling all over my face. It was a moon face, In fact, my skin started to, tear up. There is a scratch and oozing out of my skin. So I made it a case study, and last time, one of our colleague, Dr. Prashant Agrawal, he did the research, everything, and he came out with that I had been reacting to streptococcal thing. So whenever I'll get streptococcal infection, because the filler is extracted from streptococcal bacilli, so that is how I was getting hypersensitive to it. And Dr. Rathore, plastic surgeon, he suggested only 2 cases has been reported, so I'm the third one, unreported.
Well, there's no doubt.
It didn't get fine with even 100 milligram of prednisolone for 15 days. I had to get it high-laced, and next day I was all normal face,
There's no doubt about it. We know Streptococcus for a long time is a very toxic bacteria. It causes, obviously, necrotizing fasciitis. It causes toxic shock syndrome. It causes pandas to the brain. It causes rheumatoid problems to the heart. And people have tried to use other bacteria like Bacillus subtilis, which is Nuva, but the use of Streptococci was started in Malmo many years ago. The question is, what complications do I see the most? I split it into 2 different periods. The first one, in terms of vascular occlusions, I was getting an average of 4 vascular occlusions a day from all over the world. We worked out the protocols probably about 2007, 2008 for hyaluronidase. So now that everybody knows how to use hyaluronidase, I see them much less. People were referring me cases even from India, we had cases coming to Ireland, from the United States a lot, Middle East, United Kingdom particularly. And now the complications I see most often is delayed tissue nodules. People are afraid to use intralesional steroids, and those that do use it in too high a dilution and cause dermal or lipoatrophy. So, I would still see at least 5 DTNs in my clinic per week. In the morning that I left to come to India, we had 3 in that day. One from a hospital, the patient had been there for almost 3 weeks. Plastic surgeons seem to be afraid of treating patients like this. They're used to surgery. If they can't do a washout, they're sort of limited. So, the use, particularly in Britain and Ireland, of hyaluronidase by hospitals is still disgraceful. They don't have it in emergency rooms, and vascular occlusions now are better treated in private clinics than hospitals. But I find that delayed tissue nodules, particularly, we know one product that causes this. We're not going to mention it on stage because there's often repercussions. But I get a lot of those still from that particular product. Thanks. Including one this morning that I just had to answer when I was sitting there, and they're waiting until I come back. Yeah.
Yeah. Now, after injecting, when the complications appear, you have got pain, erythema, discoloration, nodule formation. So, what do you think? When is the time for you to intervene, or at what time do you intervene?
Well, there's a very clear dictum. If in doubt, if you even suspect 10% or 5% that there's a vascular complication, then always hyalinase. See, this is a temporary product. You can always remove it. You can re-inject it if you want, if you feel the need. So whenever in doubt, hyalinase. So actually, that's what Dipti was showing me her pictures that she just spoke about. the vascular event. So I still feel it's more like a hematoma. Of course, this I've not seen it personally because it was increasing in size. I don't see why a necrosis should increase vascular ischemia would increase. If there is blood supply compromise, there's no reason for swelling to come. So I still feel it was a hematoma, but that hematoma could have increased more. It could have got infected. It could have caused venous congestion, possibly. So I was just telling her, I had two patients similar about same area, chin, because it's a very tight component. And I am very certain they were not arterial injections, but because I didn't want to take a chance, I injected Hyalase them. So whenever in doubt, Hyalase. Don't think. Yeah, I was pretty certain that they were not, but I still did it because I didn't want to take a chance.
So the best policy is not to wait. Any doubt, inject Hyalase.
Whenever in doubt, Hyalase. Okay? Especially for all the youngsters sitting here, you need to keep 5 vials of hyaluronidase in your clinic. If you're doing fillers, check the expiry date of the Hyalase. It should not be Hyalase. Do you need to do test dose to Hyalase? No, not if there's an emergency. If you are treating a vascular complication, you do not need to do a test dose because that is a bigger emergency. Okay, and do you need to do a test dose if you are treating a chronic nodule? Yes, because you're treating a chronic problem. So you will always do a test dose with Hyalase. But you will not do it in an emergency, not when treating a vascular complication.
Emergency, you don't have to wait. Yeah, you
No.
don't have to do sensitivity test. Also
If a patient comes with an arterial bleed to me, you think I'm going to wait for the CBC and FBS report? No, I'll take him up in OT and suture it. So if you have a vascular complication, Hyalase right away. Don't wait. And the principal protocol is what we follow, De Lorenzi's protocol. That is 500 units per area. Inject every 45 minutes to 1 hour. Keep the patient in your clinic for 3 injections at least, and then you may inject further depending upon that. Because Hyalase gets washed away and Hyalase gets broken down by enzymes very fast. So it won't stay. So if you inject a very large dose, then only you'll get some amount of product which is actually going to break the filler. So you have to have a high pulse dose of Hyalase. Repeated injections.
I totally agree with Viral, and I'd put it 1 or 2 amendments that I'd use 1,500 at a time, and I have done that for many, many years. But the second thing is, people keep asking me, well, what happens if the patient is allergic to Hyalase and you've got vascular compromise? We're all doctors. So what if they get an anaphylactic reaction? Keep adrenaline in your fridge. You know, if you're working in an ER in Delhi, in any hospital, you're going to get 2 or 3 anaphylaxis in a night. It's no big deal. You're a doctor. Use adrenaline. So this attitude that has crept in, oh, they're allergic to Hyalase, I'm not going to use it, and so they allow the patient to get more necrotic. You know, come on. That's, I think, naivety in terms of, you know, your ability as a doctor. You should have Hyalase and you should have adrenaline. 2 things in your fridge.
Yeah. So you inject 500 units every hour.
It's 500 units per area. So if you have a chin, it's a large area. So you'll probably need 1,500.
Okay.
Yeah. If you're injecting the whole nose, if it's just a tip of nose, only tip, then maybe 500 is enough. But if you're injecting the whole nose, you need again 1,000 to 1,500. So it depends upon the area that you're treating, the amount of area that you feel that there is compression or necrosis.
Yeah. And can I say also, there was a big difference for many years between the United States and the rest of the world. And it took me a long time to figure it out. In Las Vegas in 2007, I told them they should be using 1,500. They were using 150. But I didn't realize in their fridges, they're using genomic type Hyalase, and as a consequence, they have only, like where we have boxes that have got in it 1,500 and 10 ampules, so it's 15,000 I use, right? They would have to use 10 vials to do the same thing. So it took us a long time to convince them they should be using 10 times the dose they're using. And still some of them, and I chair in IMCAS and in Monaco, I still see American doctors coming up showing, you know, they're afraid to hyaluronidase doesn't cause any problems, you know, and I mean, there's a lot of mythology there that isn't based in science. I've treated thousands of patients with hyaluronidase, literally thousands, and in terms of vascular occlusions, in the hundreds, you know, and I've never had a problem in anybody.
So now another theory is also there that you must flood the area with hyalase, maybe 1500 units at a time.
Unless you're using an ultrasound, and an ultrasound you can be specific to get the vessel and you can use much less.
And the theory said that if you inject a lot of hyalase, the whole of the filler will be dissolved. If you go for a lower dose, all the filler may not get dissolved and it may get broken into small pieces, which may further aggravate the embolization by shifting them distally. Do you agree with that?
Yeah, that's why the repeated injections. You flood the area and you repeat it after 45 minutes to an hour. You do this at least 3 times. And this is the reason that you want to break an entire filler. You want nothing to remain there, especially if you're thinking of a vascular complication. Now, if you're dealing with a chronic issue, like a chronic nodule or something, it's different.
Yeah.
You may go very conservative, inject little bit, see, you come back and inject more. But if you're dealing with a vascular complication, you don't wait.
Yeah.
Time is essential.
So, how long should you wait before re-injecting the same area? After 3-4 hours, 2 hours, 8 hours? Suppose you are not getting the desired result.
With hyalase.
Hyalase.
So, if you, 3 injections is minimum, flood the area.
Interval?
45 minutes approximately.
45 minutes.
Yeah, in 3 injections is minimum if you're a large area, relatively large. Watch the area, look at the blanching, look at the turgor, look at the filling, look at all the signs of necrosis, venous and arterial. Many times we miss the venous congestion. So look at the reticular pattern if it's developing. If you feel it's resolving, then you can let the patient go home and call him next day morning and inject him. If you feel it's still not looking good, it's better to keep the patient there and re-inject after maybe a couple of hours to 2 to 3 hours. So it's a clinical decision. You have to follow what you see. It depends on that. And now, of course, with ultrasound, you can actually see the filler. So if you're going to see the filler in the vessel, you can actually go and inject. If you feel it's still there, you can go and inject more.
And if you go onto YouTube, you'll see interesting sort of discussion between myself and Dr. Tim Pierce, who was advocating using much more hyaluronidase than I would expect. Some people are using 15 vials of 1,500 units on the one patient on the one day, because they were expecting to get capillary refill time to drop to 2 seconds at the time. If you flood the area, as Viral has already said, you don't have to get your capillary refill time back to exact on that day. It'll come back over a day or two. If you get it down to, you know, below 7 seconds, down to 5, down to 4, it's probably enough. Let the patient go home, it will improve. But if you're flooding it to the extent that you're using up to 15 vials on the one patient on one day, I think that can cause problems to the patient, their own hyaluronidase.
Now, you had a vascular compromise. You have undone it by giving hyalase. And suppose the same patient comes to you after 1 year and he wants you to inject more. Will you be scared to do on the same patient, or will go ahead? Just practical question.
In terms of myself, most of the problems I see are related to 3 or 4 products. And it's always the same ones when they break down. Now, vascular compromise is obviously different, but we're left in a situation which is more important, because vascular compromise happens because the proceduralists happen to be unfortunate to hit a vessel. But if you're in a situation where you've taken out all of a product, maybe 2 or 3 mils out of a mid-cheek, and then you have to start all over again with another product to replace it, because the hospitals won't do that, you know, that's where the problems exist. So you'd need to have your choice of product. And certainly don't put in, there's 3 ones that cause the main problems.
Thank you, everybody. I had a lot of questions, but I think we are running short of time. So with due apologies to all our spectators.
Thank you so much. And with this, ladies and gentlemen, please put your hands together for all the esteemed panelists who were here on the stage. And I would request Dr. Viral to please felicitate our moderator, none other than Dr. P.K. Talwar. I would request you, sir, to please come right at the center of the stage so that we can felicitate Dr. P.K. Talwar. Thank you so much, everyone. Thank you. Okay, so ladies and gentlemen, now moving forward towards our next session. And before we start off with our next session, we have the lamp lighting ceremony because our chief guest is here, and we are also going to felicitate our very important award, that is the Lifetime Achievement Award from FADS. Now, for the lamp lighting, I'm going to invite here on the stage none other than our chief guest, Dr. Manisha Nijhawan. Can we have a big round of applause for our chief guest of the day? Ladies and gentlemen, please put your hands together for Dr. Manisha Nijhawan. I would also like to invite Dr. Vijay Kumar Garg, Dr. Dinesh Maur, Dr. Ganesh Pai, Dr. Vibhu Mendirata, Dr. S.N. Bhattacharya, Dr. Manisha is already here on the stage, Dr. H.S. Girgila, Dr. P.K. Talwar, Dr. K.K. Verma, Dr. V.K. Sharma, and Dr. Kailash Bhatia. So we have all the delegates here on the stage, and thank you so much, everyone. I would request you all to please come together for the group photography along with the lamp. So as this photography session is going on here on the stage, we can see all the important delegates here on the stage. All the FADS members are also here. Come on, ladies and gentlemen, give a huge round of applause to yourself. Thank you so much, everyone. Now I would request our chief guest to please stay back, and I would request the rest of you to please come down and settle down. Meanwhile, I would request Dr. T.A. Rana sir and Dr. Ramanjeet sir as well to please stay back. Dr. Vijay Kumar Garg sir, please stay back, and I would request you, the rest of you to please come down. So, ladies and gentlemen, we are going to present this trophy on behalf of FADS to our chief guests who are present here. For this, I would request Dr. T.A. Rana and Dr. Ramanjeet sir, to please present the award to our chief guest, Dr. Manisha Nijhavan was our chief guest for the day. Everyone, please put your hands together. And now, the Lifetime Achievement Award from FADS. We are presenting this to Dr. Vijay Kumar Garg. Can we have a big round of applause for Dr. Vijay Kumar Garg? I would request our chief guest, Dr. Manisha Nijhavan, to please say 2 words to all the members who are present here.
Good afternoon, all of you, and heartiest congratulations to all the organizers for FADS Congress. And today I am really honored to be here and standing here in front of you. And it's really a great privilege, honor for me. And I think this is the best platform for all youngsters to learn cosmetology. And as soon as they pass from MD, they don't know anything about the cosmetology, usually from the government colleges. So it's a great platform for all the youngsters. And I really congratulate the organizers for this. Thank you so much.
Thank you so much, ma'am. We had Dr. Vijay Kumar Garg for the Lifetime Achievement. Sir, we all want and wish to hear from you.
2 minutes. It's on the, first of all, I should be thankful to FADS Society who has honored me with this award, Lifetime Achievement Award. And really, Dr. Ramanjeet, the President, the Secretary, Dr. Jyotirmay, Vice President, and of course Dr. T.A. Rana, the main person who is in charge of the whole organization. And I'm really thankful to all to honor me with this award, a Lifetime Achievement Award for my work. And really I'm thankful to all the organizers and especially the president of this association, Dr. Ramanjeet Singh, and the vice president and the secretary, scientific secretary, and the main CEO, Dr. T.A. Rana, for honoring me this award. Thanks on my behalf. Thanks a lot. Thank you.
I would request once again all the people who are here, please, if we can all have all of you here on the stage. I will take the name once again. Dr. Denesh Maur, Dr. Ganesh Pai, Dr. Vibhu Mendirata, Dr. S.N. Bhattacharya, Dr. Manisha Nijhavan is already here, Dr. H.S. Girgila, Dr. P.K. Talwar, Dr. K.K. Verma, Dr. V.K. Sharma, and Dr. Kailash Bhatia, and Dr. Patrick Tracy. Can we have you please? Can we have you all here on the stage? Now I would request Dr. Ramanjeet sir to please felicitate all our guests and the delegates who are present here. So we are honoring with the medal. Can we have a big round of applause as we honor with the medal and present a shawl as a gift of honor from all of us. Come on, ladies and gentlemen, keep applauding as we present the medal one by one. Come on, ladies and gentlemen. Ladies and gentlemen, come on, show some energy and keep applauding for all the delegates who are present here and getting felicitated by FADS. So one picture, everyone together with the medal.
Now I would like to invite Dr. Viral on the stage because Dr. Patrick Tracy will be revealing his book, international book on complication on aesthetics, and this is happening right here over the stage.
So this is the revealing of book.
Now you can go ahead with your...
Oh, thank you. I wanted to present this to Viral. Him and I are friends a long, long time. We met in Greece originally, Mumbai, when he started his first clinic back 17 years ago now. And I've written many books, but this particular one has become a bit of a Bible in aesthetic medicine complications. We just signed a deal to China, where I have to go in 2 weeks' time to give me an award for this book, and they're translating it into Chinese. So I'm very heartened to give it to a good friend of mine for many years, Viral. Yeah.
Thank you so much. Thank you. And it's really an honor for me to receive the signed copy. Patrick has written so many books, and I remember first we met way back in Athens in Greece, where we went out fishing together, sailing and fishing. So, and then we've been friends for many, many years.
Fishing for what?
Well, that's for another day.
So thank you so much, sir. And once again, this one is from all of us. We would like to congratulate Dr. Patrick on the launch of his book here among us. Can we have a big round of applause? Thank you so much, everyone who are present here. Thank you once again. So now, ladies and gentlemen, we are moving ahead towards session D. And for that, I would like to invite here on the stage our chairperson, I would request Dr. T.A. Rana, Dr. Vibhu Mendirata, Dr. Manisha Singh, and Dr. Vinay Singh to please join us here on the stage as a chairperson for our next session. So we have our chairpersons coming up and joining us on the stage. Dr. T.A. Rana, Dr. Vibhu Mendirata, Dr. Manisha Singh, and Dr. Vinay Singh. So now we are going to call our first speaker for this session.
Thank you, sir. I must thank, first of all, the FADS organization, Dr. T.A. Rana, sir, Dr. Jyotirmay Bharti, Dr. Ramanjeet, sir, for giving me this opportunity to interact with all of you. I'll introduce you to you myself. I am Dr. Vinay Singh from Delhi, an IADVL member, and this year I am contesting for the post of National President IADVL. So need your valuable vote and support. I'm sure some of you must have received some of the flyers, my thoughts, what should be done and what is being done in IADVL and how we can improve for the common member. Although IADVL is a very big organization, but I need wholehearted support from all of you. This is my sincere request. Please vote for me. Thank you so very much. Thank you, ma'am.
Thank you so much, sir. And with this, we also wish you luck. Now, moving ahead towards our very first speaker, Dr. Shreya Das Jain. Can we have a big round of applause? And I would also request our chairperson to please introduce our very first speaker for this session.
So, a very good afternoon to one and all, and I would like to start this session by introducing our speaker for the session, and who's Dr. Shreya Das. And she's founder, director at All Skin at Indore. She's a consultant dermatologist, and amongst her important achievements, we have various presentations, and she has a couple of publications as well. And anti-aging treatments and lasers, injectables, they constitute some of her interest areas. So I welcome Dr. Shreya Das, and you may kindly address the audience.
Good afternoon, everybody. I'm Dr. Shreya Das Jain. I'm from Indore. I would like to start my talk. My topic today is rheology and physiology of botulinum toxin, along with advanced indications. Yeah. So, I have divided my talk into these three separate sections only. So I'll first discuss the physiology, then rheology, which is interesting because we are not talking fillers, we are talking toxins here. So the flow of the product and the longevity of the product and the side effects of the product and few advanced indications I'm just going to enumerate because the next speaker is going to take that up in detail. So this is how I've divided my talk. The first physiology part is basically the introduction types, dose equivalence, reconstitution, storage, mechanism of action, most of which we already know. So I'm going to just brush through the slides. The later half of the talk is related to diffusion, adverse effects, immunogenicity, why effects of botulinum neurotoxins are irreversible, and the factors which affect and the factors which can increase longevity. So we all know that botulinum neurotoxin is derived from Clostridium botulinum, anaerobic spore-forming gram-positive bacillus. There are 7 distinct subtypes, A to G, out of which A and B are the ones which are clinically relevant, and A is the most potent. Why botulinum neurotoxins are unique? Because they are very particular. They are natural products. They are derived from living bacteria Clostridium, and they are also pharmaceuticals. Presentation is not complete. It's not showing complete. Few sides are not visible. Sorry? Okay. So these are the few FDA products, FDA-approved botulinum toxin products. We all know this chart. I have just put it here for reference and also to show you one point that I have highlighted. When we talk about onabotulinum A, which is Botox by Allergan, abobotulinum A, Dysport by Ipsen or Galderma, incobotulinum toxin A by MERS. These are the 3 that we use clinically most often. As you can see, in clinical characteristics, the minimal migration of toxin from injection point, which is around 3.1 centimeter square, is for Botox, which is onabotulinum toxin A, and it's similar for Xeomin, which is incobotulinum A. Abobotulinum, Dysport, is it migrates further from injection sites as compared to onabotulinum and incobotulinum, and that area is 4.1 centimeters square. Why this is relevant is that's how we discuss the diffusion of the product, and we know whether the product is more likely to diffuse into adjacent muscles and cause any further side effects, adverse effects. So dose equivalence is very important because we've just discussed that there are multiple types of botulinum neurotoxins and multiple brands. So they are not interchangeable. You can't use the same number of units for Dysport as you use for Botox. So this is again important to make sure that we are not overdosing the patient and hence leading to diffusion and adverse effects. So Botox, Xeomin and other Asian botulinum neurotoxins like Ciax, Neuronox, Stenox, they all are supposed to be, the dose equivalence is 1:1. They are all supposed to be the same units. But Botox as compared to Dysport is 1:2:5. So you have to inject accordingly. And most of these we know are available in 50 and 100 unit vials. And Dysport is available in 300 Spaywood units vial. Now reconstitution and storage, it comes in as lyophilized powder in sterile vials stored and at 2 to 8 degrees, can be used up to 24 months. 100 unit is reconstituted with 2.5 ml of sterile normal saline, and 300 is reconstituted with 3 ml. So the important points are the vacuum inside the vial is the test for sterility, so it should always be checked. Avoid shaking and agitating the vial to prevent bubble formation. We always have to inspect for any particulate matter or any discoloration if we see in the vial. And after reconstitution, it has to be stored and stored at 2 to 8 degrees. So once reconstituted, so most of them come as a single patient use vials, but if we take care of the sterility part and the temperature regulation, then we can definitely use them in multiple patients. Reconstituted botulinum toxin A may be stored for a period of at least 4 to 6 weeks at 2 to 8 degrees temperature without any detrimental effect to its sterility or efficacy. Now, mechanism of action of botulinum toxin, neurotoxin A. So we know that in normal muscle contraction, acetylcholine vesicle docks at the nerve membrane, and acetylcholine is released into the synaptic cleft. It binds to the receptor on the muscle, leading to muscle contraction. But under the effect of botulinum neurotoxin, this release of acetylcholine is inhibited, and that's why the muscle fails to contract contract, and there's muscle paralysis. Eventually, how does the effect reverse? By the sprouts that emerge, and there are at the affected nerve terminals, and synaptic activity returns. So there, I have a video showing the mechanism of action. I'll come back to it if we have the time. Let's discuss the rheology first. This is the same mechanism that I just showed the diagram of. Yeah. So, yeah, rheology of botulinum toxin. So when we talk rheology, we mostly discuss fillers because rheology means the flow of the product. So when we are talking flow of the product in terms of botulinum toxin, I wanted to discuss a couple of things. Of course, the first will be the diffusion and hence the adverse effects of the toxin. So we all know that minimal effect is seen even at short distances from the site of injection, which is in fact the property because of which Botox or botulinum neurotoxin injections are extremely safe procedures to do. But possibility of local diffusion or potential leakage into systemic circulation always exists, which basically depends on the volume and speed of injection, dose and site of injection. We are going to come to this again. The paralytic effect outside the target muscle is due to the local diffusion and is generally limited to the adjacent muscles. How we discuss complication of botulinum toxin, that adjacent muscles migration leads to brow ptosis or heavy brow or frozen face. However, it should be considered that the diffusion of toxin beyond the site of injection and beyond the adjacent muscles also is a possibility, but it is accompanied by its progressive dilution because of larger and larger volumes in extracellular spaces. So the injected toxin becomes so diluted that it is no longer capable of binding to the presynaptic membranes. And so that is the reason we don't see a lot of adverse effects of toxin, not to the few to the adjacent muscles and rarely to far off muscles and systemic circulation. Now about immunogenicity of the botulinum neurotoxin formulations. We know all of them are poor antigens, particularly with respect to the cousin molecule of Clostridium, which is tetanus neurotoxin. Now, still there are few factors which are involved in the immunogenicity: product-related factors, treatment-related factors, and site-related factors. So product-related factors are the manufacturing process, the antigenic protein load, and the presence of toxin, denatured toxin, acting as a toxoid later. So we know that the antigenic protein load, like in zeomine, which does not have this, is less prone to develop an immune response to the product. Treatment-related factors such as toxin dose, frequency of injections, prior exposure via routes can impact the immunogenic response as well. And site of injection, so if we are injecting, let's say, neck, which has a lot of lymph nodes, so there are more chances of developing an immune response. And of course, to minimize all of this, our thumb of rule, anyways, we follow it any which ways, but the reason why we follow it is to prevent immunogenicity and adaptive immune response, is to use lowest effective dose and try to have longest clinically acceptable inter-injection interval. So the interval between 2 sessions should be as long as possible, and the dose per treatment session should be as less as possible, which does not mean doing suboptimal doses, which means not overdosing. And this is one point that I wanted to put forward because we were discussing rheology, that why the effects of botulinum neurotoxins cannot be reversed. It's a unique feature. Once the toxin has reached the interior of neurons, its activity cannot be reversed until it has naturally ceased, because we don't have any drugs which are permeable to the neuronal plasma membrane and which are very effective in blocking their metalloprotease activity. Now, this is a very important slide. The factors on which the longevity of the toxin depend. So, duration of paralysis, it varies extensively, but majorly it depends on the dose. So, as I mentioned earlier, the optimal doses. The longer results are expected, of course, as compared to a patient who's been injected suboptimal doses. Then the second is location and type of muscle. So, few studies have mentioned that forehead results last longer than glabellar results. Also, heavier muscles and the muscles which have less mobility, like masseter, we know the results last longer, 6 months, 8 months. Then lighter and more mobile muscles like mentalis, nasalis, where it is 3 months, 4 months. The third point is supplements. These are few recent studies, but the data is insufficient to make any claims. But few studies have mentioned increase in longevity with zinc supplementation. Treatment repetition is one point that we all know, that there is an improvement in the longevity of the results with each treatment cycle. But I would like to point here, of course, only if the patient does not end up developing antibodies to the product. So in a normal patient who has not developed antibodies, repetition cycles, so then with each treatment cycle, there is an improvement in the longevity of the results. It also the longevity also depends on the type of nerve terminal. So if we are addressing hyperhidrosis, we know that the results last longer, 8 months, 9 months, up to a year, as compared to if we are injecting glabular complex. We have to repeat it in 4 to 6 months at max. So it depends on the type of nerve terminal as well. And the reason why I've put brand in the end is because of the lack of unbiased and not unfunded studies. But yeah, recent studies have mentioned that abobotulinum A, which is Dysport, is likely to be more effective, and the longevity is more than Botox.
Dr. Shreya, finish your talk within a minute, please.
Sorry, yes. This is my last slide, which is advanced indications of botulinum, which will be covered in the next talk. That's it, sir.
Thank you. Thank you very much, Dr. Shreya. Nice talk.
Thank you, sir.
Thank you so much, ma'am. And now I would request the chairperson to please come forward to felicitate Dr. Shreya Das Jain. Please put your hands together as you present this. Okay, so ladies and gentlemen, moving ahead towards our next speaker, and we are going to call here on the stage Dr. Kiran Hebalkar. Can we have a big round of applause for Dr. Kiran? Meanwhile, I would request our chairperson to please introduce our next speaker.
Good afternoon, everyone. Would like to introduce our next speaker for today, Dr. Kiran. She's the Director and Chief Dermatologist at Kiran's Clinic, Andheri, Mumbai, and practicing aesthetic for the last 18 years, and she has special interest in all the laser procedures, Botox fillers, and she's a trainer for advanced thread lift as well. Over to you, Dr. Kiran.
Good afternoon, dear friends, and I am Dr. Kiran from Mumbai, and I'll thank the FADS team for giving me this opportunity. So today's my topic is about the botulinum toxin injection techniques and markings, which is a very important point because if you master in this the marking and injection technique, so you will have less side effects and your results will be great, and the dosage will definitely vary from each patient to patient, but then you can always adjust your dosage depending upon your patient's need. So the marking and techniques, definitely you need to master and follow them properly. So as already Shreya has completed the dilution, so I'll not go in details. So my points will be here. Use always a fresh normal saline, never use a stored one. And the dilution, the suction should be very slow. The vacuum, because the vacuum if it's not good, then you have to discard the vial because it's not stored properly and it might have contamination. So this is the same video of, so I'll just skip this. So let's go ahead to the horizontal lines, which are the frontalis muscle, which is responsible for the creation of these horizontal lines. And usually we inject with the BD syringes, which is of 30 to 33 gauge needle. And the depth of the penetration here will be subdermal or intramuscular. And usually at these points, we inject up to 4 units at each points. So 5 points we have marked. I'll show you how the marking is done. So this is the temporal fusion line, and in between is the spread of the muscle. And we ask the patient to raise the forehead. And we mark the lateral limbal line. So in between this, we will give the toxin. And the markings are done 2 centimeters above the supraorbital rim, so that we don't inject into the fibers of the lower frontalis, which are the elevators, and we don't get a frozen look to your forehead. So the marking should be done 2 centimeters above the supraorbital rim. And then the center point is done in the medial part, and the in between is injecting the third points are injected, third, fourth and fifth. So here I am injecting 4 units, but her muscle is very small, thin, so I'll be injecting only 2 points, 2 units. So this is the injection technique. So we'll clean the area. Audio नहीं है उसमें. And we should get a nice bleb so that you feel that you are in the good plane. If you are deep, the bleb will not be there. So this is how the forehead injection is given. Now comes the glabular lines. So usually glabular lines, which is the common 11 line, and the muscles which responsible for this is procerus and corrugator. Again, these are the 5 points where we are injecting. So in the procerus, the depth of the needle injection is usually deep, middle to deep, and in the body of the corrugator, it's usually deep, and in the tail of the corrugator, we inject very superficially, and I'll show you how the markings are done. And we inject around 4 units in each points. Again, the units can vary depending upon the muscle fibers, how bulky they are. So this is the marking. Danger area in the frontal part, which will cause the ptosis of your
lid.
So now the injection technique for the procedures.
Go full depth inside. The needle should go inside. So it's
For females, we usually give 4 units. In men, we can go up to 6 to 8 units. And you can divide the injection also in 2 points, depending upon the belly. So this is the corrugator injection.
So when we are injecting the corrugators, so when you are injecting in the body, we should hold the muscle from below and go deep inside fully, so that you are injecting into the muscle and avoiding the frontalis fibers. So I am injecting now 3 units. You can go up to 4 to 6 units in this area in men. And then I am in the tail, I am just pulling and I am just injecting very superficially 1 bevel tip.
So just the bleb has to go and you just put, it's just very intradermal, so don't go very deep. So this is the corrugator injection we did. Now comes the crow's feet, which is again caused by orbicularis oculi muscle. And here again the BD syringes are used. These are the 3 points which are injected on either side, and the dosage is again around 4 units. Again the dosage will vary from the person to person. So total 24 units are injected on both the sides. So here are the crow's feet markings.
So now we'll come to the crow's feet. Smile. We'll ask the patient to smile. And from the orbital rib, around 1.5 centimeters or 2 centimeters lateral, that is usually we place 1 finger away. You can mark the central point for the crow's feet and draw a vertical line, and then 30 degrees up you will mark the second point, and 30 degrees down you will mark the third point. Here again you have to be careful that you are not going deep, otherwise you will put the toxin into the zygomatics major, and which will cause the ptosis of the cheek. So you have to be very careful and very superficial.
So again the marking technique, the injection technique.
So already we have done the marking, the center one. Here we can inject very superficially in the intradermal plane. So we are just targeting the superficial fiber as the muscle is very thin. And now in the upper part.
So now comes the bunny life. So visually it's caused by the nasalis muscle. It's very important to treat this area, because once if you do the forehead, glabellar lines and the crow's feet, when you are smiling, then these are the muscles which becomes more prominent and looks little funny. So it's always to target this muscle, maybe with small units, but always try to treat it if it's possible. So markings, again I'll show you.
Nasalis, just nose work, nose work. So you can see the fibers of nasalis muscle. You can just inject in the center.
So very simple, superficially we have to just inject.
So now we are doing the nasalis. We have done already the marking. We just clean it. We'll ask her to crunch the nose.
So here again around 2 to 4 units we can inject depending upon the activity of the muscle. And very superficial intradermal, again taking care of not injecting deep, otherwise you will inject LLSAN. So again the crooked smile can come. So now comes the masseter, which is one of the favorite, and we do usually for the slimming of the face. So this is how we do the markings.
So once we have completed the upper part, we come to the lower part of the face. In the lower part, the toxin is usually used to do the slimming of the jawline. So for slimming, just clench your teeth. So we can see the bulb. Now we'll just do the markings. So below the ear lobule, draw a horizontal line up to the angle of the lip, and a vertical line which will be the anterior border of the masseter muscle. So behind this, in this rectangle, you can give
mark 3 points. So you have to be careful because you don't want to hit the risorius muscle which starts from the fascia of the masseter muscle. So you have to be very low and very deep so that you are targeting the deep fibers as well as the superficial fibers of the masseter. So I'll show you the injection technique. So here I am using 8 millimeter depth needle because we want to go a little deeper, and we have to ask the patient to clench and we have to give deep injection. So either we can use 8 millimeter or the tuberculin syringe so that we can go deeper and then we inject. So we can give up to 20 to 25 units if the muscle is heavy. Again clench. Relax. Clench. Relax. So making sure that you are injecting deep into the muscle. So next comes the marionette lines, which is when you get a sad smile or the lips are drooping. So which is usually caused by the DOA muscle. So we can ask the patient to make the sad face and we can just check for the DOA activity. This is for the marking. DOA, which we usually do in the females who have a droopy corners of the lip. So we'll ask the patient to just make sad face. Sad face. Yeah. So now you can see the dimpling here. So this is the DOA muscle. We have to be careful of the DLI muscle which runs deep and below the DAO. So we have to treat the DAO very superficially and laterally so that we are not interfering or going inside the DLI muscle, which will cause the lip pull. So and that will cause the asymmetry of the lips. So now I am injecting the DAO very superficially and laterally. So usually 1 centimeter lateral to the lip angle and 1 centimeter down. We'll be injecting very. Here you can inject up to 1 to 2 units. 1 unit, not going deep. Very superficial. You still see the lip. Usually pointing the syringe outside and not coming like. Yeah, this is very important. Always go from the other side and inject. The DLI. So now comes the dimple chin, which is the mentalis action of the mentalis muscle, which will increase the mentolabial frowning with the groove goes deeper, and we get the dimpling of the chin. So here again we'll see the markings. Now we come down to the mentalis. Again we can see the mentalis is the muscle which will pull the chin upward. So we'll draw a perpendicular central line and we'll just inject medially with the needle pointed towards the center, the toxin on both the sides. I am injecting the mentalis. You can see the upward. Again on the either side you can inject up to 3 to 6 units. The central line, going deep, medially pointed. Stay nearer midline and stay deep. So you will not have. Usually we inject at one point also, but then some fibers of the lateral side of the mentalis remain, and then you can get one side dimpling more on the mentalis. So next we have the platysmal bands, and which is very favorite to give you a slimming face, the jawline, and it gives you a nice lift to your the jawline and gives you a relaxed look to your neck. So this is how we will do the markings. So for the jawline sharpness, so we do the Nefertiti technique. We'll ask the patient to make E. In her case, it's not so prominent, but we can still see the fibers coming here. So this is the fibers which we have to target, and put few units down and above the jawline, which we are targeting the platysmal muscle and the platysmal band here. So this is the Nefertiti technique where we will be injecting the toxin. For doing Nefertiti, we usually go below the jawline and we are not crossing medially to the angle of the mouth, so we can draw a perpendicular line. Because we again don't want to inject into the DO and the DLI muscle, so we have to be very careful. 2 units here. I've taken
10 units total.
So I am injecting around 10 to
So
12
here we are
units you
trying
can
to
inject
treat
in
the
this.
Platysimal fibers.
Intradermal
Here
injection.
also superficially, this is the intradermal injection. We are trying to target the platysimal.
And then again in the lateral
Cause the
platysimal band, you can inject up
and
to
you can
6
give
to
a
8
sharp
units. In her case, it's not so prominent, so I have not injected. So next comes the platysimal bands.
Now again, if you are trying to treat the neck, so we can see this platysimal band, the central branch, which gives the two bands. So this we can inject directly into by holding the bands, we can inject inside the bands and we can relax these bands, so it will give you a softer and a nice tighter look.
So this is how we have been injecting.
To do E and then we can inject holding the band, we can put.
At each point you can inject around 2 units. So usually if the band is very strong, so you can go up to 8 to 10 units. So again with the trap Botox is very common these days because they want the slim shoulder line. So this is usually injected into the trapezius muscle. You have to take the marking, the joint and the neck. There it's injected. Around 5 units you can inject into the holding the muscle. You can ask the patient to shrug and then you can inject. But don't go beyond the shoulder joint. Just go medially after checking the trapezius muscle. And thank you.
Thank you, ma'am, for showing us in detail how to mark and how to inject. And any tips which you want to give to the audience while injection? Like you already said that if you are injecting on the left side, you have to stand on the right side. That is very important.
So again, when you're doing the left side of the eye, orbicularis come from the right hand side and do, because then your needles are directed away from the extra-auricular muscles so that you're not injected deep in the muscles. Again, similarly, when you're doing the jawline, come from the other side and do. And I think specifically marking and the depth, if you are keeping it properly, you will not have any side effect.
Thank you so much.
Thank you so much, ma'am. And I would request you to please come at the center of the stage. Meanwhile, I would request the chairperson to please come forward and felicitate Dr. Kiran Hebalkar. So, ladies and gentlemen, as we felicitate, can we have a big round of applause for Dr. Kiran? Thank you so much, ma'am. I would request Dr. Ganesh Pai to please come forward here on the stage to felicitate our chairperson. Okay, so Dr. Vibhu Mendirata will be presenting So, ladies and gentlemen, we are felicitating Dr. Vibhu Mendirata. I would request Dr. Ganesh Pai to please felicitate Dr. Vinay Singh as well. Thank you so much, all the chairpersons who were present here. Thank you so much. Dr. Manisha Singh, we are left behind with one more felicitation, that is Dr. Manisha Singh. So, ladies and gentlemen, moving ahead towards our next panel discussion, and for this I would like to invite here on the stage Dr. Jyotirmay Bharti. Can we have our moderator here on the stage? Everyone, please put your hands together for our moderator. I would like to invite the panelists here, Dr. Shreya Das Jain, Dr. Kiran Hibalkar, Dr. Deepti Dhingra, Dr. Gulshan Panisar, Dr. Smriti, Dr. Viral as well. I would request you to please come up.
I would like to invite Dr. Viral Desai, as most of our panelists are not available today, and Dr. Smriti Srestha, please, on the dais. Dr. Shivani. Okay. Can we have Dr. Shivani? Yeah. Dr. Gini Chabria. Botox है. नहीं अच्छा. Dr. Kiran. How do I change the slides? Excuse me, slide कैसे change होगा? Through which we can treat so many things which when we know the anatomy very well. And ideally speaking, this is one of the safest injectables in our practice if we know how to inject, okay? So what complication can arise if you have any of these problems like dilution problem, or if you are a little unaware about the anatomy? So we have our expert panel here and we'll be discussing one by one complications here. So these are the complication, this is the problem you can treat with just this one miraculous product, but if used cautiously, there is no complication, but if not, then what can happen? So what can go wrong with forehead treatment? If you are doing the forehead treatment, that is, you're treating the frontalis muscle, what can go wrong? Complications are brotosis, residual upper eyebrow wrinkles, and spock brows. So I would like to tackle this and ask you one by one, why brotosis happens? Dr. Gini?
Hi, good evening, everyone. Good morning, everyone. Rather good afternoon. So brotosis generally happens if you are injecting your frontalis muscle, okay? And if you are injecting the lower fibers, then the ptosis can happen. And sometimes, so that's why there is this recent line of convergence which has come up. So there's a beautiful paper by Dr. Sebastian Cotofona, and which says that you always need to divide the forehead into upper 1/3 and lower 2/3, and try to have your injections in the upper 1/3 area. Then you will avoid this problem of brotosis. But sometimes we see that, rightly said the second, that the residual upper eyebrow wrinkles. So if you see, so maybe a little dose of toxin you can put maybe in the lower 2/3. Don't be very low, so you can avoid that as well. Yeah.
Right. Anyone who wants to add something to it?
So yes, brow ptosis is the most common side effect that I have seen. If we if we stay clear 1 centimeter above the supraorbital rim, if we are staying clear of the orbit, then getting a brow ptosis is not very likely. And also, frontalis is the only elevator. Rest are all depressors, so it's always better to go easy on injecting the frontalis and not giving too many injections. You can always give a lesser dose and correct the patient on a follow-up. We can always do a 2-week follow-up once we've seen the final result of the Botox. So avoiding the supraorbital rim would be the most important thing here.
Right. Anyone on Spock brows?
Yeah, so for Spock brows, it is when we have treated the medial fibers of the frontalis and left the lateral
Fibers of
fibers of
frontalis
the
muscle.
frontalis.
Yeah.
And so there is elevation at the lateral and depression at the medial aspect. And so it gives that quizzical brow kind of look, which is very unacceptable to the patients because it gives an angry look,
right,
funny look to the patient.
Perfect.
And
So
to treat it, you just inject
lateral fiber of it,
fibers
you
and
inject,
it
yeah,
gets better.
and you can
Yes.
take care of it. So this is the brotosis, how it looks. So here you can see it's not a litosis, it's a brotosis. The eyebrow has drooped down, okay? And
one thing.
How can I play this video? Ready? Yeah. So this is how brotosis will... Brotosis is the situation where your eyebrows droops. Why it happens? Because frontalis, raise your forehead, yeah. So you can see frontalis muscle is the only muscle of the face which lifts the forehead. So if you are injecting, relax it, divide your forehead muscle into half and don't inject the lower fibers of frontalis muscle. If you inject here, that leads to complete drooping of the frontalis muscle and can lead to abnormal eyebrow shape, flattening of the eyebrows and brotosis. So the idea is to inject on the upper and middle part of the forehead. Ready? Next week. Yeah, so this is Spock brows. All right, we were talking about here, we forget to inject the lateral fiber of the frontalis muscle, and that is when you get this kind of picture. So as the doctor suggested, you have to inject later on. You can call the patients after 7 days, and if you find there is Spock brows, then you inject where? You can guide us.
We need to inject, we have to mark the anti-Spock point and inject 1 to 2 units depending on the deficit or the Spock. Also the second thing, sometimes naturally most of the humans have asymmetry. So while injecting the first initial setting itself, we have to see that the anti-Spock point units required might be more as compared to the other eyebrow. If you see, find there's asymmetry.
So what is anti-Spock point? How do you decide?
So we can mark the lateral eyebrow border and then just go 4 centimeter above, below the forehead, mark it and just inject superficially.
Ideally, when you see Spock brow, tell the patient to raise their eyebrows, and wherever you are getting the peak, inject 1 to 1.5 centimeter above that line, just 1 to 2 points of botulinum toxin, right, Dr.
Yeah,
Ganesh?
yeah, rightly said by you. And sometimes female wants a more arched brows. So
Yeah.
at that time, you can just leave the lateral fibers or inject lesser unit, like
Units.
maybe a 1 unit. And I always call my patient for a follow-up after 7 days, just because sometimes it do happens when they never animate themselves and see in the mirror. But if we have injected, and we should always call them for a follow-up so that we can have them those animations and we can see, and if we have to correct, we should correct it.
Also, we should, since most of the time our face is some degree of natural asymmetry is there. So we should point it out to the patient at the time of injecting, because the brow may not be symmetric. One brow may be higher and the other brow may be lower. So we have to take that into account.
Right.
One thing I would like to point in the complications of forehead injections, what I have seen of late or what I have started observing, that few patients do have flattening of this forehead when they are when repeatedly injecting. So this is one thing what I'm observing of late for patients who are
Yes.
getting repeated injections. Yes.
Yeah.
So I think there comes the role of your skin boosters or maybe a little filler, because you're
And give a break between 2 injection
Yes,
points.
it should be
Ideally,
proper.
it is, we recommend every 4 to 5 months. But if you see thinning or flattening of frontalis muscle, you can always advise them to wait for a little longer, like a year, and then get it repeated. Yeah. So now coming to the glabellar part, what can go wrong when you are injecting the glabella, that is procerus and corrugator muscles? Lid tosses. So I told you this is different than brow tosses. So what happens and why it happens, Dr. Kiran?
So I already mentioned in the injection technique that if you are injecting into the corrugators and your depth is not correct in the tail, if you are going deeper, so the toxin can go into the levator palparis superioris muscle and it can give you this ptosis. And it's very difficult to treat. It will take 2 to 4 weeks to go on its own, but we have to give them some drops so that, which are not easily available, but then, yeah.
It also works for few hours, so the patient needs to keep on repeating every 2 hourly the drops so that it can
Yes.
lead to at least relaxation of the
And at least
lid
for 5
muscle.
to 7 days.
More
Yeah.
than that, till the effect reverses. So it
Okay.
is almost for 2 to 4 weeks. It's short, yes.
Yeah.
So actually, it's not so easy to get it, the lid ptosis. It really points to a faulty injection. Because if you are giving less dose and the desired dose at the desired point, the chance of it going to levator palpebrae superioris is very low unless you puncture the septum.
Yes, it's
orbital
negligible,
septum.
but it may happen. So,
So-
this is a very recent picture which I showed you. I had an Insta post also on this, because this is, she is a, what do you call, who posts?
Influencer.
Influencer. She is a very famous influencer, and her thing got wrong, and she posted it all over the media, you know. So that is where I told the, you know.
So we can use nafazoline and phenylephrine
Yes,
drops,
apraclon, yeah.
2 to 3 times a day, and because those are alpha adrenergic agonists and cause a little bit of pupillary dilation as well.
Yes, so it happens because of diffusion of the Botox into levator palpebrae superioris, which happens because of your little more lateral to the injection point and you are deep, because the tail of the corrugators should be injected little superficial, you know, and units should be little less.
So I think here the thumb rule should be, because we know about the diffusion of toxin. So whenever we are injecting, so draw a mid-pupillary line, and whenever you're seeing even the tail is crossing that, so I think we should try to limit ourselves.
Yes.
Never cross the mid-pupillary line.
Yeah, don't cross the mid-pupillary line. Yeah, that's
And
the...
be above the supraorbital rim when you are injecting, particularly your corrugators.
Yes. Can we play this video? Drooping of the lids is drooping of lid and not the forehead muscles. Here your lid droops because of the treatment of glabular reason, that is your procerus and the corrugator muscle. So if you cross the midline where the insertion of levator palpebrae superioris is attached, if your injection point crosses this area, this diffuses into that muscle and can lead to drooping of the lid. So this is different than brotosis. Always mark drooping of the lids. Next slide. So what to do? There are two techniques. One they have already disclosed, that is apraclonidine. You can put eye drops every 2 to 3 hours until unless the symptoms has reversed. The second treatment is injection of Botox. So you mark the levator palpebrae superioris muscle and you can inject just 1 unit of Botox on both the sides. Sorry, I forgot to make the video of that, but you draw a line from mid-pupillary line to the lid in a triangular fashion, and wherever it is on the junction of the eyebrows, you just inject 1 unit very superficially. That reverses the symptoms. It elevates the lid to a certain extent. So it can give an instant result to the patient. So in male, how do you inject, and in female? So in female, you inject in more arched manner so that the eyebrows draws little up and backward. But in male, we inject in a very parallel and horizontal manner. Now what can go wrong if you are injecting the crow's feet? Diplopia, ecchymosis, which is not a big issue, dry eyes, and corneal exposure. So can we have our opinion, our panel's opinion, why we get diplopia?
Diplopia is when the toxin migrates to lateral rectus, and it usually happens
extraorbital muscles, yeah.
Yeah, so then you're too close to the eye basically. You've not taken the appropriate margin that is supposed to be taken from the orbital rim.
Yes, and what are those margins? How do you mark the area for crow's feet? Can you enlighten our, delegates for that?
So you feel the orbital rim. And you can mark 3 points which are at least 1 centimeter away from the orbital rim, and then inject. And sometimes if the crow's feet is too marked, you can have a more lateral point, but usually it's 1 centimeter away, and always point your needle bevel away
from the orbital area.
And it is a superficial injection. You can kind of raise a bleb. It should not be a very deep injection.
Very deep injections, right. So if you are injecting it well, if you are knowing the anatomy and you are respecting the margins and all the things considered, actually you don't get any diplopia ever. I have not seen any case so far in 15, 16 years.
Very unlikely complication.
Very rare complication, but it may happen, right? So this is ecchymosis, which happened because of wrong injection, maybe near vessels. Do I need to show the video? Can you show that video? Injecting crow's feet, you have to be very careful that you have to be 1 centimeter apart from the orbital margin. So always palpate your orbital margin, and 1 centimeter from that, always inject over this area. If you go inside, it can diffuse into extraocular muscle and can lead to diplopia, which is a complication due to injecting over the crow's feet line. When injecting, tell the patient to again frown please, and inject 1 point over the lateral part of the eyebrow, 1 in the center, and 1 equidistance from that part. That is how, okay, fine, relax. Next slide. So you're in. So treatment of crow's feet, they have already explained. I have shown you the video, so I'm skipping this part. And this is how the results looks like. You can inject little further also if the lines are little deep, but the injection should be very minimal, like 0.1 unit 0.5 units, right? If I'm not wrong, or you can do the mesobotox. So what can go wrong when we are, yeah.
Two more things might happen when you inject your orbicularis oculi. One, maybe cheek doses.
Yes, yes.
And because if your injection is quite low.
Little low on the zygomatic muscles, yeah.
Yes, so your zygomaticus muscle may be affected. And one may be ectropion when you inject
Injecting
the lower eyelid.
medial, yeah, lower
So
eyelid.
if the dose is high when you're injecting, so if you're targeting your lower eyelid muscles, the injection point, your units should be like 1 or 2 units, not more than that.
Not more than that. But few have suggested 5 units. You can go up to 5 units also.
I have
but
never
I don't think that's a good
I don't
idea.
have that courage. I don't know whether someone has done, but I don't have that courage to go up to 5 units.
Yeah.
Two more, honestly. One is smile asymmetry, if we are too
Yes.
medial and low. And then one is something known as shelf effect, where if you've injected a lot of product, the skin also on the around the periorbital area becomes immobile. So when the patient is smiling, the cheeks elevate and the whole
Yeah,
the lower
it
face is
pulls.
moving, but this area is not moving. This is known as shelf effect.
Yeah.
That is also very common if we inject higher doses.
Right, we are getting so many good inputs.
One more thing is that sometimes it's not exactly lid ptosis or there's lid tardiness. The patient feels heavy.
Yeah.
And it is more advanced towards the end of the day. So that you'll have to actually just wait for the effect to wean off. Maybe 2 weeks, 3 weeks.
Yeah.
And you have to counsel the patient at that time.
And meanwhile, your muscle also get, used to of
Used
that,
to, yes.
and it compensates for the droopiness and heavy feeling.
With feeling heavy.
Yeah. So, when you are treating bunny lines, what complication can happen? Nothing much, ecchymosis and hematoma. Anything else we would like to mention?
LLSAN, if you are too lateral, injecting into your LLSAN.
Yes.
So it can lead to a little bit of smile asymmetry.
Yeah, the lip of that side will droop down.
Lip ptosis.
Yeah. So this is the point for bunny line treatment. Maximum dose 2 to 5 units each side. If you do that, there is no complication. And this is how you inject. You tell the patient to frown, and wherever they are developing these lines, you can inject 1 to 2 units. What can go wrong when you are treating marionette lines? Generally nowadays, this is very common procedure we are doing as an advanced Botox. And people, instead of going for fillers, they are coming for Botox. So what can go wrong when you are treating the marionette lines? Doctor, any one of you?
Smile asymmetry?
Yes,
Most
crooked
commonly?
smile, drooling of saliva.
Drooling of
But
saliva.
why it happens?
So we are supposed to inject a DAO, but if in case we are more medial and deeper, we can end up injecting DLI. So
yes,
that's why all these complications can happen.
Yeah, so this is when you smile, your smile gets asymmetric, that is crooked smile. And this happens because of diffusion of the Botox into DLI. Can we show this video? For the Nefertiti lift, that is sharp jawline and dimpling of the chin. Can you clench your... So this is the dimpling you can see over here. For that you can inject into mentalis. What happens when you do Nefertiti lift, or you are trying to correct the DAO, or you are injecting the mentalis? The problem is the same, that is crooked smile. Can you smile? So one lip goes up and one lip goes down. Why it happens? When you are injecting DAO, depressor anguli oris muscle, it diffuses into DLI, which goes like this. And that is the elevator of your lower lip. So when you inject this, this goes down, and while laughing, it gives you asymmetric smile. Same happens when you are injecting mentalis. So if you inject, I think next video. For the Nefertiti lift, that is sharp jawline. Next. Similarly, when you are injecting for mentalis, you have to be a little lower and over the mentalis muscle, and the injection should be deep. Don't go a little higher up, otherwise again it will diffuse into DLI muscle and can lead to asymmetric smile.
Next slide.
Same happens similarly when you are injecting for...
Next slide.
So this was the complication which was happening if you are not cautious injecting marionette line or Nefertiti lift or the mentalis muscle, asymmetric smile, and patient can complain of drooling of saliva and the food while chewing.
I just want to add one thing here.
Yes,
DAO is a very complicated muscle. Nowadays, I prefer injecting more of your fillers in that area, which gives a lot of good myomodulation. And I think for that 2 units or 4 units, you can't go beyond, I think, 2 units
Yes.
in each side. You are actually risking the patient's asymmetric smile while injecting DO is quite a common thing. The
Yes,
other
very
thing,
common procedure. So unless you are very thorough and you have been
Yeah.
injecting for years, don't try that. That's
I
the
have
very
still
tricky.
come across 2 to 3 patients, even though knowing the anatomy, marking it well, but I have come across. So I do less. The other thing, even if you're injecting it well, sometimes patients are so used to with their normal smile, even there is no smile in asymmetry, you have injected properly in your DAO, but still they don't like that smile.
Yes.
This is also what I've observed. So I prefer doing fillers in that
And
area.
sometimes they complain of weakening of the muscles, like when they are doing gargle or they are washing their mouth, they feel their muscle has become little weak, to perform those sipping things gets difficult. But it helps, obviously, if the lips are drooping too much. So if you inject 1 to 2 units of Botox, it helps in even fillers to stay longer and give you better result and better augmentation and lifting of the drooping lips.
And also people who cannot afford fillers.
Yes.
Then we
It's
end up, because it becomes a lot cheaper option.
Yes.
And I think before injecting, we should always assess the strength of the muscle, how much they are active. If they are really active and they're pulling your angle down, then only go ahead. Otherwise, don't take the risk.
Yes, true. So we have learned, so this is how, if the angle of corner of lips are drooping, 2 to 3 units of injection superficial in the DAO muscle can help tremendously. Cobblestone chin, same, you inject mentalis deep. If you go wrong, again you are going to have asymmetric smile. This is how you get result in dimpled chin or cobblestone chin. Same complication, any other complication we see after mentalis injection, doctors? No. Nefertiti lift, what can go wrong in Nefertiti lift? Anyone?
Bruising is very common.
Bruising, neck
Bruising.
is a loose area, mobile area, so bruising.
Dysphagia.
Dysphagia, yes.
If you're over-injecting.
Difficulty in breathing. If you are injecting too many units, though it is very safe procedure to be performed, but when your patient compel that, doctor, you should be injecting more, I'm not getting desired result, and you get over enthusiastic with your injection and you're injecting too much than required, so that is where you face this kind of problem like dysphagia and...
If you're coming very medially, again we are trying to go the DOA crossing, again you can hit the DLI. And
Yes,
same problem.
but generally we don't do that, right?
in case, but
because
then-
the marking is such for Nefertiti lift, so uncommon, but yes, may happen due to maybe highly diluted product may diffuse little more than required area. So hyperhidrosis, any complication, doctors?
Weakening of the grip
is
very common.
Yeah. If you inject
Palmer,
little more units, like generally we
even
recommend
with-
50 units, but
Even with 50 units.
I have seen with 2 patients actually.
Yeah, so that's what I was saying, that even
Yeah.
with standard dosages, it is a complication which can happen.
Okay,
but
fine.
it is a short, it gets better.
Yeah.
It's not going to
One
be
more complication I have seen, patient has not got any result, not even 1%. Anyone who has experienced such kind of, after injecting 100 units, right? So what could be the reason, Dr. Viral? Sorry? But it was first time injection. Yeah. I injected for the first time. He has never taken that treatment.
The brand of the Botox, I mean the botulinum
It was
toxin.
Botox, yeah.
Cold chain maintenance, and maybe nowadays.
But I injected twice. Then he came back for refund of money. I was like, okay, fine. But he was like, no, you inject me again because I'm really troubled and I'm in army. So I was like, okay, fine, I'll do it for free. I injected again, and then also he didn't get any result. So I can't be. No,
Ma'am,
I changed the brand.
I think there are few studies about primary antibodies also, right? Not that we not experienced it, but I have read it for sure.
I have experienced this with 2 patients of mine. So now I'm scared of injecting in hyperhidrosis.
Right. So primary, because she's saying that the patient has no history, so then
Yeah.
primary antibody.
He was getting injected for the first time. So it may happen.
Ma'am, I'll just
good
add one
learning
thing.
for us. And so many people who has faced this, right? Doctor, yeah. Oh. Okay. So she's saying it can be compensatory hyperhidrosis that can also ensue, right? Yeah. Can we give mic to her, please? Yes, Dr. Amalia.
Well, this happened to me once or twice, not having any result at all.
Yes.
Actually, these people were people, very active people, doing a lot of workout, a lot of metabolism.
Mine was army person.
No,
Yeah.
really. But it's quite rare. The other thing that happened to me, because I do a lot of hyperhidrosis, is I injected once in the hospital where I was training, 5 vials of Botox at once
Okay.
in a patient with armpit hyperhidrosis, palms and soles. So half for the armpits, 2 for palms and 2 for soles. And she, after 15 days, a month, she had a general weakness on her body, couldn't breathe very well.
It diffused
hopefully,
into muscles.
everything was fine after, yes. This
After
is
it's weaned off from the body.
Yes. So if somebody has hyperhidrosis in many areas, it's good
Don't inject all at once.
Yes.
Give it
separate.
some timing.
Yes.
So, yeah, very good point you mentioned, Dr. Amalia. Thank you. Anyone?
I want to add something. I have a patient right now. I am going to mostly publish also, I don't know, put up a case study. The patient has hyperhidrosis, axillary palmar plantar, and hyperhidrosis on the dorsum of the foot.
Okay.
So I
very
contacted Allergan people also for some literature or something, but they also did not have anything. So I'm still I just thought I'll ask also if somebody has had any such experience. And then I was told to then take pictures and do
Anyone
everything
in the
and
house who
probably
wants
write
to-
about it as well.
Who wants to share any point regarding this? No one. And Allergan literally have nothing in their.
I mean, I just thought of talking. I put it up on the dermatology groups and everywhere also, but nobody knows anything.
In fact, dorsal hyperhidrosis is very rare. We hardly see these cases. Okay, so we'll sum up our session, and I hope it was great for you all. Thank you so much. Okay.
Hello. Hello, hello. One patient came from Kazakhstan for dorsal hyperhidrosis. I injected it and there was no result at all.
Okay. It was fine.
It was fine, but there was no result.
No result.
Patient complained.
Because maybe there is no muscles over here.
Yeah, but muscles are very thin, that is the reason.
Yeah, so...
But for the, as far as the hyperhidrosis over the palms and soles is concerned, I have done many cases and the result is 100%.
No, I faced 2 patients not responding at all, like not even a single area which got result.
Most of the patients come before the assessment for military examination or CRPF or something. Everybody passed that exam.
Okay. Thank you. Thank you so much. Thank you, everyone. Thank you.
Thank you so much.
Thank you so much, ma'am. I would request Dr. Jyoti Mai to please... okay. So I would request the panelists, all of you, to please present... Okay, so as we can see, all the panelists felicitating our moderator. Can we have a big round of applause for our moderator? And I would request Dr. Viral to please present okay, so we are felicitating Dr. Gulshan Panisar. So I would request Dr. Viral to present our... Ladies and gentlemen, please put your hands together for Dr. Gulshan Panisar. Thank you so much. Thank you so much, all the panelists. Okay, so ladies and gentlemen, I would request Dr. Ramanjeet and Dr. Jyotir as a chairperson to please come up on the stage. And I would like to invite Dr. Patrick Tracy as a speaker. I would request chairperson to introduce.
Thank you. Can I have the entire slide, please?
Well, thank you for the invitation, and I'll speak on polynucleotides.
We have Dr. Patrick Tracy. He doesn't need any introduction. I believe he's a very, very popular and aesthetic surgeon, and he has flown all the way to bless this conference and to share his experiences with you. He'll be speaking now on neuropeptides from biotechnology to beauty. Over to you, Professor Dr. Patrick.
Thank you very much indeed. I was just telling Viral that the last time I gave this lecture was in the Ukraine 6 weeks before Russia invaded it. So what are polynucleotides? Polynucleotides have been used in medicine for about the last 30 years, and we've used them mostly for tissue repair. So they've only crossed into aesthetic medicine probably in the last 4 or 5 years. And as we know that outside the cell, they can be pro-inflammatory. So they're natural polymers of polynucleotides. Polynucleotides we know for a long time because of DNA and RNA. They're the compounds that build cofactors, coenzymes, RNA and DNA, and they're aromatic compounds with active free oxygen radicals. So these long-chain polynucleotides have a couple of advantages. The first is stimulating tissue repair. The second one is they have anti-inflammatory properties. The third one is we've used them in medicine quite a long time for the treatment of ulcers, burns, that sort of thing. Actually, I should have shown some pictures where I've used polynucleotides in legs that have degenerated over the last 10 years. I have some good pictures, I can show them later. And as a consequence, they're very, very safe. So the new regenerative things in medicine are either going to be polynucleotides, which have to be injected. So they're injected about the level of the dermis, and exosomes. Exosomes are straightforward. Your estheticians can do it. You don't need a doctor or a nurse to do exosomes. They go superficially onto the skin. So as a consequence, they can be used with dermal rollers. We use them a lot post-CO2 laser. And polynucleotides are slightly different because they have to be injected. So what do? They do three different things. The first one is the antioxidant effect that we mentioned earlier, and that's through free radical scavenging. The second thing is they bind with water, so as a consequence they hydrate the skin. But the third one is the one we're interested in. That's tissue repair, collagen formation through stimulation of fibroblasts. And how do they do that? They do that through those G protein compound receptors in the skin, particularly A2, the adenosine part of it, and we'll just look at them. So the first one is the antioxidant effect with free radical scavengers, and this is used obviously to protect DNA against UV radiation. This effect can last for a period of a week or more, and this aromatic compound is the part that is free radicals. But that isn't really what we're interested in. We're interested more in tissue repair. But the second thing is we should look at the fact that it does bind water molecules, and it binds water molecules through that polyonic structure. Now, fibroblasts, this is the interesting one. So it works through stimulation of the A2 receptors. They're the adenosine receptors within the skin, and adenosine receptors are a subsite, as I said earlier, of GPCRs, which are the G protein coupled receptors. Now, they're used in many things that we're looking at recently. They're used in signal messenger transmission. They're used in cell-to-cell communication. But these are one of the ways that they're used to form collagen. And for those that don't know much, I suppose, about A2 receptors in the skin, these are the things they're used for, and we're really hoping that they're going to work on the third one in the implication of wound healing. Now, I've been using wound healing and exosomes for a long time, for probably 10 to 12 years. As I was chatting with Al this morning, we've been using stem cells. We used them originally from fat tissue, stromal faction, but then we switched over and we're using ones from red deer in New Zealand. You can get them from a colleague in Singapore. They're not cold chain. They're used as signal messengers, and we use them a lot in terms of repair with red light. Now, a lot of my work has been followed up by the Chinese, which is interesting, because I believe that if you have a situation where you've either got a burn or a vascular occlusion, there's one big thing missing, and that's blood. So in terms of skin repairing itself, it finds it very difficult. And it finds it very difficult because everything that we use for skin repair comes through blood. So if there's no blood, what do? So if you can't bring Muhammad to the mountain, you bring the mountain to Muhammad. So as a consequence, you can use, and this is to prevent dermal scarring, particularly in terms of vascular occlusion. We've done a lot of work on this. You can, and don't forget that fibroblasts are only workers. Fibroblasts have to be told what to do, and you have to have lots of workers. So if you're left with a problem like this, don't be afraid to attack it, either with a CO2 laser or even microneedling, so you have lots of fibroblasts. And then when you have the fibroblasts, you have to tell the fibroblasts, look at guys, this is what I want you to do. I want you to build this. So if we consider it almost like building the pyramids, just because we have a lot of slave workers, that doesn't mean that they know to build a pyramidal structure. So you have to either use signal messengers to tell them, listen guys, one floor goes on top of the other, or growth factors, who are specialized people that come in and trim the different structures. So if you're going to do wound repair, always consider, if you've no blood, you've got to tell the skin what to do. And to tell it what to do involves red light as well. So if you're going to use stem cells, which we use more so than polynucleotides, if you know skin, we have a lot of dermatologists here, epidermal tissue goes through a thing called EMT, which is epidermal migration transfer, or mesenchymal transfer, and as a consequence, that can become tumors and skin cancer. But if we've got a situation where we've got mesenchymal stem cells and the potential for dermal scarring, if we use red light, we can turn the keratinocytes back into epidermal tissue. And I've done a lot of work and won awards for a lot of this. So this is a fairly minor part of wound healing, but it's an interesting one because polynucleotides are easy to get, they're easy to use. I suppose what I don't like about them is that the patient needs 3 or 4 treatments, and then whenever you're going to charge people, it can turn out to be quite a lot of money compared to stem cells. So again, the work through the A2 receptor stimulation mechanism to improve collagen. And obviously also you can use these to improve hair growth or all the different things. So because it's near lunchtime, I'll spin through this. So how do we do it? Okay. In terms of administration, this is the area we want to reach. This is a higher area than, or a lower area than exosomes. Exosomes are higher in the skin. These are at the lower dermis and subcutis. So as a consequence, it's the deeper layers of the dermis where we want to inject. And I find if you switch over to the new needles that are coming in from China, and that's the little 34 gauge ones, they're harder to get, but they're much better than even the Botox needles or any of the other ones. And they work real fast, particularly around the eyes. You know, they're just a small little 34 gauge needle, and they're wonderful because they have less side effects and they work really fast. So they come from salmon, and salmon sperm is very commonly used for a lot of things in the world. Salmon sperm, salmon make a lot of sperm. In case you didn't know, this is how they milk salmon for the sperm, and they're used extensively in medicine for other reasons. And I see they're using them now to get the heavy metals back out of mobile phones. They've just come up with a mechanism only a couple of months ago, because all the mechanisms to date don't work well with the environment, but salmon sperm can be used now. So in terms of injection, this is the way that it's done. You go down to that level in deep dermis, you almost form like a little bleb, and then you can move to different areas within, I suppose, the skin itself. And there are sort of marked out, I suppose, levels that we do inject. And again, if you go too superficial, you'll get little lumps. If you go too deep, you'll get no effect. And it's almost like hyperhidrosis when we were speaking about it a moment ago. You have to go into the skin. You're not going to get an effect if you go below it into the muscle, which is one of the reasons, particularly when I'm doing palmar hyperhidrosis, that I don't block nerves. So as a consequence, you don't know when you're too deep or you're in the skin. If the patient hurts a bit, particularly with BTL we tend to use, or 25% lidocaine, they'll feel a bit of pain, but not too much. I've never seen hyperhidrosis not working, and I've done it for, wow, I've certainly done it for quite a long time, 1997. What's that? 20, 30 years? Yeah. Okay. So again, in terms of injection, you can use the different techniques already. A lot of people favor fanning techniques for polynucleotides with a cannula also. You can use linear threading, serial puncture, cross-hatching, and these are normally the injection points that are favored for serial puncture. 30 gauge needle, I'd switch that to 34, it works better. Deposits 0.1 to 0.3 mil. Avoid intravascular, well, I suppose that's just common sense. I don't tend to aspirate. I don't think we're down deep enough, but that may not be the best advice to give some people starting. And particularly, you're using the one needle. So if you aspirate the first time, it'll work. But if you've already injected it and the needle's full of your product, aspiration means nothing. So I don't tend to do it. Where it says there, contraindication, periorbital, that is not a contraindication. Certainly all the polynucleotides now you can use around the eyes. This was a lecture that I gave maybe 7 years ago originally, and they didn't have the right formulation for eyes with this one, but we do now. So again, in terms of injection, it's a very straightforward technique. And in terms of using the fanning technique, they're the sort of injection points to use. And again, I wouldn't worry about where it says there not to do the periorbital area. If you're using a cannula, probably make sure that you're still in the dermis. It's very easy to leave the dermis with a cannula. Use 25 gauge. And again, oops, I'm sorry. Okay. In terms of the neck, again, the injection points are almost similar to Profilo. Needle inserted perpendicular to the skin. Again, 0.1 to 0.3. So this is a very straightforward technique. And as I say, the only problem I find with it is, if you use dermal fillers, you do it all on the first occasion. If you're using polynucleotides and you're bringing the patient back 3 or 4 times, you have to match your, I suppose, costs accordingly. And often, if there's a lot of clinics, there's a race to the bottom because they all try to lower their sort of costs. You can use it in hands as well. Again, with a cannula. I suppose the big advantage of polynucleotides is they're just so easy to do, and it doesn't take a lot of experience to use them. If you're using a cannula, I prefer to do it the other way around and do it from the, I suppose, distal portion back to the proximal. And if you're doing hands, I find hyaluronic acid is so straightforward, particularly the higher G' ones, and a CO2 laser as well, if the patient will tolerate that. Use them on the body. Again, tend to use a cannula. Different techniques, serial puncture or fanning. So that's, I suppose, important there. So you're using a series of 4 treatments every 15 to 30 days. And a lot of patients do it every 2 weeks. And these are the sort of improvements that you're hoping for. And you often don't see them starting until, I suppose, 2 or 3 treatments into it, because collagen obviously takes 28 days to form in the first place. So this is a fairly typical, I suppose, patient. And to me, the results aren't dramatic compared to what I do to patients. Probably if I had that neck, I'd do a CO2 and it would last longer. But the big advantage is if you have a big clinic with a lot of staff, polynucleotides that your nurses can do, and it's straightforward and they're working away in the background when you aren't even aware. So again, they're fairly typical results. That's after 3 sessions. So the results, I mean, they're not miraculous, but they're good. And I mean, you'll never really hear a patient complaining. But where I fit it into my practice is we have 5 doctors, and we have about, God, I don't know, probably 5 nurses and maybe 10 estheticians across 3 practices. And this is sort of one of the things that keep your nurses busy when you're not there. And particularly, I'm semi-retiring now, so I'm only working 2 days a week, so I have to have something to keep my nurses occupied. And this is, I find, perfect for them. Okay, so the normal, I suppose, contraindications. I'm not sure even if they are complications or contraindications. I couldn't see how a pregnant or a breastfeeding woman could have a problem from just getting, I suppose, the polynucleotides per se. People below the age of 18, that's new regulations that we have. Epilepsy, diabetes, herpes, infection, serious allergies. My impression is of the new, I suppose, bioregenerative medicine, the sort of people who you shouldn't be injecting, particularly with DNA or with exosomes, are people with cancer, or even people with pre-cancer. Because at the end of the day, you're taking a cargo of, I suppose, vesicles, putting into it mRNA, DNA, protein, signal messengers, blah, blah, blah. If those cells are coming from a source that have cancer in them, obviously, theoretically, they're going to spread that. So, I mean, that would be my big contraindication. If patients have had cancer or previous cancer, just be careful. And that's the end of my lecture. Time for dinner.
Excellent presentation. Excellent presentation. I must congratulate you. Just one question. After about, say, 4 sittings, that's what you recommend. So what is the longevity of the result? It can last for how long?
That's a very good question. My jury's out. The company said 2 years, but certainly my patients are being brought back, from what I can see, on a 6 to 12 month basis. And the patients seem to be happy with that. For some reason, some patients don't want dermal fillers, even though dermal fillers in the right hands will give the best results of most things. But there are people who, and I think this is how Profilo got that whole market of non-dermal fillers, and they sort of seem to fit into the Profilo market. We have people who come to me and sort of say, Patrick, look at my face, the nurse did this, wonderful. And I'm looking and I can't see something dramatic, but there is certainly a subset of patients, and often younger patients, that just want something done, something makes them better, that's not fillers, and that seems to be that. Yeah.
Any results regarding pigmentation, melasma, some improvements?
It's a very good question. I've seen them certainly more with exosomes, and I don't know whether it's the dermal roller that's doing it also. I haven't used polynucleotides for that reason, but I know that it's one of the indications, for sure. But I've seen hypopigmentation with, or decreased pigmentation with exosomes and polynucleotides, but it wouldn't be, if a patient came in to me with pigmentation, it wouldn't be my first choice. No.
Is it painful while injecting?
Anything going into the dermis is painful. To be honest, I love pain. Because, well, not so much even that, but when we were doing isologen back in 2001 to 2003, we got great results. Other people didn't. And if you are getting in the dermis, there's two things in the dermis. One is pain receptors, and the other is blood vessels. So if you're not getting pain, you're not in the dermis, you know. So it is a little painful, but to be fair, we put on BTL beforehand, so with a 34 gauge needle, it doesn't really hurt.
Thank you so very much. Any questions?
How do you follow up the treatment? Do you continue 4 protocols after 6 months or 1 year? Or?
We tend to be honest, Faral, most of the polynucleotides are done behind my back, and all I hear is reports that they're wonderful or complaints, and I never get complaints. So I certainly promote the nurses doing the polynucleotides because it's a money spinner. The same way as Profilo is. You know, people just come and keep getting it done and keep getting it done, and it happens, as I say, mostly behind my back, as do exosomes. You know, I deal mostly with skin cancers, flaps, that type of thing. But I mean, there's a whole, I suppose, process going on behind me, and polynucleotides is one of those, you know.
And what is the concentration of the polynucleotide you want? How much should it be? How many particles should be per ml?
I don't know. I think that's more applicable to exosomes per se. And you need to be careful with exosomes because they always tell you it's got 1 billion cells. But to believe it or not, the number of particles in exosomes is a bit irrelevant. It's the protein load that's in them. But they'll all tell you, you know, sort of, oh, look, we've got 2 billion cells per se. I haven't heard it so much, Viral, with polynucleotides. They seem to be the same concentration as salmon sperm in them all, I think. I'm speaking in Dubai soon for Purosomes, and I know they come from, in terms of exosomes, cow colostrum, and they promote the fact that they can get an awful lot more things. But I was recently in the States in one of the factories, and they said, don't worry about the number of cells, look at the proteins or what the cargo was carrying, you know. Yeah.
And my last question.
Yeah.
What about the Periorbital? What is the dose there? How much do you inject?
For the periorbital area, different companies have different ones. Chroma have file art, so they have a special one just for eyes, and so you just use it normally from the syringe. In terms of SkyMed, they tend to make it slightly different. They're saying they give you the hyaluronic acid to mix with it, but they said if you're doing the eyes, to sort of use it on its own. And in terms of Filex, they were one of the first ones to have the eye one, and on their box also they have eyes. So I think in terms of the polynucleotides, the eye ones seem to be in a different product type per se, but there was one time when they started originally they said not to use eyes, but now I think all the companies are using them. Actually, that original thing was from Juvenis, which was Chroma, before they switched it into file art, and they weren't using it, and now they are. Yeah. Yes? Not at all. Okay, this is a very good question. I was in Pakistan about 2 years ago, and I sat on a plane with a dermatologist from Modena in Italy, and she had a full-blown anaphylaxis to fish that had to go to hospital and was kept in hospital for 2 or 3 days, and they didn't know they had a fish allergy until that happened. That's the only case that I'm aware of. So, I mean, certainly an allergy to fish should be up on that also, for sure. Yeah. I can't hear you totally. There's a microphone here.
Hi, doctor. I've been using polynucleotide in my practice, actually as a Profilo 5 points injection. And in your experience, I just want to ask you, compared to radius, like hyperdiluted calcium hydroxyapatite versus polynucleotide, what do you prefer for lifting, more lifting?
Yeah, it's a very good question. Recently, SkyMed have come out with a product just a few months ago that is a mixture of calcium hydroxyapatite and something else. They haven't fully released it, but I've seen the pictures, and they're using it for where we would use Profilo body, particularly, sort of bat wings and legs that have got an awful, and their results. They're letting us use it. If the pictures, if you can believe them, are way above anything I've ever seen, including a CO2 laser. So, I mean, hyperdiluted calcium hydroxyapatite is a wonderful technique, given wonderful results, but there have been some problems recently with it that I suppose should be looked at. And I'm not sure what they are, whether it's skin necrosis or something, or nodules, but certainly I've been informed that we should revise our protocols for it. It's a difficult one, because if the patients came to me with a problem and I used polynucleotides, I'd be in a better position to answer that. But the patients that seem to be coming in are patients that are coming into the nurses. What should we do? We're doing polynucleotides. So they're not presenting to me, if you can imagine, with a cosmetic or a physiological problem. It's a bit like Profilo. When Profilo came out first, they were showing you could use it for accordion cheeks, and I did it. It didn't work. But I mean, certainly, we were getting hundreds of patients coming in looking for it, either through marketing or whatever, and all those patients were happy. We got no complaints. But it wasn't to me like a physical or physiological indication that they came to me and I give it. And polynucleotides seem to fit into the same category. It's like they're going on in the background because patients are just coming in wanting better looking skin, and it's been used for that. So to look at your problem the other way around, if a patient came to me with a lot of accordion cheeks, would I use polynucleotides or diluted radius, particularly in the neck? I probably wouldn't use either. I tend to be very much, look, you got a problem, let's take a week off, I'll do CO2, you'll end up with a great neck. Huh? Oh, combine them together. Oh, it's quite possible. I haven't done that, but I'm sure you could. I couldn't really see a contraindication, and I'm sure the polynucleotides probably would work with the calcium hydroxyapatite to get a better result. I'm sure. I was in Montenegro a few days ago, and a lot of people are combining PLA also, Yeah, well, it's PDLA, so it's one of the variations of Sculptra, and I suppose they're using the potential power of a stimulator of collagen along with a stimulator of collagen to get a better result. I'm all for combination treatments, and certainly I'm all for things that probably when you add 2 and 2, you get 5 instead of 4. And I've spent my life combining treatments, so I haven't personally done it, but I certainly would love to see the results. Thanks. Yeah. Well, you could do the trials, yeah.
Wonderful presentation. So thank you so very much, Dr. Patrick.
Not all.
It was pleasure listening you all this while.
Yeah.
Thank you.
Thank you so much, sir. And I would request, sir, please come right at the center of the stage. And I would request Dr. Ramanjit, sir, to please felicitate Dr. Patrick.
Oh, thank you.
So here we are presenting momentum to Dr. Patrick Tracy. Thank you so much. Well, ladies and gentlemen, those of you who are present here, can we have a big round of applause for Dr. Patrick? And meanwhile, I would like to announce the lunch is open, so you may proceed for the lunch, and we will be here after 45 minutes. No. Okay, so we are going to resume by 2:45, so please grab your lunch and come back as soon as possible. Thank you. So we have the chairperson here. Dr. V.K. Sharma, Dr. Anju Jha, Dr. Shivangi Singh, and Dr. Pihu Sethi. Now I would request our chairperson to please introduce our next speaker. And our next speaker is Dr. Amalia.
Hello. At the outset, thanks for inviting us as chairperson in this conference. I would invite Dr. Amalia to talk on neck rejuvenation with combination of HIFU, PDRN, and Toxin.
Thank you. It's my pleasure to be here once again. How can I use this one? I press it. Can you? I can. Well, the topic of today is neck rejuvenation with a combination of HIFU, PDRN, and botulinum toxin A in a series of patients. I have no conflict of interest. Well, we all know then that skin aging in the neck area involves loose or sagging skin, horizontal neck lines, fine lines, loss of jawline definition, fat accumulation, uneven skin tone or pigmentation, prominent platysmal bands. Neck skin aging is a very challenging problem because patient satisfaction rates are relatively low when a monotherapy is applied. So here we need combination treatments. The objectives of this study is to examine the effectiveness of combined HIFU and PDRN treatments performed according to a specific protocol along with botulinum toxin A as a method to address skin aging of the neck in 49 patients. Actually, we have treated hundreds of patients, but we enrolled 49 patients in this study. These treatments target structures located at different anatomical levels, and it is important to evaluate their efficacy, interaction when combined, as well as their safety and patient satisfaction. Well, botulinum toxin A is the gold standard in treating platysmal bands in both men and women. It can also improve jawline through Nefertiti lift injections. Nefertiti, as we have heard before, involves injecting the depressor anguli oris and masseter muscles to sharpen jawline definition. The recommended dose of botulinum toxin A is 20 to 50 units in total for platysmal bands, injected in 2 to 5 points per visible band, in 2 to 4 units per point. Same applies in Nefertiti lift, as we can use 20 to 50 units as well in total, injected in multiple points. The advantages of botulinum toxin A in treating skin aging of the neck is that the action is very targeted to relax platysmal bands. It provides a lifting effect when Nefertiti lift is performed as well. But the disadvantages is that it is a muscle-related treatment. The potential side effects include asymmetry, difficulty in swallowing, and weakness. It does not address skin quality or fine lines, and it is highly skill dependent, and the duration of the results are 3 to 6 months. What about HIFU? High-intensity focused ultrasound treatment hits the reticular dermis and SMAS to temperatures above 60 Celsius degrees, causing the contraction of the denatured collagen and promoting neocollagenesis. HIFU treatment in the neck area uses 1.5 millimeters, 3 millimeter depth transducers that target the dermis and 4.5 millimeter transducers that target deeper layers, such as the SMAS layer. An average of 300 to 400 shots is applied to the neck area with a pulse duration of 1 second per pulse. Ultrasonic waves penetrate the skin, stimulating collagen production and leading to skin tightening. The advantages of HIFU is that it is an holistic approach to neck rejuvenation, and it targets both the upper layers and the deeper layers. The improvement in skin texture, fine lines and sagging skin is visible, and jawline also has much improvement after HIFU sessions. It is a long-lasting result treatment, as the results may last up to 1 year. The disadvantages are that the treatment may be a little bit painful, there may be erythema and sensitivity, and the results depend on the skill of the provider. PDRN is a compound derived from salmon DNA, as we have heard before, and it is a very promising new treatment in regenerative medicine, activated A2 adenosine receptors. The properties of PDRN is tissue regeneration, anti-inflammatory, anti-apoptotic, anti-melanogenetic, and wound healing. What are the cosmetic effects? As we all know, they promote cell activity, collagen synthesis, hyperpigmentation treatment, soft tissue regeneration, skin revitalization, anti-inflammation, scar reduction, anti-aging. So we have youthier skin, smoother skin texture, less scarring, reduced pore size, improved skin hydration and elasticity, and quicker recovery. So, we have very good improvement in skin elasticity, superficial wrinkles, skin texture, hydration, and healing, but we don't use it in allergic patients, pregnancy, breastfeeding, autoimmune diseases, active infections, and cancer. The advantages is that it's a very targeted treatment as we insert PDRN, promoting skin regeneration and collagen synthesis, and we have improvement of skin tone, fine lines, elasticity, skin quality. But the disadvantages is that we may have erythema, bruising, the duration of the results varies, and we need multiple treatments, usually 2 to 4 sessions every 2 to 4 weeks, and the reevaluation is in 6 months in general. So, we examine the effectiveness of botulinum toxin A, followed by combined protocol of HIFU and PDRN in a way to correct neck skin aging. Botulinum toxin A was injected in platysmal bands, and the pressure anguli oris and masseters were applicable, combined with PDRN 2 ml. Additionally, HIFU was performed involving the transducers that we mentioned before. So 49 patients, 35 women, 14 men. The mean age was 46. All patients had medium, and some of them had severe skin neck aging. All patients had undergone botulinum toxin A in the past as a monotherapy. So we started with botulinum toxin A injections, followed by 3 sessions of PDRN and 3 sessions of HIFU performed every 3 weeks. Neurotoxin was performed in platysmal bands in all patients in average dose of 41 units, and Nefertiti lift was applicable in 15 patients with an average dose of 25 units. Here is a video of how we inject the platysmal bands. It's very important to feel the bands between our fingers and then inject in between our fingers. PDRN sessions started 14 days after the first injection of Botox. So we had 3 PDRN sessions. We used polynucleotides 20 milligrams per ml. And we used the microdroplet technique, 0.05 ml per point, 1 centimeter between each point at 3 weeks interval. And so we performed PDRN on days 14, 35, and 56 after Botox. So this is the technique that we used for PDRN. HIFU was performed at 1 joule per square millimeter with an average of 300 to 400 shots. 3 sessions were initiated 14 days after PDRN, that means 28 days after Botox, at 3 weeks interval on days 28, 49, and 70 after Botox. And as I mentioned before, we used the transducers of 1.5 millimeters, 3 millimeters, and 4.5 millimeters. So we addressed the superficial layers as well as the deeper layers and the smash. Photographs were taken on day 1, 2 months after the last treatment, and the photos were compared with previous photos of the patients when neurotoxin was used as a monotherapy. A significant reduction in vertical lines was noticed 15 days after the last treatment, with a patient satisfaction rate of up to 85% by month 4, compared with 55% when neurotoxin was used alone. So it's very important to notice that we had 30% more satisfaction in patients who underwent combined treatments than patients who had only Botox. The patients reported better results in dynamic and static wrinkles, duration of the results, skin elasticity, sagging, and skin texture and firmness. Nearly all patients mentioned a better appearance in the skin tone, fine lines, jawline definition, and hydration. None reported any severe side effects, except for a mild erythema after HIFU and minimal bruising after PDRN. Here are some of the results. We can see how this combination protocol helped a lot, sagging skin, fine lines, and platysmal bands as well, and how a beautiful definition of jawline, the definition is much, much better in the second photo than before. It's very difficult to treat in a monotherapy. Here as well, a woman of 55 years old with very prominent platysmal bands. And we had a really good result with the combination protocol, Botox, HIFU, and PDRN. The quality of the skin looks much better. And also some aging spots and signs are not visible in the second picture. Here as well, we have more spots and aging signs on the skin, photoaging. We have much improvement. Botox helped a lot in the thick and very prominent platysmal bands, and the quality of the skin is really, really much better. Here as well, and profile photos. The jawline definition is really impressive here. Here as well. Well, the combination of HIFU, PDRN with botulinum toxin A is a safe, minimally invasive therapeutic approach with great results in neck skin rejuvenation. The combined protocol targets all structures of neck and lower face that contribute to neck skin aging. Additionally, botulinum toxin A seems to have a better performance and longer duration when applied as a part of an energy-based device and injectable PDRN protocol. Thank you very much for your attention.
Very good. That was a very lucid presentation, Dr. Amalia. Any questions? 1 or 2 questions we can have. I believe this was a study where you have used all 3 things in all your patients?
It's a study. Actually, it's one of our favorite protocols for neck. We have treated many, many patients, but we enrolled 49 patients, so we could have more accurate numbers and statistics on how these treatments work together. Yes.
Okay. Thanks. That was Dr. Amalia from Greece. Thank you, doctor.
Thank you very so much. And
Next
now
we have...
Okay.
I would like to ask Dr. Amalia to please come right at the center of the stage, and I would request Dr. Pihu to please come forward and felicitate our speaker. So, ladies and gentlemen, moving ahead towards our next speaker, but before that, we are felicitating Dr. Amalia with this memento. Can we have a big round of applause? Now, ladies and gentlemen, we are going to present our next speaker here on the stage, and the next one is none other than Dr. Viral Desai. I would request our chairperson to please introduce our next speaker.
So next speaker is Dr. Viral Desai, and his topic is evolution of threads and how to choose. Dr. Viral Desai is a plastic surgeon and has a keen interest in aesthetic dermatology as well. Yes, doctor, you can start.
Thank you so much for the introduction, chairpersons. My topic is going to be, it's a very vast topic. I'll try to cover it as much as possible in 10 minutes. But it's going to be about threads. Why is it not coming? क्या करें? Can She's not coming. Okay. Basically, threads are nothing but suture materials which are placed under the skin. They basically have various purposes. They're to tighten and lift the parts of the body or the skin. And of course, now we talk about biomodulation. Now, basically, it's a cosmetic procedure. It was originally thought that what do threads do? They bring together tissues, they close gaps, they lift, they realign the sagging tissues, and of course help in facial contours. And then there was the so-called collagen stimulation, elastin stimulation with threads, especially when you talk about monothreads. And my last part will be about the new threads. So there are floating threads and there are fixed threads. Floating have no anchor points. They are mainly PDO threads. The fixed threads always have a pre-decided trajectory. They have an entry point, exit point, or both. They have to have an entry point. They always don't have an exit point, or they may have both. And they are relatively put in fixed areas of the face. Floating threads are put in the more mobile areas. If you see this definition, you have your monothreads, unidirectional, bidirectional. It depends on whether your cogs are running in one direction or running in two directions. Also, you have the newer threads which are multi-directional. I'll come to that. It could be simply loaded on the needle or twisted. That is the twisted threads. Depending upon the barbs, they may be on one side or they may be completely around the circumference of the thread. So it depends how many barbs are there. The barbs could be pasted on the thread or they could be cut into the thread. So that's the cut threads are the molded barbs. Long thread, typically what is longer than 90 9 centimeters is considered a long thread. Anything shorter than that is considered as a short thread. The material, it could be needle type or cannula type. Now, monofilament threads are basically absorbable. They are mostly PDO, sometimes PCL. They are folded and put on needles which are of the size of 25 to 27 to 31 and even 33G. The main purpose of monothreads is only one, which is basically rejuvenation. So you put them actually parallel to each other at a gap of 5 millimeters to maybe a centimeter, or you put them as a mesh, crisscross. And what they do is you put it always in the dermis. You do not put monothreads in the subcutaneous fat. You put them in the dermis because your purpose is to stimulate elastin and type 3 collagen mainly. Okay. Yes, they have been sold many times saying that they do help in lifting, but no, monothreads, in my opinion, do not help in lifting. All you see is a rejuvenation which will last you maybe 2 to 3 months or at the most 4 months, and that's about it. That's your purpose of monothreads. Then of course you have your barb threads. So depending upon the direction of the lower diagram clearly shows that they are bidirectional. So you have the barbs running in two directions. And the upper one, which are the newer threads, is basically a pair of bidirectional. So they do not have a clear portion in the center with barbs running on one and second direction, but each one is a pair, okay? So these are the newer threads, and these are actually called as a multi-directional threads. Now, if we look at the longevity, PDO, PLLA and PCL, the three commonest materials used for threads. PDO is used more rampantly as compared to other materials. The biodegradation period is 6 to 8 months. PLLA is a little longer, and PCL is around 2 years, 1.5 to 2 years. Flexibility. Now, this is a very important point. Anybody using threads knows this. Your PDO threads come in stiff cannulas because the threads are not flexible. So you cannot actually mold them, contour them and curve them. But that is possible partly with PLLA, and PCL are very, very flexible, okay? So the advantage of having PCL threads is one, increasing the longevity. Second is, of course, increasing the flexibility when you want to lift, contour, go along the jaw or in the midface, which is not possible with PDO threads. So this is the main thing, and all are very safe. As you can see, the last column, all are very, very safe, okay? Any of the materials. Now, this particular diagram was interesting. I think it kind of summarizes all what is available. So like I already mentioned, monothreads, only for rejuvenation. They could be twisted onto each other. So that means multiple threads at a time. Now you're looking at screwed threads where they're screwed onto the needle. Okay, it could be single screw, double screw, or multiple screw now. Multi-screw also come. What is the purpose of screw threads? Partly lifting, but mainly giving volume. So if you put them in nasolabial folds, marionette lines, or hollow temples. So the purpose of these screw threads are mainly for volumization. Okay. Then you're talking about your cog threads, double cog, single cog, or cogs which are running all over. These type of threads are mainly for lifting. The purpose is lifting. So whenever you come across any kind of cogs, barbs, or cones, that is basically to grip or anchor the tissue, and the main purpose is for lifting because it anchors into the tissue. Okay. Now you also have multi-threads. What is the last one you can see is multi-threads. Obviously the purpose of multi-threads is again volumization. So if you have a deep nasolabial fold, marionette line, if you want to even put on a dorsum of nose in order to augment it, these are the threads which are very useful, the multi-threads. Okay. Now you can see the first three are basically cut barbs. So the barbs are actually cut into the thread as compared to the last two which are pasted. So what happens in the pasted barbs, the suture is intact, but the barbs are pasted on it. So you do not decrease the diameter of the thread at any junction. Okay. What is the advantage and disadvantage? Obviously the suture remains very, very strong because you do not cut into the suture. You do not cut into the circumference or the diameter of the suture. But what is the disadvantage of the pasted threads? They make the cannula very, very thick. They are more traumatic and they are less forgiving. So if you want to insert pasted barbs, you need larger cannulas to insert them. So obviously there is more bruising, more pain, more downtime. And if you go in the superficial plane, it's difficult to reverse the pasted barbs as compared to what it is. So yes, you may think pasted barbs are very good, but you also the risk and complication increase with that. So everything comes at a price. Now I'm just going to quickly go. So you can see this diagram where the screw threads, they are placed where you want basically volumization. Okay. Now technique, you always remember that you anchor the thread to your ligaments and you pass them beyond ligament from the fixed area of the face into the relatively medial portion, which is the mobile area. Okay. So the threads are going to hold basically at the ligament level, whether it is a cheek septum, lateral cheek septum, whether zygomaticofacial ligament, your platysma auricular or a massetocutaneous. You're going to pass them through these ligaments into the mobile areas and you're going to anchor them upwards. Okay. You never cross the line. So if you draw a line from your medial canthus through your modulus, you never cross this particular line. You never go beyond this line because one, your vessels are there. Second, your nerves become superficial. And third, if you pass the fold, you can actually you can increase the fold. If you go across the nasolabial or mentolabial fold, you can actually increase it or exaggerate it rather than making it better. So keep that in mind. Also, threads are only, barb threads are only put in subcutaneous superficial fat. Okay, unlike fillers where you put them on bone, periosteal plane, deep fat pads, threads are always in the subcutaneous fat. Only monothreads are in the dermis, otherwise they have to be in the subcutaneous fat and nowhere else. So if you are using cannula threads which are barbed and you're trying to pass your cannula, if there is no pain, it smoothly glides, you're on the right plane. If you get resistance, either you're deep or you're superficial. And if there's excess of pain, again you're in the wrong plane, always. So like I said, the fixed point. Now if you see in this, the fixed point is beyond the lateral cheek septum and the zygomaticofacial ligament. So from that relatively fixed point, you pass the thread into the mobile area and you pull the tissue towards the fixed point. So you get the lifting effect. And if you pull it up more in a particular way, in particular tangent, you also get volumization. You can create volume with your own tissues. So you don't need fillers here. So that's what threads can do. Okay. The vectors could be vertical, oblique, or horizontal, depending upon what kind of lift you want. I think we're running out of time. I'm just going to quickly go through this. So now the newer threads. PDO is not flexible. PDO is short-lasting. PLLA stimulates very good collagen, but PCL is longer lasting and flexible. So the new threads are actually a combination of PLLA with PCL, which will give you longevity along with flexibility and very, very good collagen and elastin stimulation. The barbs are cut in a particular way that they don't weaken the thread. The barbs are longer, so that the longer the barbs are, you get better engagement of the tissue in such cases. What happens with bidirectional threads, if you have 5 cogs on one side, 5 on the other side, and one of the cogs breaks or disengages, you get a lopsided pull, and that is because of a tug-of-war effect, because it pulls more towards the side which has more cogs, okay? With the bidirectional threads, even if one cog gives way, the other continue holding it. You do not get a lopsided pull. So this is another big advantage. Then you're talking about the new generation, which was just launched last year. We used to have HA coated threads. HA coated threads are basically hyaluronic acid coated, giving some hydration to the tissue and having less fibrotic reaction. But now you have HA impregnated threads. So you can see that this is the surface of the thread. In that there are 3 types of capsules: submicro, micro and nano capsule. Each one of them contains HA, which is released gradually. So they are of different thickness, the each shell, the small, medium and thin, thickest and in medium. The thin one will release HA up to 6 weeks. The medium one releases from 6 weeks to 3 months. And the thickest one releases HA from 3 months to 6 months. So you get gradual hydration of skin, gradual HA release, better collagen, elastin stimulation, and of course, you get good anchorage and good biostimulatory effect. So we heard Patrick talk about PDRN. We have some lectures coming by Sarah on exosomes, and we know that, and of course, Amelia spoke about HIFU. So we know that everything is going towards collagen stimulation rather than fillers. So this is what the new threads do. They not only lift tissues, they not only create volume, anchor tissues, but they will also create a biostimulatory effect because of the material and because of the sustained release of HA which occurs over 6 months. So this was studies done, the wrinkles, unevenness, pores were much better. Then this is the unique combination of lifting, armoring, what all threads do, but also biostimulation and creation of more collagen elastin. Some results, I'll just quickly go through them. Okay, anything, you want to ask me any questions, you can follow me if you want, anything. We also conduct a lot of trainings and inquiries, for non-surgical procedures. But yeah, you can get in touch with me if you just want, you can scan this. But I had to rush this. Threads is a very long topic. It probably takes 10 days to teach if you want to teach all types of threads. But I've tried to at least give you a brief in 10 minutes, okay? Thank you so much.
Sir, if there is a keloidal tendency in the patient, should we do threads or should we avoid it?
Actually, it's controversial. If you want, probably, you can risk it by inserting a few mono threads. And then maybe if you can look at barb thread. But yes, wherever you go to puncture, when you're inserting the cannulated threads, the size is quite large. It's 18 number needle. So there is a chance of keloid happening at that spot. So the only other way, now once it's inside, that's not a problem if you're on the right plane. Because there you're going in the subcutaneous fat. The problem is the entry and the exit points if you have. So maybe then you can take your entry points higher up in the hairline. So as plastic surgeon, we used to also open up the temporal fascia. I didn't put that here. Actually suture the thread to the fascia and get better anchorage. So, you know, if you do something like that, which is hidden, you may still get away with it. But otherwise, you have to be careful. Thank you.
Thank you, sir. Sir, any long-term side effects? Any long-term?
No, nothing long-term. I have done facelifts also after thread. And it's fine. I mean, the thread is there. And especially with the new threads, the HA, the fibrosis is very minimal. Maximum fibrosis I've seen when we do a facelift, when we was with PDO threads. The amount of fibrosis, but it's still very manageable. It's still okay. If you're using energy-based devices, then the tissues get really badly damaged. It's difficult to perform surgeries. But that way, relatively, threads are safe. So I'm sure you all know the global tendencies that, that fillers are kind of stagnated or kind of gradually going down. They're being replaced more by EBDs, PDRNs, exosomes, which polynucleotides. And now, of course, threads are really picking up globally, and especially the new biostimulated threads, because you don't only put them for lifting tissues and volumizing, but also for biostimulation. So I think, yeah, we look at threads is probably going to be the future. It's there for a long time, of course, and it's going to be rising. Okay? Thank you so much. Yeah, we had a lecture by Dr. Anuya, which was on exosomes, but we also have Dr. Sara is going to be covering up exosomes in her talk. So I think let's not double it up, and we'll have a discussion that time. Thank you. Thanks.
Okay, I would request, sir, to please... I would request one of the chairperson to please come forward and felicitate Dr. Viral Desai. Ladies and gentlemen, please put your hands together for Dr. Viral Desai. I would request Dr. Ramanjeet to please come up here on the stage once again to felicitate all the chairperson who are present here. Thank you so much, all the chairperson, and it's time that we are going to felicitate each one of you present. So, come on, ladies and gentlemen, can we have a big round of applause for all the chairperson who are present here? And as we are felicitating them one by one. Ladies and gentlemen, can we have one big round of applause for all the chairperson who are present? Now, moving forward towards... Okay, so I believe most of you are here. Meanwhile, we are getting the photography done. I would like to thank all the chairperson once again. Ladies and gentlemen, before we proceed with our next panel discussion, once again, I would like to make an announcement that Dr. Patrick was here and he presented the book to Dr. Desai, and by mistakenly he has kept it somewhere. In case if you find it, please hand it over to him. It was kept right at the back. In case if anyone finds it, please hand it over to him. Now moving ahead towards our next panel discussion, and for that I would like to invite our moderator here, Dr. Indu Balani. Can we have a big round of applause for Dr. Indu Balani? And we have our esteemed panelists who will be joining us here on the stage, and I'll be taking the name one by one. Dr. Amalia, Dr. Viral Desai, Dr. Shivi, Dr. Shivi Nijavan, and Dr. Rinki Sharma. Can we have a big round of applause for all the panelists? Once again, I would take the names of all the panelists and I would request you to please come up here on the stage for the panel discussion. Dr. Amalia, Dr. Viral Desai, Dr. Shivi, and Dr. Rinki.
Okay. So, good afternoon, everyone. And Dr. Amalia has already presented how she has managed some cases of neck with a combination protocol. This mic? Okay. So, moving forward, we can discuss more. And if any of you also have any questions, you are free to ask the panelists. Well, we all know that we are dealing with the face all the time, but aging of the neck is also very obvious, and sometimes it lags behind, and then our patients themselves ask us to work on the neck as well. And a neck, it's not only bands, sometimes it's heavy faces, there is submental fat pad also. So there are different types of necks also which need to be managed, and especially in our Indian type of faces where jawline definition is required, but it's a great problem to actually achieve the best results with non-surgically. So let us have the view of the panelists about what are the main concerns patients have when it comes to neck aging and how do they differ from facial aging. Anybody would like to address?
Well, the main concerns is how can I have a very, very good result, because most of them have seen that the results with conservative treatments on the neck are not so amazing as the face usually. Yeah. So they want treatments to have good results, no downtime, of course, and long-lasting results, because this is also a problem with the neck area, in my opinion.
Probably we should start working early on the neck as well when we are working on the face, I think.
Yes.
So, so you've already mentioned your results with HIFU. Yes. So HIFU alone also, do you think, is it sufficient? Does it give some results, some satisfactory results to the patient?
Yes, it's good for actually mild problems, mild sagging, mild loss of jawline definition. But when we combine it with other treatments, the results are really very good. Sometimes after HIFU, you have an immediate right after result because of the contraction of the skin. They like this feeling. Yes, you need treatments. Usually, I do 2 to 3 sessions monthly, and we have a good result, usually.
Anybody else would like to mention their experience with HIFU for the neck, in Indian patients especially?
So I feel HIFU is not recommended to be a standalone treatment. As you know, there are certain areas that need to be avoided with HIFU, like the trachea area, the middle area. So definitely we should do a combination treatment, maybe a botulinum toxin along with HIFU.
So for those who have a submental fat pad, for example, do you think just HIFU is sufficient, or yes, in that also we need some combination treatment?
Then I think that should be enough, but can be combined with probably an injection lipolysis. with deoxycholic acid.
So basically we can consider the limitations of HIFU as a lot of skin laxity, thin necks, maybe we could not do HIFU. Okay. Okay. Exosomes. So exosomes, we have also learned, attended some sessions, and I think there'll be another presentation on exosomes. So exosomes for the face, I know everybody has a limited experience, but for the neck specifically, has anybody tried exosomes? Yeah.
I haven't tried for the neck.
Dr. Viral, I think you have an experience.
I actually have used exosomes for nearly 4 years, but mainly for hair.
Okay.
I have used exosomes for face and neck.
Okay.
But personally, I preferred PDRN over exosomes when it comes to face and neck. Okay. So yes, I've been using PDRN for a little over 2 years now, and I'm quite happy. So if you actually break it down, what are the problems of the neck? One is, of course, the fat, right? It comes through that. Most of it, because of that, the jawline definition. Then, of course, the sagging. Then you look at the pigmentation, which is not so much of an issue as compared to the faces. Then you look at the texture, which is your fine wrinkles or your coarse wrinkles, and then, of course, your muscles. So if you have your platysimal bands running, it's a blind. You just inject your toxin. There's nothing else to be done. Otherwise, surgery, of course. But we're not going to surgical management. When it comes to fat, I used to personally like the HIFU a lot. But when I saw the problem with HIFU, when we try to operate after HIFU, it's crazy. The tissues are as if they have been blasted. It's like a war zone there. To do a facelift or a neck lift in a patient who's on HIFU, it's very bad. It's easier to do in a patient who's done a previous facelift. Okay, so looking at that experience, I started doing less and less of HIFU, and I'm going more towards deoxycholate injections. And with the new formulations, we have like Lipolab, like Aqualux. They buffered the pH in such a way that they're less painful, the inflammation is not too much, the downtime is not much, and they work quite well. So yes, we've been using a lot of deoxycholate now. So get the bulk down, inject the muscles toxin. For the surface pigmentation, of course, you use your Q-switch or peels or or should I talk about that? Yeah. And when you talk about those, particularly those fine wrinkles, I think are because of two purposes. Either you have loss of fat and collagen and elastin, and second is your basically your superficial muscle. I forgot the name of the muscle. In animals, when a fly sits on a cow, the whole skin contracts. So that is the muscle which is also present in the human body, but it's a remnant of it. It's very, very thin. So we probably get that. So micro Botox, meso Botox probably helps there, and definitely anything to build collagen. So now preferring more of PDRN personally.
Yeah. So anybody who's planning surgery, I think we should not do HIFU.
Yeah, this is something now I've been telling for last 1 year to every conference I'm going to. You please do us a favor and the patient. Ask him if he's planning surgery. Then don't do HIFU. If he doesn't want to do, continue doing HIFU lifelong. Okay, every 3 months, 2 months, whatever you want. But if he's ever planning surgery, do other things besides HIFU. Okay, it's very difficult, and you tell the patient your complication risk will increase by at least 20%.
So for exosomes also, we can conclude that as we are having more experience on faces, maybe we can do the neck simultaneously and get more results.
So Patrick is not here, but he was speaking. Of course, he has more experience than all of us. He was speaking that when it comes to pigmentation and fine wrinkles, he prefers exosomes over PDRN.
So again, now the role of PDRN also, we would like to, if anybody wants to state any experiences they've had with just PDRN. So Dr. Amalia already discussed the combination treatments, and we all agree that combination treatments are best. But any specific guidelines when we should do PDRN, or whether we should counsel the patients initially only that they will need these combinations and it's just not one thing which is going to work, or if somebody has a lower budget, then maybe should we just do PDRNs?
Yes, there are many factors that we have to take into account. It's not only the results of the treatment, but also the budget, how many sessions somebody will need, because some people don't have time to come to the clinic every 2 weeks. So these are, of course, factors that we have to have in mind. So for PDRN, actually, it applies to almost everyone. There are no any. There are some contraindications, of course, like allergies or breastfeeding, and cancer, and all this.
Suppose they're not able to come frequently, then should we still do 1 or 2 sessions?
Yes, but I have to explain them that maybe the result will not come very early, or they have to do some more treatments, fractional. Sometimes when we have really big problem and people cannot come very often, I suggest maybe more aggressive treatments, fractional laser plus PRP to address the aging, severe aging. Yes.
So this is a case. Dr. Shivi, I think this case was given by you. So what did you do in this case, basically?
So basically, we can see and analyze in this patient that she has a lot of prominent vertical bands, platysmal bands. So I did botulinum toxin for her and 25 to 30 units along the platysmal bands.
So this, the result, sorry. This was a single session, right?
Yes.
So the results are pretty good. Yes, but then I think if now you tell her to do all those PDR and HIFU, I think the results would improve more.
I also counseled her for skin boosters. She came to me around 2 years back. I also counseled her for Profilo.
Okay.
So,
and has she done all these other treatments
yes,
also?
yes.
So she's constantly improving.
Yes.
Yeah. So Dr. Rinki, would you like to tell us some other treatments that you're doing, or what combination treatments are you doing in your practice for neck?
See, first the assessment of the skin is very important. What is the patient concern? If the patient has come, the major concern is the double chin. We have to focus the double chin first. To go with the lipolysis injections first, reduce the fat or HIFU or whatever, and then the threads also work for giving that lift. So the combination treatment only with the double chin, only one treatment is not going to work. Yeah. First mobilize the fat and then do a stretching thing. Same with the neck also. The monofilaments also work for the little bit tightening of the skin. Then you can maintain it with the PDRN and everything that improves your tissue texture, the fine line, wrinkles, everything. So the combination and this all treatment, it doesn't last for a long period of time. So naturally a maintenance is always required after 6 months or so.
Yeah, so no. I think thread slide should have been here. Well, I would like to ask Dr. Viral, like if you have any particular vectors that you're doing on the neck, or how many threads are you using on the neck specifically? Like for Aptos threads only, if we consider, like face we have these 5 threads on each side. So do you do it in the same way on the neck also, or do you use double needle or something else?
No, on the neck you can have 2 types. One is of course your cannula threads, and then of course is your double needle. So double needle with bidirectional cogs. Personally, I think that gives a better result in neck especially. If you're doing for neck or a combination of jowls and neck, where you do it like a scarf method, you pass it from here going into the neck, where you're taking care of jowls as well as the neck. So that works very well. In fact, yesterday we did one demonstration of a double needle on our table, okay. And the results were amazing. They were definitely better. All the candidates could see they were better than the free floating. So I think double needle gives you a very good effect in neck, the so-called hammock technique, where you actually pass it one pair from here, one pair from here, and you crisscross them. So you have a hammock, and then you have barbs running this way, unidirectional, the clear portion, and the other way. Yeah. So you actually mold the whole tissue. They give great results in neck. I mean, I was running out of time, but I would have showed you some neck results. Okay. They were very good. So that gives you good results. Otherwise, if you're not, that's a slightly more complicated technique. But if you're not, you can still use your cannula threads. And you always start behind the platysmal auricular ligament. That is your anchoring point. You pass it towards the midline. You stay a centimeter below your mandible border, and then you don't cross the midline. In the same way, you mold the tissues towards the periphery. towards outside.
So that would be for a bit of this below the chin. So, like if we have sagging all over the neck, so is it just you will use mono threads and PDRNs, or you would go till lower down with your cannula threads also?
No, if you are talking about sagging, you're talking about generalized neck sagging, right?
Generalized neck sagging.
Generalized
In a
neck
neck
sagging.
like this, for example, maybe she has submental fat also, and then maybe
Submental fat, submental fat. Lot of things have been recommended. Even monothreads have been recommended. You put them in the fat and you expect lysis of the fat. Okay, I just never saw it. Okay, never ever. So it's more like you're convincing the patient. You're trying to convince yourself than it is. So if you have submental fat, I think the best option would be inject, debulk it, and then put threads.
And then put thread. So, no, so do those threads go lower down also? That is what I was just meaning to ask.
Yeah, you can put them lower down. Generally, there are some vectors you have to be careful about.
Like some horizontal vectors to lift them, lift this part of the neck like
You can. But then you don't use double needle there. Then you use your cannula threads. Yes.
Okay. So combination, have we discussed all the combinations that are possible? Anybody using anything else for neck? Apart from toxins, boosters?
MNRF.
MNRF.
Yeah. Actually, we also use MNRF for the fine wrinkles and it works quite.
Okay.
And yeah, that is also safer. Safer to do surgery in patients with MNRF than HIFU.
Okay.
The HIFU, it depends on what depth you go. If you're going 1.5, it's okay. That's not a problem for surgeons. The moment you go more than 3 mm, especially your 4 mm probe, then you're definitely going to cause a lot of problems and fibrosis. So it probably works only, the mechanism is to destroy the tissue and cause fibrosis. So that's what it does.
Okay. Dr. Amalia, you were going to add something?
Excuse me, what's the question?
Any other combination, any other treatments for the neck you are adding on to your
I also love PDO threads as well. PDO threads.
PDO threads, okay.
Maybe
so those are the mono threads.
They look very simple, but they do good work here. They support the skin.
So how many threads do you inject?
I can put sometimes 100 threads.
100. So we've all seen pictures on Insta of the neck being full of threads. I think those work by microneedling or by some collagen stimulation.
Yes, chemical pills sometimes when we have aging spots as well. There are too many treatments that we can combine. RF, microneedling, PRP.
So all that we can do on the face, we can, PRP is another treatment, skin boosters have already been mentioned. So all that we can do on the face, we can also do on the neck, but we should start at the right time maybe, because if we go on working on the face, the patient feels that the neck is lagging behind, and then they will come to you with these concerns, and they will not see that much of an improvement also compared with the face. So it's better to start early, I think, on the neck. Aftercare, I think it's according to the treatments that we are giving. No special aftercare on the neck. I don't think anything.
Actually, I recommend the creams that we use for the face as well. Face and neck are one unit. I used to say to my patients, you don't have to put your cream. What we see usually is that the cream stops here in the jawline. And after jawline, everything is ruined.
So if we want to treat the neck also, if we want to see the patient as a whole, I think we should counsel them accordingly. We should guide them that whatever they are doing on the face, whatever creams they are using should also extend onto the neck. Then only I think the treatment would be complete. Right? So Dermacon 2027 will be happening in Delhi. We want it to happen in Delhi, so please vote for that. And any other questions the audience has, they want to ask the panelists about anything on the neck, any treatments on the neck? Yes? Anybody? No? So I think you've answered all very well.
If it's a lot of sagging with a lot of fat and very, very fibrotic kind of platypus glands, please send them for the neck lift.
Send them to plastic surgeons.
Don't
that
try to
should
do.
be the concluding
I'm sure you can't improve them too much, and I'm sure all of us know that.
So there are limitations to our treatments, and in neck particularly, we should be aware of those limitations.
Basically, it's easier for a facelift than neck. It's even for a plastic surgeon. Neck is a trickier area So obviously it's going to be trickier with even non-surgical treatment. So please send them to plastic surgeon. Don't fire your HIFUs so much that it becomes difficult. Okay? Thank you.
Thank you so much.
Thank you so much, ma'am. And I would request Dr. Indu Bilani to please come forward and felicitate our panelists, Dr. Shivi and Dr. Rinki. Can we have a big round of applause as we present this memento to Dr. Shivi? Thank you so much. And now I would request Dr. Rinki to please come forward. Everyone, please put your hands together for our esteemed panelists. Thank you so much. Thank you so much, all the panelists. And thank you so much, our speakers who were present here. Now, ladies and gentlemen, we are going to proceed towards our next panel discussion. And for that, we are going to call our chairperson here on the stage. I would request Dr. Kaushal Kumar Verma, Dr. Okay, so ladies and gentlemen, we are going to proceed forward with the next session. And for that, I would like to invite here on the stage our chairperson, Dr. Kaushal Kumar Verma, Dr. Manisha, Dr. Saeed Mubashir, and Dr. H.S. Girgila. Can we have a big round of applause for all the chairpersons who are going to join us here on the stage? Once again, I would take the names Dr. Kaushal, Dr. Manisha, Dr. Syed Mubashir, Dr. H.S. Girgila. I would request Dr. Ramanjeet sir to please join us as chairperson. And now we are going to present our very first speaker here on the stage. And for that, I would request our chairperson as well to introduce. Everyone, please put your hands together for Dr. Sadhna Deshmukh.
So I would like to invite Dr. Sadhna Deshmukh. She is a consultant dermatologist, aesthetic dermatologist and trichologist. She is postgraduate dermatologist from BL Nair Hospital, Topiwala. And she is the owner of and medical director of Sadhna Deshmukh Forever Young Skin Hair Laser Dermatology Clinic at Bandra, Mumbai. And working as consultant dermatology at Hinduja Hospital, Mumbai. So, Dr. Sadhna, you are welcome.
Thank you so much. Good afternoon, everyone, and I'll be presenting skin boosters in dermatology. Thank you. So, in our dermatology practice, even today, the majority concern of our patients are for skin texture, skin color, hydration, and the popular treatments in our dermatology clinic is first is our prescription, what we write for our patients, then chemical peels, PRP therapy, skin quality, energy-based devices, microderm abrasion, skin quality fillers, mesotherapy, microneedling, and skin quality toxins. Aging shows a decrease in fibroblast with reduced collagen production and other extracellular matrix protein, resulting in wrinkles and loose skin, coarseness, pigmentation. So what are skin boosters doing? they are increasing the production of collagen, hyaluronic acid fillers, boosters, which are low cross-linked, and they enhance and fortify extracellular environment, ameliorating the pigmentation issue, inflammation, vasodilatation, and thus it causes the beneficial effect for boosters. Now, classification of boosters. Boosters are HA boosters, which are Restylane Vital, Juvederm Volite, Profilo, Viscoderm. Then we have PLLA, polylactic acid, which is Sculptra. Then we have PDRN, which is polydeoxyribonucleotide, which is extract from salmon sperm cells. Then platelet-rich plasma, growth factors, exosomes, secretomes, chitosan, and even botulinum toxin in microbotox form can be used for skin boosters. Today we are discussing HA boosters. Now, why boosters? We know that this is an era of regenerative medicine. We want to regenerate the tissue, we want to regenerate the collagen to prevent premature aging and thus to delay the invasive procedures which will be required for our patients in the future for facelifting and other anti-aging procedure. So when we discuss the architecture of our face, it is always the, for the foundation, we use the deeper treatment like HIFU or dermal fillers. Then we do a lifting with threads and dermal fillers. And the superficial, like the roof of our skin, we treat with boosters. So different boosters which are available. The skin boosters, they enhance the texture and repair and thus they do hydration. Whereas Profilo, which is a biostimulator or a for the bioremodulation. So the skin boosters will trigger the hydration. It stretches the reticular dermis, causes activation of TNF-alpha and growth factor. There is production of pro-collagen and thus production of a healthy collagen, number 1. Usually boosters are injected in the dermis, superficial dermis or mid-dermis versus fillers which are injected onto the periosteum or supraperiosteum. So the benefits from our boosters are deep hydration, they restore and remodel the skin and collagen, it gives incredible glow, hydration, and improves the texture, elasticity, and reduces the wrinkle formation. They act on fibrous component, which is collagen fiber, elastic fiber, and a HA component, which is like a gel-like substance in our dermis. So these are different HA boosters, Restylane Vital, Juvederm Volite, Profilo, Viscoderm, and we've discussed that why we do that to improve the texture, quality of the skin, for hydration, for dry skin, to improve the elasticity, and also it can be used to treat acne scars. So the first one is Juvederm Volite, which is a Y-cross technology. It is 12 milligram per ml of hyaluronic acid. The results of Volite last for up to 6 to 9 months, and the protocol is after doing your first injection, the second one you will do after a month, and the third one after 6 to 8 months. I'm just going to show you this video, but I don't want to show the entire video. Can I operate from here? How do I operate from here? नहीं आगे जाना है नहीं आवाज़ मत बढ़ाओ आगे जाना है आगे मीन्स यहाँ 3 नंबर हाउ डू आई सी नहीं होगा okay never mind. So what I wanted to show in this the earlier video, only the marking what we do for Volite, but so here if you on the forehead, always use cannula because forehead is a area where there are maximum vasculature and we want to be safe. Cannula injection makes it relatively safe. And you can see that immediately after treating, the half side, the hydration is immediate, and the other untreated side, you can see that the wrinkles are seen. This is just the immediate effect. Of course, we have to do the repeat injection. The second booster is Restylane Vital, which is a NASHA technology, which is non-animal origin stabilized HA. Again, the protocol is you do day 1 first injection, then repeat after 4 weeks, and the third injection you will repeat after 3 months. You can do microboluses, you can do fanning technique, you can do linear threading technique. Again, when you are doing it with the needle, your needle for the booster should be in the superficial dermis or a mid dermis, not in the, it should not be very superficial. This is the depth of your injection. Different pre-post photographs for hydration. Boosters, they improve the skin quality to a considerably great extent. Now this is the decolletage area. Again, you can do linear threading technique, or you can use the same area with the help of the cannula. Similarly, on the neck, you do it as a linear threading technique or with the help of the cannula. Boluses on the neck for Vital and Volite can be problematic because if it is not placed properly, you can have lumps. Again, the neck can be done with the cannula. Some of the pre-post pictures. Then hand rejuvenation, do the marking. And after doing the marking, you can inject the filler, the booster, with either microbolus technology. So you pinch the skin and you inject the product drop by drop. Or you do it with the help of a cannula. So you make an entry point and then inject the booster with the help of a cannula. After the procedure, massage the hand well, and hand boosters, they give good results for anti-aging of the hands. Some of the pre-post pictures. Then comes Profilo. Profilo is the highest concentration of HA filler, which is 32 milligram per ml. So that makes it 64 milligram of HA in one syringe. And is there a volume to this? So Profilo is, again, there are 5 injection points on the face, and these are called as BAP points, which are bioaesthetic points. So the first point is the zygomatic arch, the second point is the nasal base, the third point is pretragus, the fourth point is chin, and the fifth point is the mandibular angle. Profilo can also be given on the hands. Again, you can give it with the cannula, or you can give microboluses. So as I said, that there are 5 points for Profilo, which is bioaesthetic points. The zygomatic prominence is the first point, nasal base is the second point, tragus is the third, fourth point is your chin, and mandibular angle is your fifth point. It's a similar video. Some of the pre-post pictures. Profilo can also be done on the forehead, but here you have to give tiny droplets of Profilo. Profilo causes a lot of hydration, and for the first couple of days there can be edema. And you can see that I have marked, because this particular patient has a very prominent vessel there, so I had marked that so that you have to be careful while injecting the forehead. Then neck, yes, on the neck, again, after marking, you inject Profilo. You have to do 2 ml on the neck, so 1 ml on each side. So the protocol for Profilo is, after doing your first injection, you repeat the second one after a month, and third one after 6 to 8 months. So that's the protocol for the entire year. Many clinics, they follow different protocol, like some they do it once in every 3-4 months, and that's how you do 3 syringes in the entire year. You have to see what suits your patient, and your patient should get results. Some of the it can also be done for the inner arm for the laxity of the skin. Hands we have seen. Repost pictures, and then comes the last booster, which is Viscoderm. Viscoderm is again the hyaluronic acid HA booster. It is a low molecular, it's low cross-linking 25 milligram of HA booster. And so these different boosters can be combined with each other, and the goal of all the boosters is to give hydration, to improve the skin texture, quality, to reduce the wrinkles. And one second. Oops. One second. Yeah, that's fine. So the protocol for Viscoderm is again same. You give the first injection day 1, then repeat after a month, and then repeat as a booster after 6 months. The problem is these are all entire videos, and I don't know how to forward it in this video because we don't have time to see the entire video. And okay, I'll show one. So more or less for Viscoderm also it is the same, that you give either a linear threading technique or you give tiny microboluses. Viscoderm, the advantage is also that you can use it for the deeper wrinkles, dynamic wrinkles. So for example, for your crow's feet and for along with your toxin, you can combine it. So this is micro droplets. The initial one was a linear threading. This is micro droplets, which gives a good hydration for the static lines.
Excuse me, Dr. Sadhna.
Yeah.
Are you done?
Yes.
I think time is
Yeah, okay, thank you. I'm done. Different pre-post pictures. I just want to talk about, we always have to keep in mind the complication. Even if boosters are, we say that safe, but we have to take care of the most important point is vascular complication, and we should not forget that the most scariest complication is blindness if we hit the vessel. So yes, a good booster should have ease of injection, good hydration, it should be safe, it should give visible results, and should have a good anti-wrinkle effect. Thank you.
So, thank you so much, Dr. Sadhna. And now I would request our chairperson to please come forward and felicitate Dr. Sadhna.
Thank you, Dr. Sadhna, for very informative talk.
So that was a very informative speech by Dr. Sadhna. Can we have a big round of applause? Now, ladies and gentlemen, we are going to present our next speaker here on the stage, and I would also request our chairperson to introduce as we welcome Dr. Shivani. Can we have a big round of applause for Dr. Shivani?
She'll be speaking on plasma pen in Indian scene. May we have her CV, please? I think without wasting much of time, I would invite Dr. Shivani, please.
Yes,
over to you. Yeah.
Yes. A very good afternoon, everyone. I'll be speaking on plasma pen in Indian skin. First, let's start with the technology. So the plasma pen utilizes innovative plasma technology to achieve consistent results. Plasma is formed through ionization of atmospheric gases, stimulating instantaneous contracting and tightening of the skin fibers and collagen production during the treatment. How does the plasma pen work? It utilizes non-invasive technology, and hence it avoids the majority of risks that's assumed when performing invasive and non-invasive treatments. It is a great option for someone who is looking for non-surgical skin tightening treatment. The indications, there are multiple indications for the plasma pen, but I personally use it for non-surgical blepharoplasty, saggy eyelids, under eye lines, forehead, static lines, sagging jowls, that's it. If you have time on hand, it works well on stretch mark, but it's a time-consuming procedure. That's something we need to keep in mind. Now, plasma pen can be safely done in Fitzpatrick type 1 and 2, but you have to be cautious while performing in Fitzpatrick type 3 and 4. These are the contraindications. The commonest one, the important ones which we have to keep in mind are if the patient is on anticoagulant medication, if the patient has pacemakers or prosthetic implants, or the patient has a known history of retinal detachment. Benefits, the plasma pen leads to neocollagenesis, neovascularization, new elastin formation, reduces the static solitary fat. Also, it's long-lasting with minimum downtime and completely non-invasive. The pre-session protocol, it's very important to prep the Indian skin. So, to use topical sunscreen and lightening molecules for a short course to reduce the natural pigmentation. Make sure the patient's skin is hydrated, moisturized, and completely sun-protected. If the patient is diabetic, you can start an antibiotic prior. Pre-session protocol questions you need to ask the patient. How is the patient's daily routine? Does the patient tan easily? Does he or she has a lot of sun exposure or any history of keloidal tendency? The patient flow and the setup. Once the patient enters, take the consent, take clear resolution, high resolution pictures. Topical anesthesia is to be applied. During the procedure, always remember to clean as you go. Don't completely clean the numbing area because you have to make sure till the end of the procedure, the patient is comfortably numb. The target area is to be sterilized. Once the treatment is done, healing cream is applied. Ensure your lighting is good for the minute work you'll be doing. Now your trolley should have everything that's mentioned on the slide. It's important to have the scratch card handy. While doing the procedure, the tip of the plasma pen tends to get charred, and you need to decrust it whilst continuing with the procedure. Now the preparation steps, first the pre-procedure prepping for the Indian skin is extremely important. Clients should follow the perfect prep for plasma pen for at least 6 to 12 weeks prior to the treatment. In prepping, use a topical sunscreen, vitamin C and topical hydroquinone short contact, kojic acid, arbutin to reduce the melanin and to minimize the risk of post-inflammatory hyperpigmentation. Also ask the client to avoid sun tanning, spray tanning, sunbeds and any form of heat exposure. Now the procedure steps, photos, consents, area is numbed, cleaned, sterilized, and the plasma pen treatment is done. Post-treatment cooling is extremely important. These are the different plasma pen techniques, starting with the first center point technique. Here 5 points are placed in equidistant way, with the center point being placed at the end. The minimum difference between 2 points, the gap would be 1 mm. Then next one, Fulton spotting. So here we go below, beneath and above the static line to flatten the line, and then we follow with the center point technique. The spray shade, this is for the plasma pen peel. The next one, Combi Blast. This treatment, the Combi Blast technique we don't usually perform on Indian skin. Now always remember to leave enough space between and don't overcrowd your points. In Indian skin, we usually go for medium to low intensity. High intensity is not recommended. Post-care, there would be swelling, mild inflammation, prescribe anti-inflammatory, keep the skin sanitized and clean and dry. For hydration, the patient can use hyaluronic acid and ceramide moisturizers. For post-procedure healing, antibiotic cream or colloidal silver. Use SPF 50, which is mandatory. This skincare routine can be started once the scabs have fully fallen off and there's no visible pigmentation left over the skin. Patient must do following post-procedure. Use a natural tynose inhibitor once the scabs have shed off. Internally take a vitamin C 1000 mg a day. Do not use any kind of peeling agent. Avoid any other cosmetic treatment pre or post plasma pen. The downtime scabbing for usually 5 to 7 days. They fall off on their own. Session gap between 2 sessions, if you want to repeat the second session, should be 12 weeks, that is 3 months. Improvement is seen initial 15 days, but the full improvement is seen in 8 to 12 weeks. After every session, usually the improvement is 30 to 60% depending on the target area. Safe combination later, once the improvements are observed or appreciated, you can combine with other treatments like HIFU, Morphus, pigment laser, red light therapy, radiofrequency, injectable biostimulators as well. Post-procedure pictures, never look back is the, while doing the plasma pen technique, you have to remember, once you have given the 5th point of the center point, the area shrinks and you won't be able to appreciate the 5 points you have placed. So there's no need to go back and re-examine the skin. This is how the procedure is done. 1 mm gap between each point and a 5-point technique. The 5 points placed. This is a center point technique. So this is the pre and post of my patients. The first one, we did no non-surgical blepharoplasty for her. She had under eye bags since childhood. We have done 2 sessions. The second session pictures are not here. In the first session itself, she had amazing improvement. Sorry, yeah. So this is before and after for the forehead lines. The improvement is seen within 1 month. This is for saggy eyelids. The improvement is seen just between 20 days. For this patient, we used center point and the Fulton spotting technique. For the first one, we treated the under eye area, and the second one, she's the same candidate. We did his smile lines as well. This is before and after in 1 session, 1 month, just 15 days gap. Advanced plasma pill, this is something you can do for instant rejuvenation with spray technique on the skin. Might be risky for Fitzpatrick skin type 4+. We can also use it for non-surgical facelift, for pigmentation, freckles, for telangiectasia, rosacea. Plasma pen can be used on body as well if you have enough time on hand, keeping in mind that the procedure takes a lot of time. This is before and after plasma pen results on hands, decolletage, and elbows. Take-home message, plasma pen is a completely non-invasive, non-surgical treatment which can help with multiple indications which we have discussed initially. It is extremely safe for Fitzpatrick type 1 to 2, but you have to be cautious while treating the skin type 3 and 4. Keep in mind that pre-procedure prepping for Indian skin is mandatory. The most crucial part is patient selection, taking into consideration the skin criteria. Pre-procedure counseling of the discomfort following the treatment is mandatory. It's time-consuming in your initial days of practice and target smaller areas initially and then later the bigger ones. Post-care routine and follow-ups are mandatory. Whether to use Fulton or center point dots inside the skin or the wrinkles and depression fold depends on the target area and what kind of creases on the fine lines the patient has. Thank you.
Thank you so much, Dr. Sarah.
Wonderful talk. Dr. Shivani, just one question for you. How is it different from derma pen, plasma pen? How is it different from derma?
So in derma pen, it's not an energy-based device, sir. We usually use the microneedling and the depth achieved is 2 to 3 mm. Whilst this completely uses the ionic gases, and we never touch the plasma pen to the skin. The plasma pen is not in-skin contact technique. We just have to take the plasma pen near enough to the skin to fire the shot, and the plasma energy itself contracts the skin. So that's how it varies. It is like a non-surgical tightening treatment, non-invasive, but with downtime, whilst microneedling has nearly no downtime and is invasive, and it is non-energy based. This is energy based. That's how it works.
It's available in the market?
Is available in Indian market. Very few doctors are currently doing in India. Also on the eyelid area where we cannot do microneedling and other things, or like on under eye bags, this is an excellent tool for under eye bags and eyelid sagging of eyelids. That's what I feel.
Excellent. Excellent. Thank you.
Thank you so much, and I would request our chairperson to please felicitate Dr. Shivani. So, ladies and gentlemen, that was Dr. Shivani on plasma pen in Indian skin. Can we have a big round of applause for Dr. Shivani? Ladies and gentlemen, we have our next speaker coming up here on the stage. Here we present Dr. Sara Al-Inzi. Can we have a big round of applause for Dr. Sara?
Hello, everybody. Hi.
Hello.
Namaste.
Welcome, Dr. Sara, for your talk on exosome in hair diseases. And thank you so much for coming.
Thank you. Hello, everybody. I'm Dr. Sara from Kuwait. I'm board certified dermatologist with a triple board certification from University of Miami, and I'm a hair specialist also from University of Miami, and and also in cosmetic. So this is a message of love to India. I'm privileged and honored to be with you here in FADS. No one can visit India without feeling love. We deeply admire your culture. India diversity, history, and values have touched hearts worldwide. Namaste. So this is the disclosure. So we'll talk about Exosome. Exosome have become a hot topic in aesthetic and dermatology community. Some aesthetic and dermatologists believe in potential of Exosome. Others remain skeptical about the Exosome. So Exosome is tiny microvesicles secreted from the cell membrane. It's a promising cell-free therapy and discovered in 1980s. Initially, Exosome considered as a waste product from damaged skin, but now most of the researchers and the study focus on Exosome cargo. Exosome cargo, it means the content of Exosome. Exosome content is protein, DNA, mRNA, and microRNA and cytokines. So it's like a bus or shuttle, and as I told you, it's produced by almost all cell types, by paracrine or blood stream. Exosome is very powerful microvesicles, and it can cross the blood-brain barrier. And this advantages of Exosome is very unique because some of the drugs cannot penetrate the blood-brain barrier, so we can encapsulate Exosome into drug such as catalase. Catalase is one of the antioxidant to treat Parkinson, and we can encapsulate catalase and can directly go to the brain. And also curcum. I like to use curcum as anti-inflammatory for lichen oral lichen planus and lichen planopilaris of the hair. But it has a poor stability, so if laboratory encapsulated curcum with Exosome, it will enhance also the shelf life of the curcum. Second, it's to protect their content from enzymes, okay? And then it's regulated the paracrine signaling pathway, and as I told you, it's contain RNA, mRNA, and protein. So most of physicians and aesthetic confuse between stem cell and Exosome. What is the difference? Stem cell are nucleated, it's a cell, it's nucleated cell that can replicate or differentiate and become specialized cell. However, exosomes are not a cell, it's a microvesicles produced and secreted through their membrane, cell membrane. And it can't replicate or differentiate, and we can find exosome in all fluid, like in saliva and semen and all fluid in the body. And also, exosome can be found within stem cell. So here, we can see the extracellular vesicles, which is the father of the exosome. Extracellular vesicles secreted exosome, macrovesicles, and apoptotic bodies. And we can differentiate between them according to their sizes. Here is the using of exosome as a tissue regeneration, metabolic, cardiovascular, inflammation, and also in cancer studies. Also, many studies showed that exosome can be used in aesthetic, for scar repair, and also for hair stimulation. And I'm a hair specialist, so I care about this aspect. So here is a very nice study for using of exosome from different sources, one of them from keratinocyte. And in that study, it found out that the exosome from the serum of the vitiligo contain different content of exosome of healthy control, like 47 microRNA versus 10 microRNA in control. That means that we can manipulate and we can treat vitiligo and any pigmentation disease by using exosome. And here in my clinic, I noticed that in my patient, when I injected 5 sessions of exosome, I noticed that the repigmentation of the gray hair after multiple sessions of exosome. So exosome will be a power tool to manipulate the gray hair. And here I found a study published this year, February 2024. It showed similar to my finding, that exosome can stimulate the melanocyte stem cell. The sources of exosome, it can be autologous, it can be allogenic, and it can be from plants. Especially here in India, ashwagandha is very famous, right? So one of the exosome is very powerful from ashwagandha seeds, showed in enhanced and also hair diseases. So as we know that the hair mechanism is interaction between epidermal and mesenchymal, and this harmony and orchestra is controlled by catenin signaling, which is agonist for stimulation of the hair follicle, and BMP, which is antagonist. And all the study about the exosome showed that the dermal papillae exosome and also adipose tissue exosome, it's upregulate the beta-catenin signaling and also downregulate BMP. Here are the many studies about exosome for hair diseases. We can use it as topical, injectable, different sources, adipose tissue, human bone marrow, and also autologous adipose tissue. So exosomes are on horizon as exciting therapeutic and hair diseases. This is very interesting. Also, there are many studies and articles about food drives exosome. It can be from grapes, carrot, ginger, and also milk exosome. And all showed enhancement of growing of the hair. Here, the using of rose as a topical for hair stimulation, and we can see in this picture. And here, the source of oxosome is dermal papillary source. And also here, oxoflow oxosome, which is from aseptic human bone marrow and can be injectable and very powerful. Personally, I use it one time in Kuwait, but the problem with oxoflow, the shelf life is 1 week. And the storage, it needs like a specific temperature to store the product. Here are very interesting study from Turkey University. They use foreskin as oxosome, as a human source oxosome. And in this study enrolled by 30 male with severe Hamilton hair type, androgenic alopecia, and it showed enhancement of a hair follicle by using foreskin-derived mesenchymal oxosome. And here, allogenic, from human to mouse or from mouse to human. But again, I just tell you about the advantages of oxosome, but still, we have a current challenging during using oxosome. And also especially in isolation and the store of oxosome. And what we are looking for, we are looking for cytokines, proteins, microRNA, and also about the method separation. The gold standard is ultracentrifugation, but still, for example, retroviral and oxosome are the same density and sizes, but still we don't have until now isolation method to separate between them. So most of the recent studies showed that we have to, or manufacturing have to use multiple or combination of the method of isolation. As I told you, there are still limitations. The source of oxosome, still we don't know which superior. Adipose tissue superior than mesenchymal cell or plant or animal. We don't know still. We don't have, especially in heart diseases. Also for storage, we don't have uniform storage for oxosome. For example, the standard storage for oxosome until now is -80 Celsius, but it showed that fresh extraction oxosome can stay just 4 weeks with this temperature versus milk oxosome, which can stay 4 weeks. So we don't have a uniform standard for storage. But this is a good news. There is a good articles, especially in Asia, Korean colleagues about the effective and safety of oxosome. Again, because I'm American-based from University of Miami, so I have to tell you that it's not FDA approved, and in America they considered as biologic. Okay, finish. Okay. Okay, let's do it. So here it's very nice, and we can encapsulate it, oxosome with minoxidil and also with finasteride. So we can take the full benefit and less side effect of oxosome. And here, okay, we can skip this one. Autologous oxosome, I've been using it in my clinic in Kuwait, and I can show you the picture of using autologous oxosome in my clinic. And also I combined adipose tissue with autologous at the same session, and I like it. Now I have ongoing cases on frontal fibrosing alopecia using oxosome. And I like until now, I like the results. Maybe next year I will post pictures. So future direction of oxosome, as I told you, we need preservation technology to protect biological activity of exosome, and also we need more researchers about combination exosome, autologous and allogenic exosome, and also we need to know more about the delivery system, either microneedling or ultrasound or laser or injectable. Thank you very much.
Thank you so much, Dr. Sara. I would request you to please settle down there because we have you as a panelist. So I would request you to please.
Thank you, Sara, for a wonderful talk on exosomes.
And meanwhile, I would request Dr. Ramanjit sir to please felicitate our chairperson, Dr. Manisha. Yes, Manisha. No, मेरा mic इधर से उधर हो गया. So, ladies and gentlemen, as we are felicitating Dr. Manisha Nijavan here on the stage, can we have a big round of applause? Thank you so much. Thank you so much, ma'am. And now moving ahead towards our panel discussion. So for that, I would like to invite our moderator here on the stage. For this, I would like to invite Dr. Pallavi, esteemed panelist, Dr. Sadhna, Dr. Shivani, Dr. Sara, Dr. Viral. Can we have our esteemed panelists here on the stage?
This one? Good evening, everyone. Dr. Patrick, can I please request you to have it on the stage? It's a very interesting panel discussion, please. It will be a real honor to have you. So we have quite an interesting and the most popular topic these days, skin booster versus exosomes. So let's try to keep it a little crisp and short. And all right, so we are skin booster versus exosomes. So, so the first thing that I would like to discuss our panel would be what is the basic difference if a newcomer has to, start the skin booster or exosomes? What is the main difference between both of them, that how you have to choose the molecule? Where's the mic?
Thanks.
Can you have
okay.
two mics? Yeah.
I'm not sure what you mean. Do you mean in terms of results or physiological process? Obviously, in terms of physiological process, one is just adding non-cross-linked hyaluronic acid to a higher level of skin, and it just causes hydration. But the other one is like a smart molecule, if you would want to look at it that way. It's carrying information for the cells in order for them to enact through genomes to make specific proteins, or in this case, collagen, or to stimulate fibroblasts. So one is like, as we explained earlier, a lipophilic structure that's like a bus or a lorry carrying cargo, and you can put whatever you want into it. We haven't really looked at exosomes in the proper way yet, because we can put anything into them, and so we've got to see them just as like a train, a mechanism of carrying molecules to the skin. And don't forget when I said earlier that they have the potential to cause cancer, obviously, if they're carrying that sort of information, but also to stop it, because we can put anti-tumor sort of molecules within it. It's the same thing as, I suppose, we're all afraid of cancer, you know, because we cut it out or we blast it out or we nuclear bomb it or whatever. But I mean, it has also the power to keep us alive. What is it? It's cells that reproduce, and we can't stop them reproducing. But we spend all our life in aesthetic medicine trying to get cells to grow. So if we stood back from it and put on a different head, thought outside the box, we could use the process that cancer cells are using through mitotic activity to regenerate new cells all the time. So I think exosomes, to me, are very like that.
All right.
We're on the bottom rung of the ladder, but they could bring us very different places if we allowed them to.
Dr. Shivani, what's your opinion on that?
So the question asked by you initially was if we want to choose a treatment for the client, which treatment we would go for.
Exactly.
Yes. So for someone who is looking for hydration, smoothness, then obviously the hyaluronic acid skin booster is the option.
Well
For
enough.
someone who is looking for improved skin texture, reduction in fine lines, reduction in pigmentation, and everything, then the smart molecule exosome, which works like a biological trigger, is the answer, because it's one molecule which works on different benefits.
So I think it's a very crisp and very cut short you have given that if you want hydration, go for a booster. If you're looking for those miscellaneous things like rejuvenation and other thing, then one has to go for exosomes. Right, ma'am? Do you want to add something else more?
Same. That's
Dr. Sarah? How you have to choose? I'm not giving any age criteria, any indication. Like
for the skin or
for the skin we're talking about. Skin booster or exosome, like what is the fundamental difference between? The first takeaway point, what I could easily understand was, you looking for hydration, go for booster. You looking for other things like skin texture, collagen synthesis, one has to go for exosome. Is there something else you would wish to add?
And also your patients, like most of my patients in Kuwait, they don't prefer like Exosome. When I tell them about Exosome, they tell me, no. Let's be safe. I want HA. So also we have to respect
what is your
the patient.
preferred mode of exosome? Micro-injectable form or the meso form is something? Because there's a lot of controversy.
I like to inject Exosome because there are many studies. Of course, it's not FDA approved, and it's safer to do it by microneedling or laser. But I prefer, I'm talking about hair, I prefer to inject Exosome. For the face, I like to do microneedling.
What's your opinion, ma'am, on exosomes, the way, how do you prefer to do it? Because it's actually very new
Exosomes
now.
are new, and what is approved is application and delivery of the exosomes.
Yeah.
So you can deliver exosomes by a derma pen or by microneedling or even by microneedling RF. In my clinic, I use it with microneedling RF. So with MNRF, I use exosomes, so you get both the benefits.
Great.
For the face, yes. I mean, I don't inject, as of now, I inject only PRP for the hair. For exosomes, I do it with microneedling.
All right.
For hair.
So, Nada, we have little vague question many times. Under 45, what is your mode of treatment, Dr. Shivani?
Between these two?
We're just discussing between hydration, the skin booster and exosome, the mode of treatment, what you would choose.
Below 45, I would choose exosomes.
Exosomes.
Yeah.
Why is that so?
Since it is one treatment for multiple options, multiple indications. So that's what would be my go-to treatment.
Have you ever used both of these procedures at one go on a patient?
No, I have not yet.
What is
but
your...
I have used skin boosters and afterwards biostimulator. They do work excellent together. And I have done microneedling as well, but with mesoglides, and then done skin boosters on the same patient, but not the exosomes yet.
So,
I suppose to give you a little bit of my background, I was very involved in hair transplant. We had about 24 clinics around the world, including the Middle East, many in India, and also Ireland, England, and Turkey. And we started using surgical methods like a long time ago. I won awards in 2007 for PRP and in hair long before the first paper I see was written in 2010. So we were using stem cells for quite a long time from umbilical or mesenchymal type stem cells from red deer in New Zealand, from a commercial company in Singapore back in 2012. That's the original exosomes. We ran them against ACDE, the human ones, did trials, and like our 4 treatments cost about 3,000 euros, so you need to get it right. And I found the stem cells were better. Having said that, exosomes are easy to use. You know,
Exactly.
I mean, you can, because they're sort of superficial, where stem cells are injected in, so it's almost like your nurse or your doctor has to do it. It's a whole new world that's opening up. And I mean, you know yourself,
Exactly, yes.
non-specific or non-surgical hair growth now, they're injecting in everything from nothing, because if you just inject in its own, Dermal will work. If you inject in vitamins, like a lot of the companies, or even hyaluronic acid, it works as well. So it's an interesting thing. I find a lot of the papers are very poor because they're not really comparative studies. If you're doing comparative studies, you'd really need to take the same person, one side of their head and the other side of their head, you know, because if they're doing 2 different patients, what does it mean? Some people have 1 follicle, 2, 3 follicles in the one area. And I found that particularly with PRP, an awful lot of the papers didn't impress me scientifically. That was me. I'm hard to impress though.
So while going through my study for this article, I went through an article which claimed that the longevity among skin booster and exosomes are believed to have a longer longevity. Do you agree with it, panelists? Any of you want to answer for that? Because it does generate powerful growth factor, cytokine directly into the skin as compared to the skin booster. In your experience?
The longevity of skin boosters, usually in my experience at the clinic, is around 5 months to 8 months, not
Correct.
more than that.
Yeah.
Yeah, Visoderm is a little thicker and obviously it lasts longer. But with exosomes, since we are naturally, biologically improving the skin quality,
exactly,
the results would last much longer.
Yes. Ma'am, do you want to add something on that?
Yes, exosomes are more for repair. Wherever you want to repair your any skin conditions, then you are using exosomes. So the result should last longer, though we are very new to comment on this. We have more experience about boosters in comparison with exosomes because
Exactly. Yeah.
it's new, so we are still observing.
So I think this one, since...
And actually, when you're on that subject, the paper you showed for alopecia areata, I'd be very interested to know, because it's an autoimmune disease, obviously, how long it lasts there. I presume you have to keep using them for the rest of your life. Would alopecia areata, the
For
paper...
using oxysome or?
The exosomes, yeah.
Exosomes in alopecia areata, right?
Yeah, actually for the autologous oxysome, especially in impact device, I have it in my clinic, and I encourage you to get it. And this device, that when a blood contact with glass beads during the centrifuging, it showed the study that IL-1 antagonist well developed, and the ratio between IL-1 antagonist to IL-1 is increased. As we know that androgenic alopecia and also alopecia areata is like depend on inflammatory markers. And this device, by using autologous oxysome, we can decrease the inflammatory marker. I've been using it to frontal fibrosing alopecia, which is scarring alopecia and also immune involved in the process. But still, I don't have any experience in alopecia areata.
I think we still have to explore that terrain of this thing. So this question was answered very well, I think, on the starting by Dr. Shivani only, when you should choose booster over exosome. Booster when you're looking for the hydration. It also called as a bridal fillers also long time back, you know. Back days when we guys used to use it, if there's a big event coming up, you do have enough 5 to 6 days of downtime for the prick. Boosters really work, and exosomes whenever you have miscellaneous. What about the frequency of the treatment in both the case? Booster, maybe once or twice in a year. What about the exosomes?
The exosomes which are currently available in India, not the injectables, but still ethically sourced, are with World, Dermapen World.
Yeah.
So their recommendation is once a month, 4 sessions, and then as often as required, once in 6 months, 8 months, 10 months, as per the client's choice.
Ma'am, you want to add something?
Yeah, as of now, I'm doing once a month, 4 sessions. And yeah, as I said, that it's new, we are still observing. And it's not even a year that we've started using.
It's not even a year, I think 6 months.
Exosomes. It's maybe 6-8 months that we are using. So we are too early to comment.
Actually, the purpose to keep the panel discussion specifically for this topic was we had presence of Dr. Patrick here because he's a pioneer in using these products, and we wanted the audience and the newcomers to know more, because as a consultant, even I am learning to use exosomes.
So as of now, in this short span, I think I have given on one patient 3 or 4 procedures are only done so far.
We don't even have
And
6
so
procedures with us, right?
We don't have a long-term observation as of now. But the results
What about the results? We are not
are very
expecting
promising.
anything downside,
Patients,
but what about the results? Like, we have been using meso solutions since years,
Yes.
you know, boosters since years. Why are exosomes a breakthrough? Why do you think they are getting more popular than anything? Why we are comparing,
So
you know,
the
exosomes with boosters also now?
Immediate results are good. Patients are giving the feedback that their texture has improved and they are getting the brightness.
Texture, yes, texture improvement,
Texture
something which you
improvement.
get to see immediately.
Yes.
Is there something you want to add, Dr. Sara, for the exosomes treatment for the scalp, which like you've been doing enough? Because I don't think we have more of the doctors doing for the scalp in India yet.
Yeah, I always believe in combination therapy, especially for treating androgenic alopecia. So I combined even Exosome with PRP. And also I combined the autologous Exosome with the adipose tissue.
So it's never a monotherapy?
No, I don't do monotherapy. I believe in combination, and I always give to my patients, because it's expensive, so I always give a good deal because it's a life commitment therapy, especially for the androgenic alopecia, and I have to respect that. I have to be patient with my patients.
Fair enough.
Yes.
Fair enough. So do we have the safety profile of both these things, boosters and exosomes? Do they differ or it's almost same? Dr. Patrick, can we please have your view on that?
If I could just take the tail end of the last question as well.
Please, sir.
I find the biggest use of exosomes in our clinic is actually not with the doctors or nurses, it's with the estheticians. And we normally, if we do something like ablative CO2 or erbium YAG laser, that's a means of drug transmission. We send them over to the estheticians, they put on exosomes, they put them under red light, and rather than phototherapy, we biomodulation, because within the exosomes, you've got growth factors and peptides, blah, blah, blah. The second thing is they can use them immediately after derma rolling. So I don't have so many patients coming in saying, I want exosomes. So we use them as an adjunct almost to other therapies. Is this now at safety profile? I suppose because one's injected and the other isn't really. I mean, it's only subcutaneous, almost on the skin, where skin boosters are well down. There's a bigger risk of a vascular problem with skin boosters rather than exosomes per se. And a lot of people don't realize that even if you're using PRP, you can cause a vascular occlusion with PRP. There's been 8 to 10 cases.
Absolutely.
You know? Yeah. So it's really almost the level of where you're injecting rather than... So if I was to replace polynucleotides instead of skin booster, obviously they're more dangerous than exosomes. I couldn't see exosomes really causing much of a problem in terms of something going wrong during the procedure. I mean, patients may have local reactions, redness, inflammation, blah, 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 like anything. Even though they're anti-inflammatories, you know yourself, when you do anything, you can get a reaction. But I would have thought skin boosters, probably less safe.
Thank you so much. So I think for the safety profile, exosomes, most of them have been derived from the natural sources and minimal side effect, more of a result. And booster, we all have been doing it, all form of it. And the takeaway points would be, again, I'll stick to your words, ma'am, simple. If you're looking for the hydration, go for booster. Miscellaneous thing, when you're looking for the texture, pigmentation to an extent, I think for the scalp, we still need a lot of experience to be very confident about it. Exosomes are the one we have to go ahead. Once in a month, once in 6 weeks is a sitting we are thinking or we are planning to for a patient. 3 or 4 sittings are giving apt results. Effectiveness, longevity is good as compared to the booster. Side effects are minimal downtime. Is there any question from the audience? Please, we'll be happy to address. Any question? So, do you want to add something else, ma'am? All right, thank you so much, thank you. Well, we have a gala dinner at 7 o'clock, so requesting all the faculty to be there by 7:30. We're expecting you to all have a good time over there. And we have Dr. Patrick's special lecture post this, so please be here, be seated.
Okay, I would request Dr. Patrick to please felicitate our moderator. So,
You have to facilitate me, sir. Come. You have to give me this.
Oh, I'm sorry. Because I'm giving the next lecture.
Yes, that's your lecture.
so here we are moderating, here we are presenting this moment to our moderator, Dr. Pallavi. Can we have a big round of applause for Dr. Pallavi? Thank you so much. And now I would request Dr. Patrick to please take over the podium, take over the stage, and here we present.
I'm filling in for Viral, who is going to leave to go to Korea. So I'm going to give a different lecture. I'm on tomorrow with complications, but this is an interesting one regarding dermal filler blindness and just where we are. Thank you. So, good. What I'm going to do is just look at the history of this, which is interesting. So, that's me. And that's dermal filler blindness. So the first thing is, it's a rare but a very serious complication, obviously, and it's something that we should be quite aware of. Blindness is nothing new. We've been having blindness from aesthetic results back from the 1950s. We originally got this with fat embolus, and now we're getting it with the fillers. So when hyaluronic acid fillers came on the market first, we thought this is really a breakthrough. And in 2004, because I went through some of my old lectures, I advocated the use of hyaluronidase, and nobody wanted to know about it. I advocated it to the company who originally made Restylane back in 2001, and they said, we'll not need an antidote because we don't have a problem with our products. I have some interesting emails that I wouldn't embarrass people to show it. Then in 2007, at IMCAS, I said we should start looking at the off-level or off-label use of hyaluronidase, because we're going to end up with dermal filler blindness, and believe it or not, nobody was that interested because it hadn't really happened. So then I advocated the use of the supraorbital technique, and I sort of advocated that now 17 years ago. Then we started seeing the first vascular occlusions. This is Julie Bass. She was from California, a nurse, a colleague of ours. She was the first patient that allowed her pictures to be showed on the internet, and that was a bad enough case. And that's Julie with her husband, who's a plastic surgeon in Dublin some years later, when her kids had grown up. Then I was chairman of the Royal Society of Medicine conference when we did it, and we got our first case in Britain of dermatologic blindness in 2008, that was. I know 2012 up there, but I remember the conference. Maybe, yeah, well, actually, it could have been 2012. I'm sorry. We started the conference in 2007, and that was about the 5th one, so it could have been 2012. And that's the agenda. You can see the bottom left, dermatologic blindness. That was from Sculptra in the temple area with a cannula. I started writing, I suppose, how to resolve vascular occlusion quite some time ago, and I have been, I suppose, credited with probably being the first person to use hyaluronidase in aesthetic medicine, and if not that, at least writing out the protocols for it. And these were the patients. Now, we had a situation, I suppose, where Jean Carruthers wrote the first papers on how to resolve this. Jean's husband, as you know, died a few weeks ago. He was a big loss to aesthetic medicine, and she had advocated as an ophthalmologist using the retroorbital technique underneath the eyeball, and I suppose that's the paper that they'd written, and the idea as a rescue method, I didn't really agree with it. So this is how it's done, and it's done mainly because that's the same, I suppose, process that's used for doing cataracts in terms of having an anesthesia to remove the lens. So the retrobulbar method at the time, I suppose, located underneath the eye. That's how it's done. So I wrote, not so much a paper at the time, but certainly an article where I said I have reservations about the retroorbital method. I expressed my opinion that we should be using the supraorbital. My main reason is the risks are high. Vision rescue is highly unlikely, as the central retinal artery, once inside the nerve, is covered by 3 layers of meninges and is located posteriorly in the retroorbital space. So what I was saying was, you can use it, but I doubt it will do anything. So that's the way things were. 2015, I wrote a paper on how easy it is to use the supraorbital method. And really what I turned around and said, we're all doctors. If you have a GP and a person gets a heart attack, you don't send them to a cardiologist. You deal with it yourself. And by the time they get to the hospital, they can give them thrombolytics, whatever. So it's the same thing with an eye. If you have got a patient that's going blind, if you were to send them by ambulance to an ophthalmic surgeon, they'd probably be well blind by the time you see them. So what we needed was a simple method, and you know yourself, the supraorbital foramen is easily palpable in anybody, and it connects also to the area of the central retinal artery. Because people tend to forget they're on 2 different sources. The central retinal artery is a branch of the ophthalmic artery which is coming from the internal carotid artery. The supraorbital artery is also part of the internal carotid artery, not the external. So that's where we were. And I had sort of advocated then in Paris also, you know, that we need a simple method that sort of people can use if they have blindness in their own surgery. At the time, I wrote letters sort of, I suppose, advocating my opinion that the supraorbital artery is obviously much simpler, that it should be done, and that was from that. So then we had a situation, I suppose, Las Vegas Conference 2011, I sort of had pushed our American colleagues to use much higher levels of hyaluronidase. And certainly myself, Stephen Diane, Claudia Lorenzo, Corey Mass, Neil Sadik, agreed that America needs to increase its levels of hyaluronidase probably to about 1,500 for vascular occlusions rather than the 150. Then we started to see cases that were solved. That was by Greg Goodman, Mike Clegg in Australia. And in Melbourne, they had used the supraorbital method, but they hadn't really. They just had injected the frontalis, and the patient restored the sight. I believe Greg Goodman now has had a second case that sort of has been resolved. So then, Abu Dhabi 2016, I had the same sort of thing. And then I started looking, 2019, around the time of COVID, and the Chinese particularly were putting out papers, why are we doing this? There's no evidence that it works. So, I mean, they went through all the cases, retrobulbar technique, had no cases. And we had been doing it for at least 7 or 8 years at that stage. Now, there was one paper by, this is by our Chinese colleagues, suggesting that it's not effective, that maybe we should be doing something else. Now, interesting, none of the Chinese papers were advocating my method of the supraorbital, but they were just saying, where are we going? And I'll get to that later. Paper after paper, I have a lot of faith in a lot of the Chinese papers that seem to be less corruptible than the American presentations. An awful lot of papers, particularly regarding dermal fillers, by our American colleagues are just paid to say things, and they don't, in my mind, much respect scientifically, whereas China seems to have a more objective viewpoint that we all used to have once. Now, there is this paper, but it wasn't a paper, it was just a letter by Chestnut, who had said that he'd reversed a case by the retrobulbar method. But to be fair, he had also used the supraorbital method just before that, and within 2 minutes, because he didn't get restoration of sight, he used the retrobulbar. So he used both ways. Who's to say that the supraorbital didn't work and that it sort of would work 2 minutes later? So that's where we were. Then I started getting cases of blindness in. I'm under contract legally not to mention these cases. They were all settled. It's just that I was involved with the treatment of a lot of cases. And I had considered the use of stem cells, particularly from our colleagues in Miami, because there was a case there of a guy who used stem cells. But when we looked at the patient, she wasn't blind from dermal fillers. She had multiple sclerosis. And as a consequence, you get relapse and remission of multiple sclerosis. So it's quite possible she would have got better anyway. So I didn't really do that. At the time, Alex Skupin was doing stem cells in Miami. And Alex and I sort of had met up. And we decided to do one of the cases in Dominican Republic. And unfortunately, the Carolina Institute that you seen the patient earlier had 3 deaths from Paolo Mancini. That was a big scandal from using stem cells. We had invited Paolo to the Royal Society of Medicine many years before that. So then the Carolina Institute had pulled out of doing the repair. Where were we then? I had raised the possibility of maybe we should be looking at supraorbital. All these doctors, oculoplastics, tended to agree with me. And interesting, one of the doctors was from Argentina, Fernando Silkovic, and he had a case of dermal filler blindness. And he, this is the patient here, female, 54 years old. He'd used a cannula, and he was doing just 0.1. The patient started to go blind. And believe it or not, Fernando used the technique in my book that we gifted to Viral. And he injected the patient with 3,000 units in the supraorbital foramen. That was the patient's angiogram. She was grade 4. And day 2, obviously, the patient had pain, neuropathic pain. Patient began to count fingers, day 5, day 6, day 7, day 8. She could see letters on day 8. Day 13, day 14, almost 100% vision restoration. So we've had about 6 cases now restored from the supraorbital artery, and that is Peter Veldhuis and the thing. But the Chinese took a totally different approach, or I should say Asia did, from the point of view that one of our colleagues in Vietnam, who is Dr. Ha Hong, he had decided to instead cannulate the internal carotid artery all the way back up to the central retinal artery. And he had a lot of cases coming in Vietnam, particularly from beauticians. And these were the patients, and these were the angiograms, and he restored 10 patients' sight. So when you hear people saying that, you know, there's no dermafiller, blindness case has been reversed, we are reversing them. Now, the interesting thing is, with, I suppose, the benefit of having Dr. Neugen's work, one of the things that happens is that when you get a central retinal artery embolism, the eyeball shrinks and gets smaller. So that actually, even though they may get full restoration of the retinal area, they lose visual acuity in a lot of the cases and may need a sort of an implant or a thing. So this is myself and Dr. Hong after hours in a Galaball in IMCAS working out, I suppose, the pathways in terms of how to treat these. So it goes to show you that education doesn't just happen listening on the stage, it can happen during a gala ball or networking outside. So he ran 6 patients, all 6 had the treatment through the internal carotid, and 3 improved, 3 didn't, and 2 of them also had hemiparesis from some of the embolus reaching, obviously, the middle cerebral artery. The improvement from that to now is actually quite good, because there's been this as an adopted method of visual rescue, and the results are actually much better than I'm showing here, which is from 2 or 3 years ago. And using up to 3,000 units of hyaluronidase. So I suppose, where are we now? I suppose the first thing is that even though a lot of people are still pushing the retrobulbar technique, there is no evidence that it does anything. Secondly, anatomically, if you look at it, because the retinal artery is behind meninges in the posterior aspect, it's highly doubtful if you're injecting in just some hyaluronidase underneath your eyeball that it's going to do anything. I don't think it's based on anatomical sort of science. The third thing is the supraorbital technique has been shown to work in patients already, in China, I believe, and in Russia also. And the fourth thing is that the internal carotid being cannulated and used with hyaluronidase definitely works. So maybe we shouldn't be sending these patients to ophthalmic surgeons. We should be sending them to interventional radiologists to do it. And certainly, the first bit of it we can do ourselves. Anybody can palpate the supraorbital foramen. If you don't know where it is, it's always 100% of the medial border of the iris, just directly above it. So, in conclusion, hyaluronic acid fillers induced ophthalmic embolism is obviously a severe complication, as is blindness. If correctly diagnosed, there's no contraindications from using that interarterial sort of method. If you're using hyaluronidase, definitely use it in the region of about 1,500 to 3,000. There's minimal risk, and that's, I picked your result together in an ophthalmic complications panel some years ago. So that's my lecture. Thank you.
Thank you so much, sir. And now, ladies and gentlemen, I would like to remind you all that by 7 o'clock, we are going to have the gala night. So everyone, please come back by 7 o'clock. With this is your host, MC Kashish, signing off for now. Have a great time. And then the tea is being served right adjacent to this banquet hall. So you may proceed for that. Thank you so much.